cases which can lead to the permanent harm and death of the patient. It reduces the patient's safety and lead to poor quality, hampering the patient experience. So we have our goal was to reduce the errors by the 50% by December 24. So for this we have adopted the did the prospective audit for the period of 9 months in Fortis Hospital Kalyan. Data collection was done from April to July by auditing 627 files, and implementation and intervention period was August to December with the audit of 794 files. We included all inpatients excluding outpatient, all with all age and gender groups. So this is the evidence of problem. So as you can see in the graph, prescription errors pie chart, total files audited 627. Out of that, 17 were wrong reconciliation we mostly found in a prescription error. Then we had 8 wrong drug frequency. Then we have the dose not prescribed one. Drug duplication we had 2 wrong instruction prescribed, 1 was wrong duration prescribed, and administration errors. Mostly root cause we identified here was wrong method of unawareness about the wrong method of administrations here. Then missed dose, double dose, wrong dose frequency, and wrong quality. By using the PDSA cycle, I tried to give a cause for each errors. So identified cause were inadequate drug dosing knowledge, wrong method of administration, lack of awareness, and traditional method of learning. So we have provided dosing guide to the across the nursing counter. When in doubts, to refer to staff can refer it, but dosing guide was not appropriately used. It was missplit, so abandon the change. Then wrong method of administration, drug specific training according to error along with the education material was provided. No new administration drug related to the specific errors. No error identified for the same drug, but unawareness about the other drugs. Administration error are reduced, adapted, but again we had some IV administration guideline errors, so we have identified that we should provide the IV administration guideline for commonly used drugs. Then lack of awareness, in that we provided a training to the staff, in that less attendance was one of the issue. Errors reduced but not as desired by the training. So we need to cover the all stakeholders, and reiteration should be required. Then traditional method we use, that we train the staff, we give hard copy of the materials. So we changed the study material, and we adapted a scan to learn method. So in that, as you can see, by providing the digital access to the study material without using a paper material, also reducing the reliance on the clinical pharmacies by providing the professional training, and by scanning the code you can easily access the study material. Also improving the consultant satisfaction by minimizing the need of repetitive clarification, and also it is a less time consuming, it is easily accessible, and it is a easily adaptable method. So and also the identifying the cause factors of the errors, we have created a materials and given the scan code for that. So in the post intervention phase, in prescription error and administration error, as you can see in a graph, it is reduced. So in study, I will say that it is mostly learning tools will be so effective in reducing prescription administration. That is the one learning we can take from this. And also by providing a correct learning tool, we can achieve our goal of patient safety. Thank you. If any questions.
So,
Can you just summarize your study once again, maybe in just 2 to 3
Yeah.
sentences? What was your objective
Yeah.
or goal, and what did you achieve? Just in 2 to 3 lines,
Our
please.
goal was to reduce the
Mic a little
yeah.
closer.
Our goal was to reduce the errors, mainly prominently prescription and administration errors by 50% by December 24. We started our prospective audit in hospital from data collection was done from April to July. Then implementation and intervention phase was August to December. In the data collection, we found that administration and prescription errors we are getting more by finding the cause of the prescription administration. Lack of knowledge, unawareness about the some drugs, lack of in administration. If we see lack of awareness about the method of administration of drugs, so we found the cause of the that cause of the errors, that was the less knowledge in prescription also and in administration also. We provided training, we provided a hard copy of the medication to study materials, but it did not help. So we, by using the technology, we created scan to learn method, and in each ward we have placed it. So in any, if any person in doubt, he can access a dosing guide, prescription highlights, any method of administration if you want of any drug, in a mobile, it's a click away. In if they can use it and study it, and if in also the reliance on the reliability on the clinical pharmacist is less in cases if not available at a present. Also repetitive doubts of the consultants, then consultant satisfaction also increase. That's it.
Dr. Jagriti,
Yeah.
good presentation.
Thank you, ma'am.
Just a few queries. First of all, the topic prescription and administration error, I think it is something we all struggle with to achieve a zero,
Yes, yes,
right, across the world.
yes,
So I'll start with your, can you go to your first slide on sample
yes,
size?
yes, yes.
Methodology slide. Right. No, the one before. The one before.
Ye-
No, no,
no, no,
the
no.
first slide, please.
Yeah.
Right. So, how did you come up the total files audited 627? Is it the prescription or is it a single prescription or are you talking about a drug chart as a whole?
No, I am not. I have not counted here the number of drugs.
Huh.
These are the patient files. 627. This is patient files.
So you're talking about, so what is your sample size? How did you come up with that number of 627?
We have a C category hospital, ma'am. So
Okay.
according to NABS guidelines, we should do about the 125 or 160 files. So in monthly, I will do 125, 150 files audit.
What is your total number of inpatients?
250, 300.
250 to
Yes, yes,
300 in
yes,
a month.
yes, yes.
And your IP days?
IPD, ma'am. It's a small C category. IP
Inpatient
days.
days.
Okay, so I should, yeah.
So
I
I
think
150 is your OP. You're talking about.
no, no,
Obviously,
no.
you didn't do anything
IP
on the OP.
No,
IPGs.
no,
This is
no,
all
no.
IP.
Yes, yes.
So she's asking for the patients admitted in a day. Are you talking about, or you did that over a month?
No, no. This monthly inpatient admissions are 324, around 250 admissions. Out of that, I have did. These are the from April to July 620 files, 627 files I have audited. But total, if you are asking me inpatient days, I have to see that.
Okay. So I think the sample size calculation methodology is something you need to look at,
Okay, ma'am.
right? Because if your sample size is not proper, your
Right,
inference and
right,
your result that you're coming up may
right.
not be the actual.
Okay, ma'am.
Okay. So coming to the next slide, your PDCA cycle. Sorry.
Yeah.
Yeah. So what is your root cause that you have come up with?
Uh,
And what tool did you use to come up with the root cause?
Root cause identified by the medication by the ESMR guidelines for medication error form. In that, we'll write the root
Did you
cause.
use any tool to
No,
come up
ma'am.
with the you?
No, ma'am. No,
No.
no.
Okay. And then you did went ahead and you implemented a PDSA cycle.
Yes, ma'am.
So at the beginning of your study, what was the measure and what was your goal?
Yeah. So measure was to reduce the errors.
Correct. From what to what?
Okay. So it was I have written in. So yeah. So these are the ma'am total errors. But total count of the prescription error, if you see 17 are the wrong reconciliations. In percentage, I have not written it here,
Not
ma'am.
required, or even
But
in numbers, if you can tell me from what was your starting point and what was your goal?
yeah, almost, ma'am, according to goal was to reduce it by the 50% in December. But these are the, I will show you the last slide. Yeah. So from 17, you can see we come up to the 11 in the wrong reconciliation. Then we had 8 wrong drug frequency. Then we had only one in post implementation phase. And also the drug duplication we had 6, then 3 in. So errors are reduced in post intervention phase.
Okay.
Same as in administration, ma'am. 8 we had wrong medicine was given. Then we had post 4. So that.
Okay. Thank you. No
Thank
more
you, ma'am.
questions
Thank
from
you.
my
Thank you, Dr. Jagruti, for the wonderful presentation. I would like to call our next presenter, Miss Anindita Biswas. Is she here? No. So let us move to the next presenter, Mr. Himanshu Sharma. He'll be presenting on enhancing MRD audit accuracy across 80 plus centers pan India at a leading eye care organization. So he is from Center of Sight. Over to you.
Thank you, ma'am. Good morning, everyone. Myself, Himanshu Sharma. Uh, so, I'm going to present on enhancing MRD audit accuracy. So, special thanks to our quality team, Ms. Bhavya Isar and Mansi Jain, and our medical superintendent, IT team, and MRD department. So, this is my agenda: introduction, problem statement, objective, methodology, then result, conclusion. So introduction is basically we are facing the we identify to need we identified to improve the MRD audit accuracy. So we did the two-step study here, two-step process improvement here. Uh, then this is our problem statement. First, how we get the there is a problem because we have a 80 plus centers, we get the ANSYs, too many ANSYs in the MRD audit. So we check the we do the RC and kappa. Sorry. So first we find that the first we are doing on the manual audit. We are facing that there is a difficulty in maintaining the data and staff are not oriented to the MRD tool. They are doing the MRD audit like taking the like they are filling the checklist only. So then what we do when the quality team go on the on-site did the on-site assessment, so we check that they don't know how to fill the MRD checklist. So and there is also a training issue. So So we did the RCA kappa by using 5Y method. So there's a first we find that because audit checklists were not being completed accurately, staff were not following the standard audit process, then they lack the awareness about the process, and we there is a lacking of training program, then because we haven't reviewed the MRD audit training. So first what we did, we implemented the online forms for the MRD audit. Then first we check the current MRD audit checklist. Then we transform the checklist into the digital form. Then incorporating the NABS standard into the form. Like there is a deficiencies that not cover the NABS standards. Like there's a discharge summary or not, or others like SNDT. So we fulfill the checklist. Then what we find that there is a reduction in by 80% in the MRD audit timing. First we take first the staff takes 25 minutes for the single file. Then after implementing the online form, we the file audit done in the 5 minutes. After implementing the MRD audit, online form, we face that there is an inaccurate filling of the data. Like again, what the staff doing, they are just clicking the link and then again starting filling. They are writing the MRD audit, MRD numbers, and go to the home and then open the link, then start filling the checklist without looking at the file. So we did we implemented MRD audit champions and trained them for each. Then we did the pilot study in Delhi and Delhi NCR region. Then we again monitor and evaluate the data. So what we find that we have a 166% MRD audit compliance rate. It is all about the MRD audit, like 30% like how we fill the data, how we do the data. It's not about the MRD audit content. So this is the outcome. This is a two-step improvement process in which the compliance rate increased significantly by 166%, and the average time taken for MRD audit decreased by 80%. Thank you. This is a glimpse of our MRD audit, and thank you.
Thank you, Himanshu, right? Okay. Um, Himanshu, so I get your presentation. So, in terms of the impact, what do you think has been the impact of your presentation and your study? If you could just tell that once again.
Ma'am,
To give answer from behalf of Himanshu. Basically, this study's impact on patient safety as terms of the documentation, because all we are know documentation is most important part and integral part for us, because there is so much medical legal cases and all. So create a accurate document and complete document is the most important thing for patient safety and quality improvement also. So we focused on that so that our documents can be complete on time, like SNDT at time, and consent forms should be filled on time. So basically the findings are the same.
Hi, Manchu. Hi. So, first of all, good topic and a very difficult topic to achieve, basically. Uh, when you say MRD audit, you are talking about the live audit, or was it you talking about the deficiency
ma'am,
audit?
both, ma'am.
Both. Okay. Can we go to your first slide? not introduction, the problem statement. So you're talking about both live as well as. So what is your problem statement?
Ma'am, we got the inaccurate data entry in the MRD form
Right.
before implementing the online form checklist, and after implementing the online form, we again get the inaccurate data entry.
So your problem statement is inefficient manual audit process.
Yes,
That
ma'am.
is what is there. Inaccurate data entry, and your compliance rate was 30%, and high administrative burden is. I don't think
Ma'am.
that comes as a problem statement as such.
Yes,
That
ma'am.
is more of your analysis, right?
Yes, ma'am.
What is the next one? What is your measurable objective?
Uh,
What was the objective?
Ma'am, the objective is to ma'am ensuring the compliances, streamline processes, and ma'am streamline the process basically.
So how your problem statement and your objective should correlate, right?
Yep.
So when you are saying your problem statement is, what was your first problem statement was
I mean accurate data
inaccurate.
get.
So how is that coming in your objective? Under which of these three categories will that come as your objective?
I'm ensuring compliance.
So that is your compliance rate of 30%.
Yes, ma'am.
So that you want to increase. The first one, your first problem statement. Inefficient manual audit.
process.
So what is your objective to solve that particular problem?
Ma'am, streamlining the process.
Streamlining the audit process.
Yes, ma'am.
Okay. And your next one was inaccurate data entry. So what is your objective for that?
Ma'am, that's the first one, ensuring compliance.
And your 30% compliance?
Ma'am, that's come under the ensuring compliance.
So what is promoting quality culture come into your objective?
Ma'am, it's all about we have to do the proper MRD audit, and we don't neglect the MRD audit. Like this is not a not.
So objective should always be measurable, and your objective should talk to your problem
Problems.
statement. Okay. Then the next slide. So what is your result? Sorry, go back to your root cause analysis, 5Y. This root cause analysis is for which problem statement?
Ma'am, this is for before implementing the online app.
You have 3 problem statements.
Yes, ma'am.
Your fourth is really not a problem statement, so I
yep.
will take 3 problem statements.
Got it, ma'am.
For your first problem statement, so this root cause analysis is for which of those 3 problem statements?
Ma'am, this is regarding the ensuring streamline processes.
Streamlining processes.
Yes, ma'am.
Okay. And so what is your root cause for that?
Ma'am, for this we didn't get the MRD audit checklist properly. Like we didn't get the sample size, and there is a issue also ki we have to maintain the hard copies of the MRD audit. That was also difficult, and also there is a issue in analysis.
Okay. But your root cause is coming. We haven't reviewed the MRD audit
Yes,
training.
training.
And for compliance, lack of
Ma'am,
compliance.
for compliance, ma'am, that was after we look after the implementation of the online audit.
Compliance of 30% in your file. So that is a compliance of not audit, right?
Ma'am,
is
it's about
compliance.
the audit, not about the content of the MRD audit. Like 30% is about the staff filling accurate MRD. Like there is a deficiency, so staff not ma'am basically like अगर कोई कंटेंट में इशू है तो स्टाफ को वहाँ पर मतलब नॉट अवेलेबल या फिर उसको टिक नहीं करना था चेकलिस्ट पर, बट ये उसका ऑडिट है, ये अबाउट नॉट अबाउट एमआरडी कंटेंट, दिस इज नॉट अबाउट द एमआरडी कंटेंट कि इतना हमारा
So this is regarding your audit
ऑडिट.
compliance.
यस.
Okay. So only 30% of your files were getting audited
यस मैम.
from the MRD
करेक्टली
team.
करेक्टली.
Okay. Fine. Then your final result?
मैम दिस इज माय फाइनल रिजल्ट दैट हमारा जो कंक्लूजन था, मतलब बेसिकली वी इंक्रीज अवर कंप्लायंस रेट फ्रॉम 30 to 80% and also decreases the time, which also highlights our problem statement.
Was time a problem?
I'm sorry.
Was time your problem statement?
Ma'am, that was also a issue in the time. Like,
It's not your problem statement that is
yes.
defined, right? So the correlation should be there. Your problem statement, your objective should say what is your goal that you want to achieve.
Got
So
it.
based on that objective, what is your result? How much of that you have achieved? So the correlation between 1, 2 and 3 is what is required in any study or a paper. So just keep that in mind next time.
Thank you, ma'am.
So Himanshu, if I could just, can I think, like my colleague said, very interesting topic, very well thought of. The intent has been very well appreciated. I think what has probably gotten a little confused in your study is that maybe you've looked into too many parameters. Maybe out of the three that you, firstly the four problems that Ms. Reshma highlighted, maybe you could have just worked on one and then
Okay.
sort of fanned it out accordingly and उसी पे ही काम कर लेते, मतलब so that आपका एक number figure
Narrow down.
understanding of what you want. So then otherwise it's intermixing everything and nothing seems to have come out more conclusively. But very good attempt, and definitely I think you can work on this and then come back again and present somewhere better. It's a very well intended that. So thank you for that. Thank you.
ma'am.
Thank you, Mr. Himanshu Sharma. It was really a wonderful topic. I would like to request our next presenter, Ms. Preeti Trikha from Artemis Hospital, to come forward for the presentation. Ma'am will be presenting on a quality improvement project on sample rejection rate due to pre-analytical error by nursing staff. Over to you, ma'am.
Good morning. Good morning, everyone. So my project is a quality improvement project on sample rejection rate due to pre-analytical errors by nursing staff. As we all know, the clinical laboratories reports play a significant paramount importance in making the clinical decisions and for the patient care excellence. And as we all know that many people consider that blood test is a very simple procedure, but in actually, studies have shown that about 70% of the clinical laboratory samples are rejected due to pre-analytical errors. And pre-analytical errors causing not only discomfort to the patient, but also it is causing a negative influence on the healthcare team. Therefore, it is very important to assess what are the, how we can reduce these rejection rates and what are the reasons why these rejections are happening. So we took our nursing staff from, because we, in our project, we took only the nursing staff, what are the pre-analyticals done by these people. So errors in the pre-analytical phase are very important because they lead to inaccurate results also and increased length of stay of the patients. So definition, according to NCBI and LM, the pre-analytical errors are defined as the errors occurring from the physician order to the analytic phase, including the test request, patient identification, collection, transportation, and preparation for analysis. The aim of our study was to decrease the lab errors from 70 to 10% of admitting patients and increase the patient satisfaction. The various objectives were to identify the reasons why these pre-analytical errors are occurring, to decrease the pre-analytical errors or errors of the patient, and to reduce that order of draw. Like many of the time, the samples were rejected because of the reduced, we have to take again and again samples, and to adhere to the IPSG-1 compliance. In the plan phase, the errors are potential for causing quality improvement, proper phlebotomy education, use of appropriate device for sample collections were the main issue. So adhering to the standard guidelines, developing clear and written procedures was very beneficial in preventing these errors. It was observed that total number of pre-analytical error during Jan 23 to June 23 were 239. Therefore, we started this quality improvement project. This was initiated. The study period was from Jan 23 to December 23, and the study phase was prospective analytic study. Pre-phase was Jan 23 to June. Intervention phase was July to August 23. Post-phase was September 23 to December 23. And we included all pre-analytical errors occurring in the ward areas we have covered, and excluded all the critical care areas like ER, ICUs, OT, BMT, PICU, etc. because these are the area where many of the time the samples were collected from the PIC lines or central lines. So we included only the ward areas in our study. The various factors contributing for pre-analytical errors were first was the newly joined nurses, novice nurses. As we all know that because of the high attrition rate in the hospitals, we keep receiving new staffs, and the staffs were not properly trained how to take the sample, what are the procedures have to be followed strictly. Lack of training were there, staffs were in hurry to take the samples. Sometimes workload is also there because nursing staffs, they have 10 other roles also to do. So workload was also a challenge. Method, wrong technique was used. Many of the time, staffs were pushing the needle directly into the vacutainers. Because of that, the rupture of RBCs, and these were the reasons. Wrong labeling, many of the time, staff put the wrong barcode on the vacutainers. Then delayed transport was another issue. Many of the time, sample was collected and it was delayed. Lately, it was sent to the lab for investigations. And material sample collection with syringe and needle. Most of the time, our staffs were using syringe and needle. Many of the times, they were taking out the vacutainer top also, and then they were putting the sample inside it. So then environment, noisy workplace, insufficient light, and the busy workplace was there. And these all factors, this lead to pre-analytical errors. Now coming to pre-phase, we got to know that the maximum number of our errors were because of diluted with IV fluid. Many of the time, staffs were collecting the samples from the site which was already on IV, like IV fluid was going, and they were taking out the samples. Many of the time, they were using a large bore needle. So these were also the reasons. Quantity not sufficient, which is required in the vacutainer for the study. The samples were not sufficient and were rejected. Wrong patient leveling because of wrong barcode were placed in the vacutainers. Samples were hemolyzed because of the forcefully injection of the samples into the vacutainers, and clotted samples were 57, and because of the proper mixing was not there. And sometimes there was a vigorous shaking of the vacutainers because of the wrong techniques. The RBCs rupture and the samples were rejected. Wrong tubes also, because new staffs were not knowing which sample in which vacutainer to be put for which samples. So these were our challenges. Now coming to the intervention and the strategies what we have implemented in our Artemis hospital. First was effective use of Eclipse needle. Eclipse needle not only prevent these kind of errors, but also it reduces the needle stick injuries. Second is vigorous training on Eclipse needle, because this was a very new for the novice nurses. They don't know how to use this Eclipse needle. So we conducted various certification training programs, workshops, and simulation-based trainings. Then creating awareness and monitoring of the patient identification. We strictly follow IPSG-1 compliance so that they should not do the wrong identification of the patients. Then strict vigilance by nursing team leaders, supervisors, educators were involved in strict vigilance while drawing out the samples. In service classes by phlebotomists, we also include the lab people. The lab team people like phlebotomists and senior doctors were also taking the classes so that we can streamline the process. Then demonstration sessions on hands-on training were done to make them aware about the use of eclipse needle, and the poster of order of draw was also available in all the areas. You can just have a look on these. Like first is the educator taking the classes, and then the phlebotomist is taking the training in the lab. Certification programs were implemented, simulation-based trainings were used, and this is the order of draw sample was placed in all the areas so that our noise nurses can be sensitized. These are the supporting documents like in-service classes and the audits. Then we also made a, this is a pre and post comparison study which shows that there was a drastically improvement in our study, like the sample diluted with fluid reduced to 25, quantity not sufficient reduced to 26, hemolyzed reduced to 19, and clotted from 57 to 16, and wrong tube was again a challenge. Then pre-phase errors from 239, the error reduced to 89, and in check phase we came to know that the number of lab errors reduced from 239, that is 70% to 27%, and the hospital still plans to continue the implementation of all the interventions because we keep receiving new staffs and attrition is also there. So this project is online, like it's an ongoing project, and then in the act phase we have now, it is a stringent mechanism we have placed in our hospital that now sample collection is a part of nursing induction, where a phlebotomist is taking the trainings, educators are doing simulation-based trainings. Then we conducted many sessions on IPSG-1 all to reduce this, and various certification programs like quarterly we are conducting external company sessions also, and audit done by various nursing supervisor every monthly. Thank you.
Thank you, Miss Preeti, right? Wonderful presentation. Only suggestion would be that keep it a little more brief and precise, because this is a paper presentation and we need to kind of, have basically a concise form of it. Otherwise, whoever is kind of listening to you will probably lose track of it. So only two questions very quickly.
Right.
One, you've kind of partially answered already. What was the duration of your study, number one? And just the conclusion in two quick sentences. That's all what I want from you.
So ma'am,
I don't want the slide. I
okay.
need you to just.
So ma'am, we initiated this project in the January 23 to, sorry. So we initiated this project in Jan ma'am. So Jan to June was our initial phase that time, and July to August was we have implemented all our strategies, and later on from the September, October, December we start doing the audit of it. So after training we start doing audit, but it is a part like after implementing also this study is like continued. We keep on doing all the interventions during the intervention, after the intervention phase also, because of the high attrition.
And the conclusion?
Conclusion is that we come to a reduction of the sample errors. We have pre-analytical errors, but definitely we cannot say that we have 100% zero we have achieved. There is reduction from 70% to 27, but our target is to achieve at least 10%. That was in our aim. So close to it. Right now also like around 10 to 15% we keep receiving the errors, but we will definitely focus on the areas. We take the samples like from which area the maximum numbers of errors are happening, so that we can conduct unit-based trainings in that particular area, so that that staffs, all those who are doing, that can be individualized. We can give them unit trainings in the lab. We can teach them in our demonstration room and simulation labs.
Thank you.
Thank you, Ms. Preeti. Not many questions. What is your sustainability plan, and your how do you plan to scale this project?
Ma'am, as we have, like in the beginning of my presentation, I said we have the attrition rate of 5 to 7%. So the staffs, those who have trained, they are doing perfectly. But the new staffs, the bulk of new staffs, every month they are coming. So we have it's a part of our ongoing study. Now we are taking this sample collection as a part of our induction program. So this is definitely helpful, and every month phlebotomists and our educators, they are conducting then one classes on sample collection, so that the new staff, those who are coming, they will be also inculcated with the current process in the hospital. And this order of draw that we have posted in all the areas, that is also very beneficial, because new staff don't know which sample to be collected first and how to do, like what is the sequence of drop sample. So these all interventions have helped us a lot, and we are keep doing it. It's an ongoing process, ma'am.
Sure. Thank you.
Thank you, ma'am.
Very well presented. I think we can give her a round of applause. Thank you.
Thank you, ma'am.
Thank you, ma'am, for the wonderful presentation. I would like to request our next presenter, Ms. Tanu Verma from Center of Sight, to come forward and present on the topic, the impact of digitalization of feedback mechanisms and real-time feedbacks on patient satisfaction and quality improvement. Over to you, ma'am.
Please stick to the time. We have to vacate the
Sure.
for the next session as
Just
well.
brief and crisp. Sure. So namaste everyone and good morning. So I would like to present on the topic of the impact of digitalization of feedback mechanism and real-time feedback on patient satisfaction and quality improvement. So I would like to acknowledge my team members, quality team, Director Medical Administration, Dr. Ritika Sachdev, Senior Vice President Operation Anuruddh Singh and Ajay Kumar, Senior Vice President Mr. Ashish Jha and Balehar Singh, Mr. Rahul Mishra and entire IT team and manager call center. So I will brief agenda, background, problem statement, RCA methodology, corrective action taken, result, conclusion in the slides. So the background is as the other centers use for manual feedback systems, we also relied to the same. So but we have followed challenges we face with the manual feedback system, like data inaccuracy, time consuming process, it was low response rate, biasness may be there, limited actionability and inability to handle large volume of sample size, because we have a multiple location centers in and around India. So problem statement was transition to online patient feedback. Actually we have shifted to the online portal, and during the phase we faced the issues of low response rate. So we did RCA from Ishikawa tool. So we have find out it was time consuming process, and there was lack of bilingual forms because our form is in Hindi and English only, and as per the other region like Hyderabad, Gujarat, so we did not had forms in that languages. So there was a process for OTP requirement and SMS authentication. As you all know, there is a so much in the market, like wrong OTPs and frauds, like so patients are also not interested to give feedback accordingly. So we move to the next slide. So we did PDCA cycle for continuous improvement, and we did corrective actions, like we re-standardized our patient feedback questionnaire department wise, scoring of each question of 0 to 10 for each and every question instead of one major question. Smiley face emojis for symbolic presentation and better understanding for patients. Shifted to WhatsApp message from text message for better reach. Automatically linked with registered phone numbers for OP as well as IP from OTP based feedback system. So we removed the OTP based system so that patient can rely on the feedback link. Multi-regional lingual form, 10 card and display of feedback signages to increase awareness and patience. Review and modification of dashboard, regular training to the staff, regular monitoring of the process. So these are some glimpses of changes. Online feedback form with the each and every question have the emojis, automatic message for feedback, which is also linked with the registered phone number, OP, and as well as IP. And these are some awareness signages and 10 card which we had displayed to our all centers. And this is the dashboard which we can monitor from the head office also. And these was the results of our study. Pre-implementation, post-implementation, sample size was 4375 in July 2023. And after the implementation, it increased 10635. And also, our NPS percentage has also increased by 59 to 66%. This data has included 19 centers data. So the conclusion is digitalization feedback mechanism across multiple locations enhance patient care, decision making and innovation through real-time data collections. And regular software monitoring ensures effectiveness, identification issues and drive continuous improvement for better patient experience and smoother operations. And the takeaway points are improved patient engagement, enhanced data accuracy, real-time insights it is a more important, and increase patient satisfaction and regular monitoring. So thank you, and I would also want to add, as per our present data, we reached to approx 1.5 lakh patients as previously. Thank you so much.
Thank you, Ms. Tanu.
Thank you, ma'am.
Can I just see your first slide, just the objective?
Background.
No, the first one, the one before this. Okay. The agenda, I'm sorry. Yeah. So if when you did summarize your conclusion,
Yes.
which of this agenda were you actually working at?
Basically, basically, this was our problem statement of low response rate. So we tackle this issue in this study.
So you were basically working at the service excellence part of the feedback of the customer,
Yes.
right?
Yes. Right.
Thank you.
Thank you, ma'am.
Very well presented, by the way, and you kept it brief, so thank you for that.
Well, thank you so much, Ms. Tanu. I would like to call upon our next presenter, Ms. Yamini Patil from Hirandani Fortis Network Hospitals, Vashi. She'll be presenting on precision care of peripheral intravenous catheter. Over to you.
Good morning, everyone, and I'm very thankful to IPSC platform and my organization and my entire team. I'm representing my entire team here for the presentation on precision care related to intravenous catheters. This is the agenda. I'll come to each slide. So, need of the study. Each patient gets admitted will have a peripheral intravenous catheter, will require IV medications, and it's the topic where we had concerns. Our concerns were related to the repeated cannulations to the patients and concerns with single prick success. Patient would require multiple pricks for a for the IV cannulation. So our objectives we kept that to increase the duration of the catheter and without any complications and increase the single prick success. Our methodology was specific to the root cause analysis, then brainstorming, what pointers we get in our root cause analysis. As a team, we would brainstorm to come out with the strategies. The strategies will be included in focus trainings and we will monitor the practices and the outcomes. So pre-implementation phase, so in May, June, July, 3 months, we did the extensive understanding of the existing situation And if you see, our 56% of the patients required IV cannula change even within 24 hours. And our single prick success was only 41%. So 59% patient would require 2 or 3 times pricks to get a single cannula. Plus, as we consider our average length of stay of patients, if it is 3 to 4 days, means almost every day patient would require a cannulation, which was a major concern for us to focus. So we did every recannulation, every patient's IV cannula when it is changed. We had an extensive Excel tool where bedside nurses would put the reasons. The patient is required on multiple antibiotics, what was the age, which site cannulation is done. So detailed data we received of the site, size, indications, and what was the reason of recannulation, which were the complication, VIP score 1, 2, what was it, we got that. Based on that, we did a brainstorming which included all the nursing in charges, nurse educators, as well as the senior nurses who are there with the patients, who are mainly handling the IV cannulations, and we came out with the special IV protocol. And these were the glimpses that IV cannulation will be done by the, sorry, I lost the, IV cannulation would be done by the senior nurses. Plus, we decided that the site selection, we will keep it non-dominant hand. Specified that we develop the cannulation, special IV protocol, which the glimpses are there, specific. And then we came to the post-implementation phase where we monitored it aggressively. And if you can see the duration of the cannula for 24 hours reduced to 22%, and we could also have the cannulation functional even more than 4 days. Then the single prick success also increased to 85% in the month of October. And along with that, we also monitored what are the IV related complications are there, because we should not have long duration of cannula with the complication. So that also had reduced. We also monitored the prevalence audit, because this duration and data we were receiving from various departments themselves. So here a team did a prevalence audit for over the months of our activities, and that compliance also increased from 56 to 85%. We stick to the sample size of 50 patients on one day. As a surprise, we would monitor all the departments to get the confirmation of what data we are collecting, because our other data was very extensive where we had involved the same team. So here a checker mechanism we had kept for a prevalence audit, and that also matched with the correlated with the data what we were receiving from the department. So I would conclude that the in detail analysis which we were doing and which our junior nurses were involved, that had given us the special IV protocol, and we could have a significant impact. And we are on the journey of precision care. We still have a challenge because new nurses keep joining. We there is a occupancy wise also there are challenges, and to develop new nurses to put a IV cannulation, because it was very easy in the beginning to say that senior nurses will do cannulation, but then unless doing, how junior nurses will learn. So we are in the journey of involving them with the simulation training and involving them with the IV skills training, and further we will still continue achieving precision care. So sustainability include more training on simulation based cannulation and hand holding with them, and further monitoring, and not stopping or not be happy with the findings. We need to still keep getting it every month. Thank you so much.
Thank you, Ms. Yamini. A good presentation. I actually don't have any questions, but it's interesting what you've come up with. So very well presented. Thank you.
Thank you.
Very good presentation, Yamini, and a very relevant topic. Just one question. In your audit, you said you audited 50 as a number, cutoff number.
Yeah.
How did you come up with that number?
Ma'am, our average occupancy is 65 to 70 patients in these 3 months.
Okay.
And in the prevalence audit, when we do, there are patients with central venous catheters also. Plus, we have some wards which are 40 bedded, one ward is 10 bedded, and the occupancy varies. So, to have a uniformity every month of a sample size, we decided we'll take 50 patients because a prevalence audit to do in one day was also difficult, and we wanted to keep it as it's a surprise audit because we wanted to get a real-time information.
That is okay.
The news
Surprise
does get
element is
spreaded.
fine, but the
So,
number 50,
yeah,
probably you
yeah.
need to have a scientific
Our
methodology to come up with that kind of a number.
okay. We
That is one question.
because in
And
prevalence audit we try to take 100% of the because it's one spot audit on the day, but to have a uniformity we had taken 50 because our patient size is 60 to 65 patients, and central line patients number will also vary. So every month we might get different and easy for conducting every month. We decided 50.
sure. Thank you.
Thank you so much.
Well, thank you, Ms. Yamini, for the insightful presentation. I would like to request our next presenter, Chokalingam, from New Hospitals, to come forward for the presentation. Sir will be presenting on enhancing OPD services efficiency through QR code-based turnaround time measurement, a research model. Over to you, sir.
So good morning to all. It's my honor to present my paper in the prestigious event. And I'm Chokalingam, representing NU Hospitals Private Limited from Bangalore, and I'm heading the biomedical department. So my topic is on enhancing the outpatient department efficiency through QR code based turnaround system. So basically when it comes to the OPD, obviously patient satisfaction is the main index where the measurements will be happen. So there are more factors for the patient safety index. The main point is like the waiting time of the patients in through the OPD services. Either it's a consultation or the diagnostics or the other points also. So here the TAT measurement is very, very important, where that will gives the patient satisfaction problems. So the issue is what we are facing it, usually either the manual readings will be taken or the check-in and check-out systems in the HIS process will be happen. Even though we say it is a digitalization process, but the check-in and check-out will be done by the GRE of a consultants actually. So this check-in check-out will be can be, there is an options to do a misinterpretation to have a the TAD within the specific TADs. So there comes the objectives, during this TAT measurements, there are certain limitations where the manual interventions might happen at the end of the day or end of the month to, avoid the root cause analysis and corrective action, preventive actions. And also the thing is that like a real-time tracking will not be there. For example, when we define the consultation waiting time of 30 minutes, when the patient's waiting time goes beyond the 30 minutes, so when I do the manual interventions, I can put it as a 29 minutes also, which should not be happen, and the collection of data should be more precise to the process. So this is the findings. There is a methodology. For example, for this particular project, what I have decided is to place a scan area at the entrance of the OPD area and diagnostics area, blood collection centers everywhere, so that the another scan area will be in the front of consultant room, a diagnostics room like ultrasound, CT, MRI, those rooms. So whenever the patients get the billing details, so they'll be giving a unique QR code. So what they will do, once they enter into the OPD area, they'll scan the QR code that will take a timestamp of entry into the OPD area. So again, when the same patient, when they are getting entry into the consultant room, the same QR code has to be scanned there. That will take a timestamp of second time, stating that it's the end of waiting time. So this difference between the timestamp 2 and timestamp 1 will be measuring the minutes that it is representing. So by this method, like we will be having the perfect data, which is real-time data, where the no human interventions will be happen. So this is my conclusion. Like it's a real-time data where no human interventions will be happen there, and the data will be very accuracy, so that no like deviations will be happening, and the efficiency, of course. So when we taken the results at the end of the day or end of the month for the discussions, so obviously we will be coming to know where the delay is happening, why the delay is happening, and all the root cause analysis and corrective action, preventive action will be very prompt to that. By this we can make the benchmarking, stating that, like, when we focused on minimizing the waiting time tat in throughout the OPD services, obviously it leads to the patient safety index to be improved. So this is a graphs which we are simulated actually as of now, and still project is on pipeline only. So we are just going through the process. Thank you.
Thank you. I think I only have one comment, rather, a suggestion that maybe if you had the scalability in terms of the understanding, should have been a little more clear in terms
Right.
from the beginning to the end. Otherwise, very well presented.
Sure,
Thank you. And a very important topic.
Thank you. Thank you.
Thank you. What was your objective?
Uh, to minimize the human interventions in the TAT measurement system,
Okay.
and should not be like mishandled it. So whatever the actual data that is getting recorded, it has to be recorded that way,
Right.
and should not be like no changes in the recordings.
Okay. Thank you.
Thank you.
Thank you, sir, for your presentation. I would like to invite our last but not the least speaker, that is Ms. Bhavya Isar from Center for Sight. She'll be presenting on a study on the adoption and implementation of software solution to enhance the effectiveness of asset management across all Center for Sight locations in India. Over to you, ma'am.
Namaste everyone, good morning. As I'll be presenting our paper today, and I'd like to begin acknowledging, excuse me, I'd like to begin acknowledging our quality team, and then of course especially to our senior manager in biomedical department, Mr. Shashank Shukla, and our deputy manager, Mr. Prashant Singh. So this will be the following agenda for my presentation. So basically, as we all know, hospitals have various assets, and then as technology advances, asset management is very important for operational efficiency. And so my problem statement is that over 80 plus locations and several thousand assets all over Pan-India and Center for Sight, we have, as regards to our equipment, critical asset details such as model and serial numbers are often inaccurate or missing. Lack of clear process for inventory handover. Previous system did not allow for effective tracking of breakdown inventory, verification, and asset tagging. And manual entry of data can be prone to human errors and is time consuming. Manual entries for gate passes further exacerbates delay in equipment movement and maintenance. And then as for our management, the absence of centralized system to track maintenance and repairs makes it difficult to effectively manage and monitor the status of assets through multiple locations in India. Difficulty in strategic decision making in procurement and condemnation of assets. So basically, with adapting a software, and our main aim was to streamline processes. For example, breakdown calls, barcoding, scannings that allowed us to track our equipment, ensure that the PM calibration cycle was ensured, implemented, and was stabilized. And then optimized decision making, and then lastly, utilization of equipment. So our basic methodology was that we finalized the asset management software that we wanted to implement. The following departments were giving training as to how the software would be used. Second, equipment data collection occurred throughout all Pan-India. And then lastly, QR coding tagging, which was done from November to December. This is a simple glimpse. This is a mobile application. They have a web portal. The QR coding, and this is a QR coding where basically you would scan the QR code, and all the information regarding the equipment would be on your phone. You'll have from installation date to service history, how much the maintenance, insurance, everything will come up on the app. The challenges encountered during the software, the manual entry of data into Excel sheets was time consuming. Duplication of assets named led to confusion while doing the data entry. Serial numbers in the software did not align with those on the QR codes. And then multi-location implementation posed challenges in coordinating staff and ensuring the efficient completion of tasks. So our result after our second phase of implementation, we saved over 100 man days within the biomedical department, enhanced accuracy and complete documentation, real-time asset transfer tracking improved, inventory handover and verification improved, and then insurance tracking of equipment. So the duration required to prepare for NABH assessment decreased by 33%. Initially, it would take 3 days, and then post the implementation of the software, it would take 1 day. As for the efficiency, the asset identification used to take 9 hours, which is basically 1 day, where, and then it would now, post-implementation, it took 2 hours, and then tagging of assets in new center was 0% to 100%, and then lastly, inventory verification of one site was from 3 days to half day. And then basically what I'm trying to say here is that the reporting of data improved. We were able to capture data, so that is why there is a number in the reporting of breakdown, because we were able to capture this data now due to the software. So my conclusion is that better informed decision making, cost savings and time savings for the management, and then lastly, the full impact of the asset management software is expected to be fully realized after 1 year.
Thank you, Bhavya, right? Bhavya, I wanted to understand just the exclusion criteria, and were there any, in fact, both of us wanted to know, were there any measurable elements in this?
Basically, we didn't have any exclusion criteria. We were basically trying to streamline a process that wasn't streamlined. There were many inaccuracies in our data, in managing the equipment, because we do transfer equipment from one center to the other center within India. So tracking that movement was difficult, but due to the software, these such processes have been streamlined.
So if I read it well, I think what you tried to present is basically a process where you were digitizing your process with the help of an AI tool, correct?
Yes, ma'am.
Right.
Yes.
Thank you.
Hi, Bhavya. Just can you, in 2 lines, can you tell me what was your problem statement and what was your root cause analysis? What was the step that you put in place and what was your result?
Okay, so basically our problem was with several thousand assets all over India. Sorry?
Have a definite number, a measure is there?
So 10,000? 10,000 equipments all over Pan-India within Center for Site. So basically we were trying to improve the tracking, maintenance, and just ensure that this proper operational services were provided to these equipment. So it was basically going from manual entry and manual keeping of data to like software digitization of the entries. Thank you.
Just an observation. I think you said 100 man days.
Yes.
It'll be nice if you could write it as 100% days. It is a man oblique woman, right?
Yes, yes, sorry. Yes, of course, ma'am. Thank you. Please come forward for the certificate. Mr. Himanshu Sharma.
Ms. Preeti Trikha. Ms. Yamini Patil. Mr. Chokalingam. Ms. Bhavya Isar. So, thank you, Reshma ma'am and Anjali ma'am. Tanu Verma. Thank you, Reshma ma'am and Anjali ma'am. I would like to now hand over the mic to our MC of the day.
Hi, good morning, everyone. Please be seated. We'll be starting shortly a very interesting session on fire safety by Mr. Atul Garg very soon. Thank you so much. Good morning, esteemed delegates, and welcome to the day 2 of the conference. I hope you're all ready and re-energized for yet another day packed with insights and inspiring conversations. Yesterday, we set the stage with some incredible discussions, and today we take it even a step further. As we move on to our topic, organizations must not only focus on mitigating risks, but also enhance their capacity to adapt and thrive in the face of crisis. Crisis readiness is a crucial element of risk resilience, enabling businesses to respond efficiently and swiftly when seen any unforeseen circumstances. To explore more, let's delve into our topic, Crisis Ready from Risk to Resilience. For the same, please welcome our distinguished session chair, Dr. Gaurav Katyal, Chief Operating Officer, Indraprasth Apollo Hospitals, New Delhi. Dr. Katyal, a dynamic healthcare leader specializing in hospital operations, patient experience, and digital transformation. As COO, he has optimized processes, enabled service excellence, and driven digital initiatives. He has expertise in revenue maximization, workforce optimization, and strategic leadership. A very warm welcome to you, Dr. Katyal. For our first speaker, I'm really honored to have, and please welcome Mr. Atul Garg, Director, Delhi Services. Mr. Atul Garg leads 61 fire stations, a team of over 3,600 personnel, handling around 22,000 emergency calls annually. Recognized with Eminent Engineering Personality Award by the Institution of Engineers, he has played a key role in shaping fire safety policies for various establishments. A very warm welcome to you, sir. For speaker 2, please join me in welcoming Mr. Tulsinathan S., Head of Engineering at Apollo Hospitals, Navi Mumbai. With a strong background in healthcare engineering, he plays a pivotal role in ensuring seamless facility management, technological advancements, and sustainable practices within hospital operations. Please join me in welcoming our third speaker, Ms. Kamakshi, AVP Operations at Apollo Hospitals. With 29 years of experience at Apollo Hospitals, since 1995, she began training and development before transitioning into quality systems in 1997. She played a key role in ISO, JCI, NABH, and NABL accreditations at Apollo Greaves Road. We extend a warm welcome to you, ma'am. Please extend a warm welcome to our fourth speaker, Ms. Dipali Loria, a seasoned healthcare professional with over 14 years of experience in project management, biomedical engineering, and quality compliance. She has successfully managed complex medical equipment projects and overseen the launch of super specialty hospitals and diagnostic chains, both in India and international. We extend a warm welcome to you, Dr. Dipali. Sorry. Thank you. Over to you.
Namaste and good morning, everyone. Welcome to the session Crisis Ready, from Risk to Resilience. In today's rapidly evolving healthcare landscape, hospitals navigate an intricate web of challenges, from ransomware attacks and devastating fire incidents to alarming instances of violence against healthcare personnel, and the risks are both diverse and unpredictable. The COVID-19 pandemic further exposed critical gaps in hospital preparedness, pushing even the most advanced healthcare systems to their limits. These challenges have underscored a crucial reality. Healthcare remains one of the least agile industries. In this environment, resilience is just not an advantage, it's imperative. As the healthcare industry benefits from rapid technological advancements, it is equally crucial to remain vigilant about fire safety, technological vulnerabilities like cybersecurity threats, and disaster resilience. This panel brings together experts to explore the latest trends and innovations in hospital security and crisis management. While technology serves as the lifeline during the crisis, in an unprepared system, it can just as easily become a liability. We have four distinguished speakers on our panel today. We have already heard about them. So I'll just request our speakers to kindly adhere to 5 minutes of presentation, maybe 7 minutes, so that we will have enough time to engage with the audience post that. First, we have with us Mr. Atul Garg, Director, Delhi Fire Service, to take us through the fire safety blueprint, ensuring safe hospitals. Mr. Atul Garg is known for his leadership in enhancing fire safety and emerging responses in the capital. Over to you, sir. Thank you.
Good morning to all. I am Atul Garg, Director, Delhi Fire Service. My issue is little bit different today because there are so many fires in last 5 years. See, if the data is there, that almost more than 100 data occurred in the hospital fire. And it is a reality. Hospital fire is reality now. How to prevent them, what to do. There are so many long lists of the rules, regulations that provide, you can say that provide a long list of doing these things, that thing, so many other things like compartmentation, systems, refuse area. But in large hospital it is possible, but in small hospital it is very, very tough. So what to do, how to go forward? So I have got something based on my experience and analogy. How to train the staff, how to train the doctor, how to train the administrators. See, I will take an example from your profession only. When a patient comes to you, what you do? You check it, you take the breath, you all vital signs you see. Then this is understanding the risk. After that, you give him some prevention, like agar aapka gala kharab hai, don't take, cold water, like ice cream, something like that. That is a prevention. Then you give some medicine, it is a production. And then after that, you advise him come after 3 days or 4 days. And if he is not improving, then you admit him and then you go on firefighting mode. Same thing is in the fire safety measure. First, understanding the risk, then prevention, then production, and then firefighting. Same. Because you are doctor are also saving the life, we are also in the same business, saving the life. So understanding the risk, hospital have a peculiar risk as far as the fire is concerned, like continuous running of medical equipment, overloading of wiring, then sorry, kitchen fire, smoking, unauthorized smoking area, laundries. These are the basically risk area in the hospitals. Overcrowding also one of the risk area, and then the patient, they cannot move it. Now 70% fire is occurring due to the electric short circuit. If you go for the data available with us, almost 70% fire are occurring due to the electricity. So what we have to do now, prevent it. We should have ELCB, MCB, testing of wiring, no overloading, and equipment should not run 24 hours. We should have some system whether equipment should have to give some rest. If you keep running equipment for 24 hours, it's going to, there will be a fire. Then we have to provide all these things. This is basically a prevention part, so that fire should not occur. Now, if fire has occurred, how to stop it, how to contain it, there is no loss of property, there is no loss of, death or patient. Then we keep installing that fire safety or firefighting equipment like sprinkler system, hydrant system, compartmentation, smoke ventilation. This is the protection system. First one the prevention system, second one the protection system. Like you will provide all fire safety equipment. There is a long list. I have a presentation. I will show that long list of firefighting equipment which will be installed. That is a protection system in case fire has occurred. Then what? How you are going to control that fire? How you are going to save the property and the lives? And after that, if fire has occurred and then it is going out of control, then what to do? Then there should be a system to train the people, train the guard, train the electrician, train the all staff, all the doctor, because awareness is the key to successful firefighting or successful saving the life. And after that, we should give a role. What role a person should do in case of fire? Because I can quote here that a baby care fire in the Vivek Vihar, they did not call the fire brigade for 40 minutes. After that, when the fire, out of control, they ran away and then we reached there. So 40 minutes delay is a devastating. All the 19 babies died there was because of this. We reached there. I was monitoring the situation and we could not locate on which floor that the babies are there. They are small babies. So that is also an issue, how to call the fire brigade, what to do till the fire brigade is not coming, and how to help the fire brigade. Once the fire is out of control, if the equipment is installed, they are not able to control the fire at that time. So these are the 4-5 issues which if you take care of, then I believe that there will be no fire. If there is a fire, we can contain the fire very easily. And if at all there is a fire and we are not able to contain it, we will there to help you out. So these are the 4 steps which I wanted to tell everybody, because fire is, once the fire is occurred, it's bringing a bad name to the hospital, legal issue, financial loss, bad name to the country. That's in case of Delhi fire, where the first time so many children died in the hospital fire. Then I got a call from all over the world. See, and all all guns are to me. What were you doing? Why you are not taken action earlier? Now that are saying, you are saying now we'll take action. So all guns were with me. All over the world we are getting a call. How a person can, how a hospital can run without the fire, and you see there was no fire safety system, only one staircase was there. So these are the issues that's coming after fire, and it is a very, very, getting a bad name also, and then that's owner, you also aware it, that owner is still in jail and all the center has been closed down because of this fire. So my advice to the all health professional, all administrators, that you must understand the risks, provide preventive measure, production measure, and train your staff. If both 4 things will be followed, I believe there will be no fire. And if there is a fire, their loss will be minimum and will contain the fire very, very easily. I have a very, very small presentation, so I will go through it. It's give elaborate what fire system should be installed by hospital, how it look like, because so many people, especially the small nursing home people, are saying we do not know what is the compartment, what other things. So I have a small presentation. We'll go through it. These are the just hospitals. This is a fire that fire has occurred. Now, occupant characteristics. That's why I'm saying it's the critical ill, extreme pain, physical immobility. These are the hazard. Basically, in case of fire, patient has to be evacuated by the 2-3 people. In case of normal fire, my one man can go and he can rescue a person. But in case of hospital, I need minimum 2 to 3 people to take out a patient, because all other life-saving equipment is with them, and people may not die because of fire, he may die because of disruption of life-saving equipment. Priority, what is the priority? That's we are early flawless detection system. This is a protection measure. Like we should have a detection system, early detection system, raising the voice, evacuation rescue, containing the fire, firefighting. These all are the fire protection system. Team design philosophy is like this. When we are building a hospital, at that time, if you know an architect, professional, then only you can design a system. Otherwise, what will happen once you have already constructed the hospital? Now my man will go and say, 2 staircases should be provided, this and that. Then it's not possible. So you have to consult us at the time of designing, at the time of drawing stage. This is a provision of National Building Code already available in guideline also, on online also. So these are the major provision on what you should have. Requirement for fire safety. This is about what is the rule and regulation in fire safety arrangement in Delhi, and all over India is the same almost, because NBC is followed by all over India. These are the fire safety, typical fire safety arrangement as per the law. What is the requirement of the law? Exact requirement. Mainly all nursing homes or hospital are, that's not meeting the requirement. This is the requirement, main requirement, exact requirement. We required 2 staircases of 2 meter. And most of the small nursing home, hospital are not meeting this. This is the major, what you call it, challenge between us and them. They have a staircase of 1 meter, 1.2 meter, because they are started a nursing home in a residential building, then they keep on adding the floor, and this is the issue. So this is a major challenge for us. We are not able to get the, giving the NOC to the small nursing homes. Requirement of staircase, same thing, that the 2 meter staircase, 2 meter staircase is required, and the riser is 1.5 meter. So these are the major challenges because of this is the exact requirement. Just showing it what type of exit we should have it. Requirement of lift also, there is if a hospital height is more than 24 meters, then we require a fire lift also, fire tower also. So that the safe evacuation is done. This is a major issue and major challenge and major requirement also, compartmentation, because in case of hospital, it is not possible to evacuate all the patients. So we have to shift in a safer place. So compartmentation is required. If you have a large hall, we should have a compartmentation in between, so that in case of fire of a one portion, you can shift to the other portion. So the life can resume, because it is not possible to take out all the patient out from the hospital. Smoke venting system is requirement. These are the typical fire protection requirement, fire extinguisher, first nozzle. These are the fire protection system which I was discussing earlier. Other requirements, communication system, all for, it is for a normally a big hospital, not a small hospital. This is my act and rule, provision the act for the hospitals. These are the typical provision, what you should have, what you should not have, how much width of corridor, how much height of the building, these are all requirements. This is my clause, how I can inspect it, what is the power given to the department for inspection. These are the violation, may lead to cancellation file. This is a typical legal requirement. If you are not meeting the requirement, what action can be taken against you. Major shortcomings, these are the major shortcomings issued. You can go through it, access to the building found block, and in some cases, if a building is a high-rise building, so everybody is using the lift. So staircase is neglected. So sometimes we have observed the staircase as a dumping yard. Although in case of emergency, you should not use lift and you should use only staircase. So the staircase was found locked, offset, poor housekeeping, fire check door damage found, empty fire escape. These are the typical when we go for inspection. These are the shortcomings we found. Just block access for fire tender, you cannot go because of parking, other things. Block access staircases. These are the. I am not naming the hospital, but it is from the hospital only. These are the corridor. If you block the corridor, then that's the issue. Like fire check door is there, but they have blocked the lock and chain, maybe for security reason, but in case of emergency, this will create havoc. See, these all are all slides from the hospital only. I am not naming them from the different hospitals. And some are very good hospital also. These are the system of fire alarm system. That's not working. Hidden without landing wall. These are the pumping arrangement non-functional. Pressure is showing 0 and it should be a 7 kg bar. These are the exit signs broken. These are the typical problem in the hospital. They have installed the system, but they are not maintaining it, basically. Poor housekeeping. It is from one of the government hospital, not private hospital. Thank you so much.
Thank you, sir. Thank you for your valuable insights. So we are keeping the questions for the last of the session so that we take all the questions one by one after the session is completed from the panelists. Now we will move on to Mr. Tulsi Nathan, who is Head of Engineering at Apollo, Mumbai, and he'll be talking about resilient healthcare systems based on lessons from recent disasters.
Yeah, good morning all. So this topic is about the resilient healthcare system. So what is meant by resilient healthcare system? The healthcare system which is able to anticipate, prepare for, respond to, and recover from any kind of wide ranges of issues or complications. So that kind of hospital will be called as the resilient healthcare system. First of all, in the hospital there should not be any kind of disaster. If at all any disaster, that hospital should have this all the mitigation plans just to overcome from that. So those kind of hospital will be called as the resilient healthcare system. We'll just see two examples for the disaster which has happened actually, and for that what are the mitigation plans we should take. This has happened in 2015 just in Miyat Hospital at Chennai, and they have installed the DG system at the basement. They have installed the DG system at the basement. In 2015, during the monsoon time, there was heavy rain and flooding. So this water has entered into the basement, DG room, as well as inside the DG. So because of that, they were not able to run the DG. So this entire backup system, just for the power, was switched off. And because of this heavy rain, the state electricity board, they have just already switched off the power. So because of that, there is no any power at all in the hospital. So the entire hospital is totally blanked out. And this all the biomedical equipment were switched off. The critical biomedical equipment, including the ventilators, also was switched off. So because of that, almost 18 patients who are in the critical care area, they have died. So in this, the major issue is that installing the DG at the basement. This hospital just next to the Adyar river actually. And keeping the river adjacent to that and installing the DG at the basement. Do you think that is a correct one? it is absolutely the disaster. They didn't do any kind of, the proper risk assessment, and they are not planned properly at the initial stage itself. So this what has been, led to this kind of major disaster. And what are the mitigation plans for this? Install a proper dewatering system within the hospital. In case of any kind of water entry within the hospital, that has to be thrown out of the hospital immediately. And we should not wait for the water level to go up and then I'll switch on the pump. It should not be in that way. As soon as the water enter into the hospital, we have to start this activity. And also we should keep additional dewatering pumps. We don't know how much amount of water is going to come in the future. So in case of any requirement, by just installing this additional dewatering pump, we should be able to throw out the water immediately. And construct a proper retaining wall with a proper thickness and with the proper this entire waterproofing, so that there will not be any kind of water seepage or leakage through the retaining wall. Elevate the diesel generator at the higher level. We should always ensure that the diesel generator should be there in the ground level, and that too at the elevated level. So in case of any kind of water stagnation or any kind of flooding, this water will not be entering into the DG, and there is no any issue with the DG. And same thing goes for the main power panel also. And the main power panel also we should not install in the basement kind of, this low level. We should install the main power panel in the same ground floor level, and that too with the elevated level. Even though if the DG is running and your main power panel there, just within the water, still you will not be able to run the DG and to supply the main power panel to the this all the power to the hospital. So installing the main power panel at the ground level, at the elevated area also, it is very much important. Provide a separate power connection for the rental DG. In case for some instant, your main DG is not working, and due to some internal issue, if it is not working, what you will do? To the worst case, without power, even for 30 minutes, just running the hospital is too difficult. You all know that. So we can have a rental DG system also for that. We can have the same agreement with the rental DG vendor, and we can do the mock calls, mock drills. We can understand within how much time they're able to supply the DG and to give the connection to get the power. So for that, we need to have a ready-made panel connection at the ground floor level, so that as soon as we bring the DG, we can connect it, we can switch it on, and to get the power immediately within the hospital. So that is also we can do. But most of the people, they are not taking it up. They are just thinking that in case of any issue, I have a DG system. But sometimes there are issues happening. The DG is not getting on when there is a requirement. Ensure that this all the critical care areas, it is not there in the basement. Basement we should use only for this all the car park kind of areas only. This all the critical care areas should be there always in the higher levels. So that is also we should ensure. The other disaster, it has happened in Dr. Zakir Hussain Hospital in 2021 and at Nasik. So in this, there are this LMO leakage at the joint area. At the same time, they were not having any kind of backup arrangement from the manifold gas system. So because of this LMO leakage, they totally closed the oxygen supply, and due to the non-availability of this backup system from the manifold gas supply, so the entire oxygen supply to the hospital has been switched off. And because of that, almost 24 patients who are in the oxygen support at the ICU area, they have died. Okay, so here if you see the major issue, improper connection and improper maintenance of the LMO. At the same time, there are so many proper backup system for the manifold. So this is the main reason that it has led to this particular disaster. And what are the mitigation plans for this? We have to install the LMO with the proper quantity, and this all the regular maintenance has to be done as per the schedule, like valves, the relief valves, all the joints, everything has to be checked on a regular basis as per the schedule. In case of any problem, that has to be attended immediately. We should not wait for the chance to come. This has to be attended immediately. And manifold gas system can be used as an alternate oxygen supply. In case of any issue in the LMO, the manifold system has to be there on the ready-made condition. It should be there in the working condition so that it can be changed over from LMO to the manifold gas supply. Automatic changeover system. It is to convert from main supply, the LMO, to the secondary supply. the manifold system, it has to happen through the automatic way. It should not happen through the manual way. In case of any disaster, we should not waste the time. So through the automatic way, it is happening. If it happens, so we can save the time during the disaster time. Oxygen generator, so oxygen generator can be installed within the hospital, and we can produce the oxygen in-house. This oxygen generator can be used as a primary supply or the secondary supply. The primary supply in the sense, the one which is always supplying the oxygen. The secondary one, in case of any issue in the primary, we can use the secondary. So that is called primary and secondary. What are the basic action to be taken to ensure that our hospital is a resilient healthcare system? Risk assessment. We should do the risk assessment for all the services, including for the power supply, water supply, and air conditioning, for the firefighting, fire alarm, safety, security, for the biomedical, and laser safety, lift safety. For everything, we should do the risk assessment. And in case of any issue, we should have a mitigation plan. And for the mitigation plan, there should be the action immediately. Okay? And the risk assessment has to be, reviewed after 6 months minimum, so that in case of any issue or any new issue, that can be added, and then the new action can be taken. Structural stability. The structural stability has to be done as per the local law, or this local guidelines through the authorized structural engineer. We should not do just like that. Through the authorized structural engineer only, we should do this particular structural stability. And for the retaining wall, column, beams, for everything, we should do the structural stability. In case of any issue, the action to be taken immediately. Through this way, we can increase the life of the building, and we can ensure that our hospital is having the full stability. The proper design for the earthquake preventive measure. During the initial design and construction stage itself, the earthquake preventive measures are need to be considered. And this is again same for the column, beam, and retaining wall. Everything has to be designed as per the earthquake preventive measures code lines. Alternate power supply. The state electricity board supply can be used as a primary supply, and DG or the rental DG and UPS, everything can be used as a alternate power supply. Alternate water supply. The local municipal corporation water supply can be used as a main water supply, and the bore wells or the water tankers can be used as an alternate water supply. And for this bore well, or this mainly for the water tankers, we should do the mock calls or the mock drills to understand how much time the vendor is taking to supply the water, and what is the quantity, quality, and everything has to be checked. Proper drainage and dewatering. As I told already, in case of any water entry from outside, we should have a proper dewatering system to throw out the water immediately. Alternate oxygen supply. The LMO can be used as a main oxygen supply. The manifold as well as the oxygen generator can be used as an alternative oxygen supply. Evacuation procedure. After doing everything, if like nothing is working out, so we need to have a plan that how to shift the patient from one area to other area, who will be shifting, and during the time what are the biomedical equipments will be used, and what is the route. For everything we should give the training, and the same mock drills also need to be done. Thank you. So with this, what you could understand, that to keep our hospital as a resilient healthcare thing, keeping always this all the standby thing, it should be there in the working condition at always. Say for example, DG and this manifold system, this all the firefighting, all the pumps, this fire alarm, this all all this kind of safety equipments and accessories. We should ensure that it is always there in the working condition. Say for example, in case of any power failure, that time if the DG is not working, again what will be of our hospital condition? Within 30 minutes, the things are gone. So for that, ensuring that the DG is always tested on a regular basis. Same thing goes for this manifold gas system. We may be using only the LMO as a primary supply at always, and we will not be worried about the manifold system. But suddenly one day if the LMO there is a leakage, and the particular day if the manifold is not working, again what will be the situation? Within 30 minutes, hospital closed. So without power and oxygen supply, we cannot run the hospital more than 30 minutes. So and that it is like a very critical situation. Same thing goes for the firefighting and fire alarm. In case case of fire,
we will restrict it for the discussion.
just as I'm just completing. Yeah. In case of fire, if my pumps are not working, my diesel pump or sprinkler pump or iron pump, if it is not working, again, as sir told, the same issue. It leads to the major disaster. So the common thing is that we should always ensure that our standby system and this all the safety accessories, it should be always tested and ensure that it is always there in the working condition. And through that, we can ensure that our hospital is the resilient healthcare system. Thank you.
Thank you, Mr. Tulsinathan, for an eye-opening discussion. Now we'll move on to Ms. Kamakshi, and she'll be talking about the future of hospital security trends and innovations.
Namaste all. It's a great privilege for me to have been called here for this presentation. I'm here to talk about some of the trends and innovation in the security, though I cannot cover the entire gamut. Some of the practices which are adaptable in our current hospital practices. Security comprises of both deployment of men as well as deployment of the digital technology. And as a 360-degree role of a security, we can say it's a hospital is a people intense area, and we have sick patients to be handled. And the access needs are different in the hospital because the different departments functions in different timings, and there are people coming round the clock. Even at 12 midnight, we can see somebody walking in for a care. And we have people with high emotions, both from the patient perspective and from the staff perspective, because sometimes it would be a sorrow, it could be something happiness, sometimes it could be an end-of-life situation where the security has to handle the balanced approach in handling the situation. They are responsible for handling the high-value assets, and they are part of the emergency preparedness. Whatever be the codes, they are responsible for the overall preparedness and handling it efficiently. This is apart from the traffic and the parking management, which again a bigger role for a security who are outside the premises. Some of the emerging threats in the hospital, I would probably call the top 4 threats in the hospital, which includes unauthorized access. So we have people who are really not privileged to enter the hospital, entering into the center. And we have, of late, we are seeing in the newspapers and the media about the violence and aggression growing in the hospital, wherein security plays a major role in handling the situation. Data breaches, if it doesn't have proper firewall systems, even with an adequate and appropriate systems, we do find sometimes system facing a shutdown. And there are fire hazards. Hospital being an area with an high-end equipment, and we also have hazardous materials throughout the building. Both from the pharmacy point of view and from the stores point of view, we have the hazardous materials stored in the entire hospital. Again, that becomes a big threat for fire, which needs to be handled. Some of the key measures which I suggest for enhancing the hospital security is a proper access control. People who have the privileges alone have to be entered, so we need to have an appropriate control system. Visitor management, again we have visitors around the clock, be it patient family or the staff, or it could be vendors or a company person or a software person getting into the theater. So we have round the clock visitor management being a biggest challenge for the security. Surveillance and monitoring, and this again we do have a lot of cameras. In spite of it, there are events happening in the hospital, and these continuous monitoring really helps to track the situation, particularly when we have an incident, when we need to look back of what really happened in that particular corridor or a particular ward. These monitoring systems really come in handy. Of course, physical barriers, when we have some untoward situation or when the patient outcome is not to the expectations of the patient family, these physical barriers in terms of gate or appropriate code system really helps in the hospital security. And not leaving the cyber security measures, because of late we do see a lot of scams happening, and we need to have an adequate cyber security measure placed in the hospital. I would recommend some of the technological advancement in the hospital security systems includes cloud-based access controls. See, today we have a situation wherein from the theater, the doctor, the surgeon sends the images through a 3D system, where there are cloud-based solution where they convert these images into a 3D picture, which really help a surgeon in the theater to perform the surgery with more accuracy. So we do have such systems. We need to have appropriate controls in these areas. And there are mobile access solutions, for example, in an say ICU system where visitors can be controlled through mobile link systems. Artificial intelligence system, which again plays a major role in getting the data analyzed and thereby giving a proactive solution. and integration with IoT devices, machine learning, predictive analysis, where a proactive approach can be done with the data analysis, blockchain technology, and zero threat security model. These are all some of the security technological advancement. In zero trust security, it's basically ensuring that it's a zero trust for both the users and the people there, so that unless there is a privilege for somebody, the security does not allow the system to accept. So that's a zero trust security model. And talking about some of the innovations, one is this digital visitor pass. Thankfully, within the Apollo system, we have it in place. We have this virtual visitor badge, wherein when a patient is admitted in an ICU, the family gets the link, and through the link, there is a code generation, and this code generation becomes the acceptance for the security standing outside the critical care unit to allow the visitors into the ICU. Then this is a contactless check, which really helps from the infection control point of view also. And access control system in different part of the hospital, again based on, it can be key cards or the biometric systems. It again prevents the unauthorized individuals entering the restricted zone. Talking about the panic button, again today we all face a situation in the hospital industry, and the patient sadness or their upsetness really comes into play, and there is a sort of a threat system amongst the caregivers. This panic button system in the key or vulnerable places can really help to call for security for immediate need. And portable, this is again one of the innovation from the smoke extraction point of view. I'm sure Brigadier will agree. This particular system really helps to avoid the smoke being spread in the floor. It helps in the easy escape routes, and really maintains the visibility of the occupants. It's a handy system, another innovation. And ANPR, this is an automatic number plate recognition. Today we have cameras which can recognize. So if somebody is like a vulnerable person entering into the hospital premises, if these numbers are given to the security, we can really catch hold of them. This again are easily available in today's situation. Facial recognition technology is yet another system where again it's a crucial for controlling the access to the restricted areas. This again can be identified through our camera system. Overcrowding detection, people count. Again, we do have currently an innovation which helps in identifying these overcrowding in different areas. And we are really able to expand the situation. It could be sometime like, for example, a particular OPD, when it is really full, we can either expand the OPD or probably create another OPD. So this becomes really handy for the administrator to take a decision. Heat map analysis and planogram mapping is yet another innovation, wherein the heat maps can really visually represent the areas of high and low activity within the hospital premises, and the administrators can take really a good situation, a good solution to understand the spaces in the hospital. And the planogram is basically a layout of the hospital management. For example, if some equipment is being utilized much more, we can, that as an administrator, we can think of having another equipment. It could be even a purchase decision. And these kind of innovations really helps in the operational efficiency and, of course, the patient experience. This is another video-based smoke and fire detection system, wherein in a large hall, we are able to really identify the smoke and fire, and again, the decisions or the security can quickly come into the play based on the needness of situation. Centralized monitoring and remote control access, again, this is again available, and I think probably whatever I'm recommending here is like something doable and adaptable in hospital industry. And irrespective of the size and complexity of the facility, these cameras really helps in catching and monitoring the video feeds and making it easier to spot and respond to the potential threats. The future of the hospital, I think, lies in AI's hand. So predictive analysis, integration of smart devices, fully automated security systems, all these are really going to help us in making a hospital a better place to live in, and really helps in adapting to the healthcare evolving needs. Of course, some of the challenges which lies in adapting to these innovation, one is cost consideration. I think often security is a department which is probably ignored when it comes to an AOP or choosing the budget. I think we need to look into this, considering the security of the building. interoperability issues, because there are different softwares which are in the hospital. So one need to consider about the interoperability issues also. User training and awareness is a very, very critical and important. And of course, the regulatory compliance in terms of legal compliance and HIPAA regulations. I mean, we talk about so much of innovation. At the end of it, everything lies in the hands of a security professional. So one needs to have a clarity in communication, need to be alert and have a confidence and the self-courage to confront any kind of situation, and of course with the compassion. I think compassion is the key word, I think which even Ms. Preeta Reddy spoke about during the opening session, the TLC mantra. I think unless the security carries this TLC mantra along with all the innovation system, he cannot be successful. Does the security require a soft skill? Yes, of course. It is the basic need for a healthcare industry, which really makes a big difference. And I would like to add, saying that even in the 8th editions of the JCI, there is an element under FMS which talks about it, 04.00, talks about the workplace safety. I think this needs to be added. This is a new element which has been added. I think as an organization leader, we need to understand and come out with a program which talks about the annual evaluation of this workplace safety. This is an, again, important role which I would like to add as part of the security measure. Security is just not a profession to handle people and the property. I think they really protect the trust of the hospital, because there are so many patients who really depend on us and they come for healthcare. And also the healthcare workers. I think security plays a major role in handling the patient and the healthcare worker safety. Thank you so much.
Thank you, Ms. Kamakshi, for a compelling discussion on emerging security trends and innovations. And now finally we would like to hear from Ms. Dipali on future trends in medical equipment safety, innovations and predictions.
So my name is Dipali and I'm working in Electa as a project manager. Today we will discuss the future trends in medical equipment safety, innovations and predictions. Aiming towards safer technology for a healthier world, we harmonize health and innovation in technology to deliver seamless, intelligent patient care and safety. Today, we broadly accentuate the future trends in medical equipment safety. We initiated with prepare and prevent, not repair and repent. We now emerge towards predictive preventive maintenance with innovations in AI and developments in other technology. The future of medical equipment safety is poised for significant advancements driven by a combination of technology, harmonizing complex workflows, regulatory changes, and increased focus on delivery of seamless, intelligent patient safety. If we consider the current trends of medical equipment safety, AI and machine learning holds the 25% of the market innovations. Cybersecurity, another 20%. Regulatory changes, another 15%. Integration of biometric data and wearable medical devices, another 15%. Automation and smart devices, another 10%. Remote monitoring, telehealth, another 10%. And the rest of 5% is battery life, power management. Now we will discuss AI and machine learning. Machine learning and high-level algorithms can analyze vast amount of data to predict failures or malfunctions in advance before they occur. AI is being used for automated calibrations, diagnosis, therapeutics, ensuring equipment is always functional at its optimal levels. It has been widely used in radiology, radiation oncology, cardiovascular equipment safety, and other domains. It improves mammography-based cancer risk predictions, improves surgical predictions. It improves digital therapeutics, 3D printing, immunotherapy, stem cell therapy, imaging. This is now encompassing even smaller devices like stethoscopes that has software to spot arrhythmia. It improves patient diagnosis, drug delivery, and management. It's transcribing medical documents, revolutionary hearing aids that utilize AI to improve speech understanding. Cybersecurity and innovations. As medical devices become more and more connected, the risk of cyber attacks increase. The future will see a greater emphasis on embedding stronger algorithm security protocols into medical devices. This will be crucial for preventing unauthorized access to data breaches, ensuring safety features cannot be tampered. Implementation of behavioral biometrics, zero trust architecture, blockchain, quantum computing, etc. are getting improvised. The next one is integration of biometric data and wearable medical devices. Medical equipment will increasingly be integrated with biometric data to ensure equipment is tailored to individual specific needs. Wearables can monitor a patient-unique biometric scanner and adjust settings on devices like infusion pumps, ventilators in real time, ensuring more precision and safer treatment. Off-the-cuff BP monitoring, non-invasive drug-free tremor treatment, non-invasive glucose monitoring, wearable infusion pumps are some innovations getting improvised. Automation, smart devices, and predictive maintenance. Smart error detection and user interface improvements will flag any irregularities in real time, offering corrective suggestions and preventing dangerous outcomes. Safety concerns will shift as the devices are becoming smarter, smaller, and portable. Designs need to minimize portable hazards, example, overheating, potential leakage, ensuring safety. Portable hemodialysis, revolutionizing infertility treatment with magnetic microbots are some of the innovations. So for maintenance, we started with generation 1, corrective reactive maintenance. Generation 2 was preventive maintenance. Generation 3 included condition-based preventive maintenance. Generation 4, Internet of Things powered predictive maintenance. Omnimedicine is the next one, remote monitoring or telehealth advances. Remote monitoring technologies are being used for devices like pacemakers to critical care ventilators, gradually expanding to much more complex equipment, and also reaching healthcare to underserved nations and remote locations. In COVID times, we witnessed advancements connecting various devices that communicate patient data to cloud-based systems. OmniHealth is an amalgam of virtual consultations and few in-person visits for consultation, and has become very common and gaining acceleration. This technology not only improves patient care by enabling real-time monitoring, but also improves safety by identifying dangerous trends in patient vital signs, triggering alerts to the healthcare providers. RPM, remote patient monitoring, has gained importance and contributing to patient safety. The other trends are sustainability and biocompatible device advancements. There is growing pressure by medical devices to be both effective and environmentally safe. Biocompatible and biodegradable materials innovations is leading to green nanotechnology innovations, bioactive ceramics, polymers, etc. The other one is enhanced user training through virtual reality-based programs, and real-world simulators will improve understanding device handling, reduce errors, and enhance the response time during emergency. The next one is regulatory changes and compliance. With innovations comes stringent safety regulations, aiming to global standardization and safety protocols, considering cybersecurity equipment as well, requirements as well. The key predictions in medical equipment safety. If we consider another 5 years growth index, AI and machine learning integration will have a steady growth. The cybersecurity focus will have a sharp rise. Regulatory compliance will have a gradual increase because it involves a lot of regulatory approvals. Wearable medical devices will have a steady growth. Telehealth will have an explosive growth. Thank you.
Thank you. Thank you, Ms. Dipali, for an insightful look. Now we'll probably gather all of our panelists together, and we'll take one question for each of the panelists from our audiences, and then we'll close the session. Somebody? Okay, somebody else for Ms. Kamakshi? Yeah, please. Okay.
small trivial issue with respect to fire doors. Now there is a need for security and a single access point, so we often see that fire doors are chained from outside so that there is no access problem. So, but it directly it is opposite to what we require for opening. So how do you deal with this situation where you want to have fire doors for evacuation, but you also want a single access point because you don't want 20 guards to be in the building. You just want one guard at one point so that he checks who's coming in, who's going out. So how do you deal with this situation? Is my question to you.
Probably I would practically say on how I handle my hospital situation. Yes, we do have the fire doors, and these are definitely operable. Probably when you press the lever, you can really get out. What we have done is an alarm system which is connected, and these are monitored by the cameras. So as somebody opens it, safety and security is actually, no, there is a small thread which goes in between. And if there are any misuse, it can be captured by the security cameras. We don't have security guards standing outside the fire doors everywhere. But however, this alarm system really helps us to ensure safety and security.
There's also a supplementary question, perspective from the government hospital point of view. Like there are a lot of government hospitals where there's not so much high tech monitoring that is available. So they eventually just put a chain and they lock it, and it's the end of the story. Cannot there be any further solution to this problem, because this is a problem seen in all big government hospitals? So just a open thing. But in fire,
Anybody else who wants to ask a question?
Integrate all these whatever we have discussed in a broader framework, not only from a regulatory compliance point of view, but enhance the effectiveness and sustainability. Sorry. Because that's a new thing which is coming. And whatever we have discussed so far is more relevant in that context.
So, if anybody would want to answer that.
Can I answer that? Okay, so see, this can be somehow met with your purchase policy. Okay, right from the equipment selection, right from the materials used. Now you have a green purchase policy. Yes, the technology advancements are there, and at the same time, we have to balance that with the social, governance also, social responsible governance also. So the organizations which are actually embracing the technology can also look at this, and they can also develop green purchase policies. Right from there are other measures like how do you get your power, because see, the thing is the hospitals are generally power guzzlers. If you look at hospital, if you compare hospitals versus the regular commercial buildings, it is 2.5 times power consuming than the regular commercial buildings. So they can look at power purchase policy. They can move more and more towards green power purchases. In Apollo, we do that, and most of our hospitals are actually operating on green power purchases. In fact, some of our hospitals are 100% reliant on the green power purchases. So this is one way of looking at going green and sustaining things, and your waste handling can be done. And there are technologies available now to recycle your wastewater. Of course, we have in India, there is a stigma about reusing the wastewater and using it for certain purposes. But you can look at purposes like in HVAC, typically you can use it for cooling towers, or you can use it for flush outs. But in German, they use it actually back for drinking also. And you have great systems available today, which actually makes the wastewater into a recyclable, recycled and drinkable water, potable water. So there are several technology advancements. So you have to balance it out. That will be the key for us to be the sustainable in future also.
One is key management of the hospital, I think, becomes an important factor, because sometimes you may have a fire which is inside a room and you're unable to open the room because you can't locate where the key is gone. So I think that is one area that we need to ensure that that none of the all rooms, the keys are there with the security where they can open at any given time. That is important. The other thing which is very important is that the security rounds at night, because after the office hours, they need to take a round and ensure that all the ACs and other things have been switched off, all the all the computers have been switched off. Otherwise, you can have fire from there also.
Thank you, sir.
Question for him.
Facility. And when you do the project, the cost budget plays a very important role. See, what we often do is we compromise on the flexibility of the systems. And the question to Tulasinadan is uh, what do you think the best way of managing both uh, the cost escalations and the design? For example, in hospital industry we always prefer what we call typically in project language N+N systems, where you have 100% backup. For example, if I have a generator which is actually a backup system, I would build the similar capacity of another generator, which means I have N+N. Whereas the trend also looking at N+1, where you don't have 200% backups, but 100% and 150 or 75% backup. So what do you think in terms of with relation to hospital industries, healthcare industries? What do you think is the best way of addressing the budget constraints as well as getting a more flexible system?
So nowadays there are like new vendors are available. There is no need that we should go for this all the existing MEP consultant only. There are new consultants are there that they can design in a better way than the existing consultant. The existing consultants, they're always thinking about huge amount of safety factors. So because of that, this all the pump selection, the chiller selection, everything they're selecting in a abrupt way, and because of this high safety factor. Say for example, I need to go for some 25 HP pump, say with 50-meter head, but they are selecting just above 30 HP and with this almost 65-meter head, because they wanted to be safe in case of just final testing and commissioning, and they would like to ensure that they are not getting in any trouble and they would like to get the final payment. So the new vendors, they are just selecting it exactly actually. If our hospital requirement is only 50-meter, they're selecting only for the 50-meter or 51-meter in that way only. So that way it is happening. And again thing, as per this for the DG point of view, for the DG we should not take any risk actually, because that without the DG and without the backup system we will not be able to run the hospital. At the same time, for example, our hospital demand is something 2000 kVA, and we can go 1000 kVA and 500 kVA, and based on the particular time that whatever the load is required, accordingly we can switch on the DG and it can be managed.
I just would like to add one more point, a practical situation which we handled a year before in our hospital, where we were running short of generator because of the flood situation, and what we had is a good arrangement with the consultant, the generator consultant. So he was able to provide us a rental generator by which we could run the lab facility. So that was probably a good arrangement with the vendor. Though we don't have the generator of our own, this could help us.
Agreed. For the temporary measure, the rental DG is fine. But for the long run and with the lesser cost, and even for the operation, so this will be better. For example, my actual load is, it is only 7250 kVA. Rather, if I have only 2000 kVA and DG, like only one number I have, So I might switch on the entire DJ actually. One DJ I have to switch it on. It will take more amount of fuel actually. So it is actually it is totally waste. So rather we can run 1000 kVA DG and one 500 kVA DG so that it will be managed. One 500 kVA DG we don't even switch it on. We can save that particular fuel.
Thank you.
So that way we can plan it out.
Thank you. So, okay.
The regime of properties and having a social pressure where people boast of their fire capabilities and equipment, everybody puts a board outside rather than depending on entirely on NOCs, etc. So it's my question to you, sir.
You are very right. We are moving on this direction. We have already issued in Delhi a self-certification type of pro forma where you will take all photographs, time-stamp photographs, all building requirement, you will give an undertaking. That I have checked it and I am responsible if anything goes wrong. We are already moving on that. Not only for hospital, for all other building also. Because staff is very limited and building are coming up every year. In Delhi, population is increasing, building are increasing, hospital are increasing every day, and it's not possible for us also to inspect every building. So we are already moving on this direction. Our performance is already issued to the nursing home cell, and they are distributing to all the hospital. I think some hospital might have received that performa also, that you have to fill it, give your undertaking, time is a photograph, so that if we'll go 5 or 10% for inspection. So already we are moving on that direction. Then it's not a issue, it's depend upon the height. The fire protection measure will go increase, your setback area will increase. It's not a height issue. More the height, more the extending the fire rule. That's the only issue, nothing else. Thank you, sir.
Thank you, everyone, for your presence and for this engaging conversation we had. So we'll bring a close to this session, and in interest of time, we'll request everyone to kindly be seated for the next session. And thank you, everyone, for your participation and patient hearing. Thank you.
Thank you, everyone. Thank you, our session chair. Thank you, speakers. Excuse me, sir. The one in the turban. Okay. Yeah, we have a special something. We are actually gifting the most interactive person in the audience. So we'd like to, give something, and our session chair would do that. Yeah. So if you could just wait for a moment. Yeah. Please be seated. Request everyone to please be seated. Yeah. You can sit in the audience, yeah. Sorry. Yeah, the other one. Once again, thank you, everyone. Okay, so just concluding it, resilience exists in nature. Plants or animals, each and every one helps us to prepare, be it sequoia, be it any other water plant, so it exists as a part in us. Thank you, speakers. Request you all to please be seated. As we roll on to our next session, request everyone to please be seated. you so much. Patient experience isn't just about comfort. It's a front line of healthcare operations. A well-run system doesn't just treat diseases, okay? It builds trust, drives outcomes, and every interaction at every step is towards the healing. Moving on to our next topic, okay, intersection of patient experience and healthcare operations, for which we would like to extend a very warm welcome to our session chair, Dr. Nitin Jagasia, Senior Consultant, Head Emergency Apollo Hospitals, Navi Mumbai. Dr. Nitin Jagasia is a highly experienced senior consultant and head of emergency at Apollo Hospitals. With expertise in emergency medicine and critical care, he plays a pivotal role in managing acute medical cases and streamlining emergency response system. We would also like to welcome our first speaker, Dr. James Merlino, Executive Vice President and Chief Innovation Officer at JCI, to the stage. His efforts have enhanced healthcare safety and quality through data and innovation. I would like to extend a warm welcome to our second speaker, Mr. Joy Chakrabarti, Chief Operating Officer of PD Hinduja Hospital, to the stage. With 21 years of experience in healthcare industry, Mr. Joy has wealth of expertise, in driving operational excellence. Prior to his current role, he spent 9 years at Sri Ramachandra Medical Center in Chennai. A warm welcome to you, sir. It's my privilege to welcome our next speaker, Mr. C.B. Rajesh, Project Head at Q Degrees. He has been driving innovation in customer experience since 2013. He leads the development of measurement products and digital solution. Under his leadership, Q Degrees has expanded into quality audits, mystery shopping, market research, and process consulting, serving diverse industries. A very warm welcome to you, sir.
Good morning, everyone. It's a pleasure to be here, and thank you for the invitation. I'd like to ask Mr. Chakrabarti to start the session off. James will be joining us in 15-20 minutes, we believe. Thank you.
Good morning, and I want to express my thanks to Apollo for inviting me in this session. So next maybe 15 minutes I'm going to talk about some of the technology what can be used for reducing the waiting time for patient at different touch points when they visit a hospital. So I'm going to talk about technology, and technology is challenging me. Go back. No, go back. Go to the first slide. Yeah, no. Yeah, just keep it. Yeah. So, okay. So now it is in place. So, as I told that I'm going to talk about different technologies which are, needs to be addressed to reduce the patient waiting at different point when they visit a hospital, and some of the innovative approaches. Some of the technologies what I have mentioned here may not be there in my own hospital, and some of them are. So I'm going to give you some sorts of ideal scenario what we should think for, but there are definitely scope for further improvement. So where is the patient waiting takes place? So if you ask patient and if you take their feedback at different touch points, you will see they will talk about the patient registration counter, they will talk about the consultation, emergency room, which is the most traumatic situation they face, then surgery, diagnostics, getting reports. All these are pinpoints for the patient in terms of the waiting. And if we see why we need to reduce patient waiting time, very simple, no brainers. Because different studies have shown that the kind of impact it creates in patient selection of their preferred healthcare provider. Studies have shown, not in India, that 35% patient, they have switched their preferred healthcare provider if they are made to wait for a long time. And the other thing is reputation. Today, because of the social media age, we have seen the moment somebody's waiting time is more, they need to wait, they give kind of feedback, and when people they search, and especially with due respect to the women, it has been seen that they look at the waiting period, and on the basis of that, lot of time they take decision where to go and where not to go. So reputation experience management is another factor. Then if you have long waiting versus your neighbor, they don't have much waiting, you are in the competition, and you need to improve yourself. And most importantly, by virtue of all this, if you lose a patient, your cost is very high to acquire a new patient. So we need to be very careful. What are the approaches? As I told, some of these are probably pretty common, but the most traumatic phase what we have seen people they undergo when they want to select a doctor, select a facility, and they want to book an appointment, and they come across a lot of hurdles. And during that time, this online patient appointment, they can identify the right slot for them, they can identify the right time for them, and accordingly they can do, which is a very win-win situation for both the providers and for the patient. Digital check-in and pre-visit registration. Today, I think when I started my career, it was very common phenomenon for the patients as well as acceptable norm that you can go, you have to stand in the queue, you have to register, you have to pay. All this were happening, but today you can get into a hospital in a facility through digital check-in, and you need not to stand in any queue. The way DG Jatra, probably all of us have seen, it has completely revolutionized the whole airport access, the check-in process. I think that is something what we should look for. This is another thing, and I remember 2016, 8th November, when the demonetization took place. Many facilities, they had major challenge in terms of how do you manage and sustain business, because suddenly cash has gone from the economy. So hospitals were also challenged. But I can tell you, in our own hospital, many of these things were on place. As a result of that, we didn't face much challenge. But over a period of time, I think, again during COVID, we have learned in a very hard way that how do you adapt some of this payment thing. And today, I can tell you, I was told the last quarter, the digital transaction in India, the way it has taken place, it is close to 4 times of what has happened in US. So it is completely changing the scenario, and we have to gear up with that. Incorporate accurate diagnostic tools before visit. What I mean is, you know, if you have certain records for, you know, you need to record, keep it, needs to be transferred to multiple care providers, means I mean doctors, nurses and all. You should do that rather than asking the same question again and again. And during that process, when a patient waits, they feel very, I think, challenged in that environment, in that particular condition, especially in a year kind of situation. So this is the thing what I was talking about, that keep things ready in the digital format so you don't need to wait and things can happen faster and better. Some of those also includes, you know, like PACS, the RIS, those kind of things help you to get. I'll tell you from my own example in the hospital before 2008, when you didn't have the PACS. Just after signing the report of the doctor, when patients were receiving it, there was a time lag because it has to come physically from the patient doctor's desk to the dispatch counter, and then that used to get collected. But when the PACS came, it has completely changed the whole thing. It goes fast. The moment it is signed, it gets automatically loaded. You can see it either from the website or the link what is sent by the hospital. Self-service kiosk. One thing we need to also agree and understand, that in any business, especially in the retail, what is suggested always, that keep your customer engaged. If you don't keep them engaged in different formats, you are going to have tough time, because they will be observing everything what is happening around them, what is happening around the facility, and from there they will get clue. They may complain, they may observe things what you don't want them to know. So you keep them this automatic kiosk and all, where they do themselves, they get engaged, they get busy, and automatically they go back with a satisfied mind. The other thing is, you know, traditionally during our young days, we have seen a patient who goes to a doctor for a consultation. They stand in a queue, they meet the doctor after waiting. But today the practice, at least in some of these private setups, have changed in a big way, where the patients are taken, reports, histories and all have been taken by this set of people, and you keep them engaged, and finally the interaction with the doctor, when it happens, it becomes really fruitful and useful. It gives a lot of satisfaction to the patients that I have spent good time with a good discussion with my doctor. Virtual queue technology, it is again very important that, you know, 2005 or 6 I happened to see, till then I didn't see in India in any hospital, where there was a system that doctor's clinic outside, the nurse who is standing there, he or she gives, press a button, an automatic message used to go to the patients that now you are third in the queue. So before that, you can be anywhere. You need not to wait anxiously outside the clinic, doctor's room, and wait for your turn. You can be anywhere, and when you get to see that you are the third one, accordingly you can come back and you can wait for the doctor. That takes away a lot of your, hurdles in terms of waiting, seeing the same facility, same people walking around yourself. You can be there in the cafeteria, you can spend time somewhere, and you can come back. There are areas where you can increase telemedicine appointment options, because COVID has again shown us in a big way that a patient need not to travel, wait, meet the doctor, but when it happens in the telemedicine mode, I can't say that it is going to be 100% useful and effective in all scenarios, but in many of these cases, including follow-ups, this is going to be very helpful, where they can cut down the kind of waiting there in the OPD, in the consultation room, and they can be at home at their own comfort zone and consult and get the work done. Patient appointment reminders to lower your risk of no-shows. What I'm trying to say, and the next slide is going to be going hand in hand. If a patient decides not to come, and if you have previous day follow-up, and this kind of systems we have in our own hospital, you are well prepared in the morning that out of your maybe 50 appointments, who are all not going to come, you can tell rest of the people, you can adjust, and you can get your clinic more better, efficiently managed by virtue of doing all this. And when you do this, you have to do one more thing, which is my next slide, that the person who is not going to come today, how do you accommodate him or her at the earliest? So you not only satisfy them by telling them that you are important, so I'm taking care of you, but at the same time your own hospital business also you can retain. Optimize access management. So this is something to do with automatically refilling. What I mean is, whether it is pharmacy and all, it may not be that applicable in Indian context, but in Western world they have pharmacy medications and all, they need to come pick up from pharmacy and all. Those kind of things also can be done without much waiting. Integrate AI in healthcare. So one of the things in terms of waiting, what we have done in our health checkup facility, where when a person who is undergoing health checkup, they are directed in multiple diagnostic modalities depending upon the workload what is waiting there. So they get an alert, or they get to see, we give them a small kind of thing where they see where they should go next. So if 40, 50 of health checkup people are there, all of them need not to go first to the X-ray. Maybe 5 of them will go there, 5, 6 will go to ultrasound. Like that it gets distributed. So that is the way, again, waiting time is reduced. These are some of the areas where we can see predictive analytics, which helps us to reduce the waiting at different point of time in the hospital, outside the hospital. Especially when I say outside the hospital, I mean when they need to come for a chronic disease management case, they can avail this kind of technology. Smart scheduling software solution for next level clinic appointment, that is something we can think of, we can adopt, but nevertheless we have to keep in mind that whatever you do in India still today, that kind of organized way, meeting the timeline and all are not happening. A doctor, on an average, it has been shown, reported, spends 2.54 minutes with a patient. So when they are so busy and when they have so many patients to see, then you can't expect that even after applying all this, it is going to take away your pain. But only thing you can expect, things will be little better than what it was before. Real-time monitoring and resource allocation. This is a photo of command center in Johns Hopkins. I personally visited and I have seen they have a healthcare system where more than 16 centers, small, medium size, connected to the main one, and whenever a patient comes to any of these 16 centers, or even in their ER, they can track and monitor that what is going to happen, how soon the ER bed is going to be empty, how soon the ICU bed is going to be empty, and accordingly they can predict. And that will be more than 400 people are working in multiple shifts to manage this center, and they claim it has improved their productivity in a significant way, and most importantly, it has helped the discharge, predicted discharge for a patient on the basis of their clinical data availability, and at the same time giving the ICU regular bed as well as the ER beds to the patients who are coming from other peripheral centers. So intelligent triaging system can be done, which can reduce the patients in the ER, their waiting can be reduced. And this is very important that when you do all this and try to use technology, you may lose the human touch, because ultimately that is something what your patients are looking for. And these are some of the methodology, or rather I should say, tools which can enable you to improve yourself further for the patient flow optimization, which ultimately brings down your waiting period. Effective communication. When you communicate, because of a wrong communication, this is not a big technology, but there are multiple technology what can be adapted to bring down this communication error, and that can reduce, because I tell something, somebody hears something and they act in other way. So those kind of things can be reduced. Importantly, how do you collect the feedback to improve this? And if you see the left side one, the patient care awareness month currently in our hospital, 1 month celebration on this patient care awareness, what we celebrate every year in the month of February, it is going on, and we have a particular week dedicated for we are listening, where from senior management to mid-level management, they meet, interact with patient. We get patient in our discussion area, and we try to understand what is bothering them, and from there we develop the strategy what we need to develop. So these are some of the facilities what you can see. Most of these are from Western world, but these are not necessarily only technology, but kind of ambience and designing architecture that can reduce waiting time for a patient, that can enhance the patient satisfaction, and that can give you a better NPS score, improving patient experience, and which is the ultimate objective for us in this discussion. So to conclude, I must say, in one hand we have technology to adopt, on the other hand we have environment, infrastructure, and most importantly the human touch, which can't be taken away completely. All this can be integrated together, create an environment which can help patients to get better service at a shortest duration, and that can keep them happy. Thank you very much.
Thank you so much for that session. I think the highlight is that we definitely to use AI and innovation technology. Along with that, also work on the perception of the patients with the ambience and other things, so that overall they have a better experience at our hospital. I've been asked for, is Nick here? Nick wanted to, no? Oh, sorry. Yeah. Then, yeah. Over to you, Nick. You were here in place of James.
Yes, thank you so much. Good morning, everyone. My name is Nick Liu, and I am from Joint Commission International. I know everyone was expecting Dr. James Molino to give a little bit of a topic on today's session. Unfortunately, he is being held up with another sessions, and I would like to apologize on behalf of Joint Commission International, as well as Dr. James Molino, of is unable to present today. So with that note, I know today is going on extremely well, and I wish everyone a very successful events today. Apologize again. Thank you very much.
Thanks, Nick. So we'd ask Mr. Rajesh CB now. He's innovative way of supporting the talk we've just had. So different ways of finding out how we can improve the patient experience. Thank you.
Good morning, everyone. So Joy actually made my life easy. He told everyone what is expected, and our job is to find out whether it is happening or not. So, so we show the mirror to organization in terms of the strategies that you make. We also tell you whether it is really working. and how patients are actually treated basis the strategy that you've made in the boardroom. So we are those silent observers who send, if I can use the word, undercover customers to see what is really happening. All right, so where is... So I'll just quickly move on. I think the context that I want to set here is there is one of the assumptions or even the research kind of indicate that 90% of the customers who are unhappy will not complain. They will simply walk away to an alternative option. That's the reality. So even if you want to take feedback, those feedbacks you only get from 5 out of 100 customers. So all those silent customers walking out of your premise is what you need to care for. And in fact, when we do our mystery shopping, when we send our customers, what we try and do is we do not simply send them, we train them. We tell them what scenarios to be watched out for, what kind of checklist that they need to follow. So there is a science behind these kind of activity that we do. So we not only calibrate the customers, we also try and tell them to create scenarios. So not all the time the customers who walk in smilingly are the genuine customers. They are actually looking to evaluate how well they are being treated. The mystery shopping activity has been there for a long time, but we have kind of evolved it. So it is not simply sending customers, they also go out and talk to your touch points, they digitally engage with your support staff, and then they go and meet your doctors. So that's the model that we follow. Just to give you a context, what are the advantages of doing this? You actually get inputs from the customer lens. These people are not biased. They don't understand your processes. They purely look at it from a customer lens. You could also benchmark it, because you could send a customer to your competition hospital and check how they deal with certain situation. So this activity is done from a vantage point of not only validating uniformity, standardization, and also checking what your competition is doing. So that's the kind of activity we do. These are some of the brands. I'm not going to be spending time here. But what I essentially want to tell you as an organization, we do a lot of work in health industry. In a year, we send close to 3,000 customers to clinics, labs, pharmacies, and various touch points. I got thrown out. Okay. So what we essentially do is we also audit a lot of conversation. So hospitals is not about doctors. It is also about various other support conversation that is taking place. So about 18 lakh conversation we audit. The machines audit those conversation, humans audit those conversation, and see what is really happening. We also take feedback. I mean, Joy was talking about listening to the customer at various levels. So we also collect 40,000 odd feedback in terms of understanding what is really happening. So these are the scale of activities that we do. Am I doing something? Okay. So now that I have set the context, let me also tell you, what is really happening in terms of outcome. So we actually do a lot of audits for various hospitals and clinics. But I want to present a use case for one of the large health service provider. And the kind of journey that we kind of look at are appointments, registration, infrastructure and hygiene, consultation, investigation, and pharmacy. This is the typical journey a patient go through. So we kind of want to look at and evaluate how these services are provided. And let's look at how much improvement has taken place in last 2 to 3 years. Now, if you look at appointment process, and this is what Joy was mentioning, that you have a lot of waiting that happens. But it is also because a lot of information consistency in terms of are you communicating the appointment details? Are you also telling them where to go, who to meet, what precautions that they need to take? So what is the kind of information dissemination that is taking place? When we started off this journey, only 30–40% of the customers were getting SMS. Now for today, when we look back, we get almost 100% SMS delivered. So that itself was an issue. It was not an issue maybe at an hospital level, maybe at the technology level. So that was one issue that we were addressing. Another issue was accuracy of information. Do you have the right doctors meeting, or do you have the right OPDs where patients are going? So we kind of looked at that. We are also looking at what kind of processes do we have in terms of guiding the patients. So many times we found that patient assistance at the reception or registration was not available, which is now getting fixed, and it is quite encouraging to see that improvement is taking place. Registration process, like Joy was mentioning, the technology has really transformed in terms of not only sending the link, but customers could make the payment. So you don't have to wait in the queue in terms of making payments. So those things have kind of decongested and also freed up a lot of time for customers to really go and get the care. So you could see almost 30% scores going up to 90% scores. So there is a big transformation technology has brought about. When I talk about pre-consultation, we had the vital checks happening, but it was not consistent. We also had issues with respect to privacy of patients in terms of vital communication. Now, we have seen that most of these areas are covered. It is handled in a private manner. Weights are not shouted out where others could listen to certain. So those issues have been resolved now. Consultation as a process has improved, but there is a lot to be done. Timeline adherence, when we send our patients, we could see that there was almost an average of 1 hour waiting, which has now gone down to 30 minutes. Is 30 minutes okay? It is still not okay, but we can improve it. That's something that we are working on. But one of the issue that we found was quite disheartening was diverting patients to outside pharmacy, outside clinics, and various other places. If a patient has come to your premise, they should be served there end to end. That has dramatically evolved. We still have few issues, but majority that has been solved. Investigation, do's and don'ts getting communicated to the patients was a challenge. It has improved. What has not improved is the timelines. Still, we go to the investigation, till what time the investigation will be over, when the reports will be submitted. Those are areas we are still kind of working on. It has improved, but it still is an area that needs to be focused on. Pharmacy, again, there are issues of medicine availability. Doctors prescribe certain medication, but that medicines are not available. And then the pharmacist needs to get back to the doctor and check, can they be given another medicine? If not, then they are sent out to medical stores where they may not find the medication. So these issues are still there. It has improved. We have almost reached 80%, but there is still a gap of 20%. I think I am in serious trouble with. In any case, so I think I was on the end of conclusion. So what I am essentially trying to. seriously don't want me to present? Oh, yeah. Okay. So infrastructure and hygiene is something that has dramatically improved, but still, if we were to look at it from our auditor lens, we still find issues with toilet supplies. You have neat and clean toilets, but you walk into the toilet, you don't have sanitizer or soaps or tissues. Those are still issues that needs to be fixed. I mean, that's the level at which we look at various journeys, right? So that you can have seamless experience for the patients. Now, finally, what are the opportunities that we still believe should be looked at? I think diversion in any form is not okay. That still needs to be fixed. Uh, Clear explanation in terms of whether the counseling is happening from the doctor side or other physicians is important, because most of the patients today are educated. They do a lot of Google research before they visit the doctor, so they already have half knowledge or half perception. So how do you deal with that conversation? That's important. Appointment timeline adherence is still a challenge. You still have about 30 minutes wait time on an average, if that can be reduced. And if digital case history is on the rise, that helps the patient at all locations. We are looking at how can it be integrated across the spectrum, so that they only need to talk about their code, and even the pharmacist can deliver their medicine. So those are aspects and areas that we believe that can be is an opportunity and must be worked upon. Thank you. That's all from my side. Thank you so much.
Thank you so much for that session. Like to open for any questions from anyone?
So my question is from sir. Sir has told that yeah, for waiting, the registration and billing process is mainly responsible. So you have given us a solution that if patient does pre-registration and billing online, so that could solve the problem. But at ground level, the actual problem is with doctor's consultation. Actually, we have 15-minute slots for doctor's consultation, but doctors usually takes more than that. So my question is, how can we manage that situation? Like
See, if you wanted,
pre-registration and billing is a different thing, but how can we handle that situation?
see, I have to work in a hospital. I can't make that as a fast complaint. You understand? So I have to put it later, the doctor's waiting time. So if you ask me how do you how can you manage, there are multiple things what has been practiced in abroad. A doctor, they have two chambers. One patient is taken here, junior has taken, then they go and see, come back here by the time another patient is ready. But in many cases here, that is not possible. The second thing is, when you think about the Western world, a doctor gives a slot of 30 minutes with $500 charge, consultation fees. Here, we do it at, depending upon city, 1,000, 1,500, 2,000, some are even 500. So when you have that kind of pressure that you have to churn out more number of consultation to keep yourself sustainable, they are prone to give in a short time lot of appointments. So it is like, where you are going to balance. Are you going to focus on more longer duration of consultation, or you are ready to make patients, waiting on that? The third thing I have seen in our own hospital, when you are very keen to follow the appointment system and everybody should come through appointment, in 2007 when I joined here, we had around 55% of OPD footfalls who were coming through appointment. Now it has reached around 70 to 73. Can you completely abolish? Answer is no. If you completely abolish this, those patients will go somewhere else. Your doctor will be upset that I am losing my patient, you are not allowing. So you are somewhere in a very compromised state. You want to bring quality, you want to give the best, but at the same time you have this kind of systemic issues. How do you do that? I think some realistic appointment time what can be given in many hospitals. I know for a 10-minute slot there will be double appointment. Why? Because if one person doesn't turn up, then I have another patient to see. That needs to be taken away. Little prolonged, waiting appointment duration with the patient, and finally little discipline. Most of the time we have seen that because of discipline, if your OPD time is 2 o'clock and if the clinic starts at 3, already 1 hour gone. And that 1 hour has gone not because of anything, because either doctor has gone to the OT or in the ICU or in the floor for round, and it is taken for granted. Patient has come for me, they will wait, they will not mind. If you make that 1 hour wait for the billing, then sky will fall. So you have to see that how do you discipline them, or most importantly, how do you incentivize them if they do the right thing. So these are some of the things. So there is no 100%, I should not say 100% result you can't get, but you can attempt to achieve by adopting some of this.
Thank you, sir.
I'd just like to add that now everything is available digitally. You've got the data. So you've got performance of every clinic, you've got performance of every area, which is actually one of the sessions yesterday it was mentioned that 95% of healthcare data is not utilized. So actually using that data with your clinicians, with your operational staff to see how you can improve that percentage. And like you rightly said, we'll never get 100%. We may be at 60, so we go to 65, 70, and then 80. I think we had one more question.
Sir, in a very similar vein, the question is about diversion that sir was talking. That does tend to happen where clinicians always have their own clinics, or for patient cost factors, they want them to come to a smaller hospital. So what can we do to maybe, like you were saying, incentivize them to stay at our center?
If you want to, in this, there are a lot of solutions have come already. So today, what we have not seen probably 5-6 years before, other than EMR as a solution, which has not been adopted in India at all in that way. There are technologies which are like, there was something called Inform DS. I'm not sure whether you know. So if a doctor writes in their prescription by regular pain, that is like a same kind of pain, they write, it gets captured, and when they write prescribe this medicine, this investigation, it gets captured, and through your call center or through your automated system, you can send reminders kind of things to the patient. You can see between two doctors whose patients conversions are more and whose conversions are less. That is one kind of solution. One step ahead, when it has gone, it has happened like when the doctors are giving this prescription, when it is done, when it is captured, it goes as a pending to-do list in those diagnostic modalities and in pharmacy. So you can capture, and you can completely control. Now if you know that somebody is really sending outside and is not listening to you, then there is a separate question where you have to take some action to get them into your kind of policy framework. Otherwise there are now enough system where you can adopt to get it captured.
I would like to ask Mr. Rajesh, sir, the mystery shopping method which you have shared for the OP patient, can we implement this kind of module in IPD journeys also? Because OP is easier, but most of the hospital mainly focus on IP patient experience.
You want his mystery shopper to lose kidney and all?
No, but is it applicable for other
okay,
journeys also?
so I'll tell you. This is quite complex. But what we try and do is that we try and onboard people who have certain illness and who are okay to kind of go into. But it is quite rare. But what we tend to do as a mitigation is where when a patient after an IPD patient checks out, we immediately within 24 hours or 48 hours go and do a face-to-face voice of customer. That's something that we do successfully. We typically not only talk to the patient, but we talk to the attendants, because attendants are the person who goes through that journey while patient is on the bed. So most of the time, attendants are able to give you a better understanding with respect to their experience in terms of the days that they've spent in the care. So that's something that we do. But what you have asked for is very rare. Not everybody sign up for those kind of things. But the voice of customer feedback post discharge is something that we do effectively.
Thank you.
I also had one question for you. So I just wanted to understand, the mystery shopper would be one patient or one undercover customer. So how do you get an assessment of the organization? Because that would have been for an hour or two in the whole year or in that month or in that quarter. So how reliable is that experience to really action to make changes?
So what we typically do, so you are right, samples are very low, but frequencies are high. So it's not that you do one interaction in a month and then take a judgment. You may get certain insight in terms of infra branding, which may not change, right? And various other aspects, or even technology for that matter. But when it comes to people engagement, somebody could have a bad day, somebody could have a good day. So you tend to have a lot of variation. So you kind of repeat it, and you also send different personas. So do not always send a youngster. So you also send different persona and see how those people are getting treated. In fact, we have a lot of people in the panel who are specially abled and also retired. So we also kind of look at how they get treated, and it gives you a sense of how empathetic an organization is.
Thank you. I think we've reached the end of the session. One more question. Okay.
Sorry for the just one question. You know, the data you presented here, this mystery shopping was done in a private setup, or it's a mix of government plus private?
No, so the used case that I showed is for a private setup.
Because the findings will vary in both.
Yeah.
Okay. Thank you.
Thank you. So I'd just like to thank both the speakers for giving your time and real insight on how we can operationalize patient satisfaction and take it to the next level. Thank you.
Thank you. Thank you so much. Thank you, our honored session chair. Thank you, our speakers. It's actually really fascinating to see how each and every topic, you know, is intertwined with the earlier topics that we had. When you guys were discussing, my mind was actually going to designing patient-centric facilities, how this is incorporated with this topic. Thank you once again to all of you all. So we would like to give certain small mementos and gifts to everyone who is interacting in the audience. Okay, request our session chair to please give those gifts to the participants who have been interacting. It's Ms. Dolly and the gentleman out there and ma'am here. Yeah. So a bit of an incentive to keep on those interesting questions coming up our way. So moving on to our next topic. In the era of rapid technological advancements, patient and ever-evolving patient needs, the efficiency and resilience of healthcare supply chain has never been more critical. And me coming from heading the dental operations, okay, I can vouch for this, that this is one of the most important topic, okay, or concerning topic that I have faced. So we would like to roll on to our next topic, reimagining healthcare in supply chain. To do the same, it's my privilege to welcome our esteemed session chair, Mr. Mohammad Ziauddin, a clinical pharmacologist specializing in medication management, pharmacovigilance, and antibiotic stewardship. He's been instrumental in quality accreditations, ethics committee, and research, a key contributor to Apollo 247's My Medicines and the drug knowledge software HIPAR. He also advises IT initiatives in healthcare. He has been awarded the Vidya Shiromani Award in 2021. We extend a warm welcome to you, sir. Please come on the dais. Please join me in welcoming our speaker number 1, Dr. Sanjeev Sharma, a senior consultant in clinical pharmacology at Indraprasth Hospitals, who specializes in pharmacokinetics, therapeutic drug monitoring, and patient safety. A warm welcome to you, sir. Please join me in welcoming our second speaker, Mr. Sachin Patidar, Senior General Manager of Supply Chain at Apollo Hospitals, onto the dais. Mr. Sachin oversees procurement and medical supply management, ensuring operational efficiency. A key contributor to strategic decision-making, he has played vital role in advancing value-based procurement in healthcare. Please join me in welcoming our third speaker, Ms. Aditi Jairam, Project Officer at Geneva Sustainability Center, onto the dais. Ms. Aditi at the IHFS Geneva Sustainability Center designs learning programs for healthcare leaders and supports GSC certified facilitators. Previously, she's worked as a senior speech language pathologist in the US, contributing to the policy development, quality improvement, and staff supervision, and pediatric speech therapy. We extend a warm welcome to you. Yeah, over to you, sir.
Very good morning. It's a very good topic. We are all gathered here for supply chain. Okay. So supply chain is like nature. It is all around us. We see any item product, it requires a supply chain to reach to us. Whether it could be any consumable products or medications. Medications are really important for hospital healthcare. Such an important topic. You know, if it get disrupted, we face that effect, and it will impact the patient safety. And we all have witnessed during COVID time how our supply chain got disrupted, and the leaders of this front line in supply chain very well handled the situations in our country and made sure that we became the world supply of the world pharmacy and supply the medications which are very important during our pandemic. So going forward, I welcome all the speakers on the dais, and we'll go through one by one session. So I invite Dr. Sanjeev Sharma, not holding him much, and he is very energetic and enthusiastic regarding supply chain. So sir, welcome you on your session. Over to you.
Let us wait for the technology to help us. So before let it come, there are two words in supply chain. One is resilient and second is agile, right? Resilient is the one when a lot of shocks come and it's able to bear that shock. Have you seen that shock coming in supply chain? Have you faced that in 2020? Right? That was a shock which came in supply chain. And agile is the one which is able to bear that particular shock in supply chain. So the process is the tool you put so that that shock can be absorbed, that kind of, we are ready for any other such shock in the supply chain. So I'm going to deal that topic, and I start with this vision. This is my favorite slide. We say how we can ensure safe and uninterrupted supply of high quality medications in a effective and efficient manner for excellent patient care. And at the same time, we want to eliminate chances of diverted, counterfeit, spurious supply coming in. So it put in nutshell what I'm going to talk about and what we can do. There was a time before 2020, we were all looking for profitability, and how we, in my supply chain, how I can increase my margins. And all the processes were towards that lean supply chain, right? I spend less on my stock holding days, and more I can generate the revenue for them. And then, of course, there is a shock which came, right? And we thought, okay, margins are important, but at the same time, continuous supply of these medications is equally important. So what we need to balance, we need to take care of those external conditions, and my supply should be with increasing speed and flexibility with agility, which we have discussed. This is how basically typically how a supply chain for medications work in hospital, from manufacturers to CNF, and from there it comes to distributor, then it comes to the hospital. And at all this given time, when you select a particular drugs through your committee in the hospital, looking into risk benefit analysis, then you procure that particular medications. We were talking about lean supply chain, which all the managers in the room will like it, because it gives you more margins, less stock holding days. But problem with this particular approach is it is not agile enough. If you don't put that agility in this particular systems, it will give you margins. It won't be able to bear those shocks which may come, those external factors when come in. You know, in Chennai, right, it rains 3-4 days, all the roads are full of waters and you can't get. So if you are not prepared those kind of shocks, you'll end up in trouble, because we are in healthcare. So answer for this agility, how I can put that processes using those new technology, new methods, use my tools and techniques, so that all these unexpected external or internal conditions, I can deal them nicely, how I can empower my people, my processes, my systems in decision making, so that we can deal with such system day in and day out when requirement comes. So lean and agile, basically that is the answer. When we combine leanness, resilience doesn't come in that, though margin comes. Agility is the one when you are able to hold those, but when you are only agile, you remember you will keep lot of stock of those items which may expire, which may not move. That is again a problem. So answer is, can we look into the hybrid of these two particular things there, where we look into margins? That's very important, otherwise we won't survive in the healthcare. At the same time, we have those conditions, those external factors, those environment, we can take care whenever it is required to increase supplies based on patient demand. So looking into what those risk factor is, how we can manage those, in very, very important to identify those risks, assess those risks, and we need to have mitigation strategies for this supply chain, so that we can bear for both internal and external risk factors. Your external risk factors, where you do not have control, it is related to outside environment somewhere else. It may be a demand risk, a item which was moving very fast suddenly stops moving. That is one. Second is supply risk. Your transport, there is a hartal there, right? Your roads are blocked, right? How your product will move into your hospitals. So your supply risk, your environmental risk. I gave example in Chennai, there are 4-5 days continuous rain and your roads are blocked. Business risk, you don't have enough money to buy those things, absolutely. So how you can take care, that is definitely top priority for any organizations. And internal supply risk is, it is the where we need to have a plan, we need to have processes, and we have system to mitigate this risk because we know this risk. Manufacturing risk, we may have raw material issues, we may have raw material coming into our supply chain, or we may have workers, we don't have trained workers, those kind of risk. Business risk because of this, planning and control risk, mitigation and contingency. Because of lack of time, I'm not going into detail of this. I will concentrate more on the how we can mitigate this PPRR risk management models. These 4 terms are very, very important. How I can prevent those risks, how I can prepare my hospital for this, how I can put my response and recovery. Prevention, you know, these are measures, precautionary measures in supply chain mitigations. I'll give you a small example how we can do. You may be having some critical items, so increase their storage in hospital. If you are keeping your for 10 days, keep them for 20 days, because without them your operation will get hampered. This is prevention strategy. You prepare, implement a contingency plan. So if there is something may go wrong, how I'm going to get my supplies on those days. And this plan should be tested and you should be able to execute that plan. And once that problem is over, how I can come back to normal things immediately by doing that. One major change we saw, you know, China was the factory of the world factory when COVID came in, and all the world was depending on one source. The learning from COVID was from one source to multi-source. If you are getting item from one vendor, make sure that you have 3-4 vendors for that. I remember before COVID, N95 mask mean I used to say that only 3M N95 mask, and we won't accept any other thing other than that. But COVID taught us we need to have multiple vendors, because first time when this came, China was an issue, their manufacturing was happened there, we could not get. So that was a learning for me personally, that we need to develop a lot of good vendors in India. So from your multi-sourcing, definitely, and from offshore to near shore. So we need to have our supplies nearby. If there is something goes wrong, we can get and we can ask this manufacturer to manufacture it more for us. So offshore to near shore, not depending upon, now world is asking India and Vietnam to produce more because of this particular risk. This is major risk, cyber security risk. All of us are using lot of technology. How? Not only it is important for my hospital to have good those antivirus, equally good for my distributor, for my manufacturer in supply chain. So all this risk, cyber security risk, is not only for me. If my manufacturers had that risk, I'm equally will have that particular risk. So we need to have compliance standards. We need to have data stewardship points at all those levels, not only hospital, on your distributor, your CFA, and very, very important is you do the vendor risk assessment every years and look into is there any risk mitigation strategy at all those particular levels. So we should be able to quickly identify this cybersecurity risk, and we have disaster recovery plan, and we have backup mechanism for all this cybersecurity risk. Now world is talking about blockchain, IoT. So that is very important to use this technology, so that my problem is I don't know in my supply chain how much is my distributor is having, how much is my CFA is having, and how much manufacturers has already produced. If I'm able to see that particular see-through in my chain, so I can plan accordingly my supply chain. So using this technology, interconnecting this technology network, that may help us further in my supply chain, reduce those particular risk. Building buffers for inventory and capacity. If you are in an area where a lot of hurricanes are there and this is hurricane season, make sure that you hike up your inventory, make it agile during that particular session. Yeah. Right, this is another one which we neglect, your freight, which is carrying your items. Have you looked into that? How many days it is taking? What are the risks in that particular supply chain by this freight? And what is reputations? Before selecting one, we need to look into the reputation of this particular. And it is not one time. Consistently, we need to keep on monitoring this risk in supply chain and new strategies. And along with this, very, very important nowadays, impact of this supply chain on the environment. And in hospital, this particular one point have a lot of impact. You will going to hear that in this particular session. That also we need to look into. That completes my presentation. Thank you. And we'll take question in the last on this.
Thank you, Dr. Sanjeev. It was very clear presentation on how the supply chain got shocked during COVID and how resilient our supply chain. It tested our country's supply chain, and also he balanced when it tests something we try to kill, but it does not kill. It makes more stronger. So that's how our supply chain got tested, and it has become now more stronger, resilient. And as well as you very well told how we balance the lean versus agile and make a hybrid model so that we respond quickly, rapidly, and as well as not compromising on the benefit and cost. So not stopping you from the next speaker, moving for the next session. We have a slide.
Thank you, Dr. Sanjeev, for making my work easy. And I think you have covered the fundamentals of resilient supply chain. Namaste and good morning to all of you. You plan to fabricate a new SELS ambulance with all the critical life-saving equipment. The normal fabrication time for a fabrication of an ambulance is 2 to 3 months. You also need a specialized roll-on stretcher for that ambulances. When you want to order, the vendors informs you that there is a lead time of 8 to 9 months. The reason? The stretchers are in high demand from the countries presently affected by war. Makes sense? You order for a surgical lab system 6 months back, and you are still awaiting for the delivery. When you insist the supplier about the delay, he informs you that the vendor is awaiting spare part from their vendor from a different country. Reason? Shortage of semiconductors. Oxygenators and balloons were in, IABP balloons were in acute shortage across the country for quite some time, and it affected the planned surgeries at many hospitals in the country. Reason? Shortage of filters and membrane used in the manufacturing of balloons and the oxygenators. Similarly, for the imported instruments, the lead time used to be normally 8 to 9 weeks, which has gone up to 14 to 15 weeks. Reason? Shortage of raw materials. Welcome to the unpredictable world of supply chain. I think Dr. Sanjeev, you have covered a lot of fundamentals of supply chain. So I'll just go to how the scenario has changed in last few years. I would put it in two ways: pre-COVID supply chain world and post-COVID supply chain. Pre-COVID world, supply chain world was more of a predictable in nature, and the focus was on optimizing for efficiencies. The themes like the lean, just in time, and predictably ruled the day. A lot of decisions were based on the stability, predictability, and the operations were normal. When the COVID struck, completely landscape changed. The lean became more of a resilient. And the companies who were mainly focusing on, the cost controls became more of a resilient so that, the interruption of the services are not there. So I'll just talk about few of the strategies that, we can implement in building a resilient supply chain. These are 6 key strategies that we can implement. These are no very, hi-fi kind of strategies, but these needs to be done at gross level. Risk mapping of entire supply chain cycle. I think Dr. Sanjeev, you have covered the entire risk mapping. Here I would like to say that, entire supply chain cycle has to be identified from the origin to the acquisition of the source. So like identifying risk, map out all the operational risk, financial risk, the compliance risk that affects all supply chain operations. Once you map those risks, then automatically the mitigation plan can be worked out. So accordingly, develop a risk mitigation plan of the identified risks, and then continuous monitoring. These risks are very dynamic in nature. It changes from months to months and from year to year. So once the risks are monitored, obviously the mitigation can be inbuilt in those factors. Second is diversifying supply network. It's very common to say this, to diversify the supply network. But then how do you ensure that, your identification of suppliers is done? So obviously, reliance on one supplier has to be reduced. For example, like sutures. There are 5 or 6 brands available in the market. So we should, have a long-term partnership with such brands so that if one is not available, another is there. If the second is not available, the third is there. So similarly, developing, multiple sources of the supplies. Then geographical diversification. Today, if you see, a lot of regions are under conflicts for some or the other reason. And if our all complete sourcing is done from particular region, certainly we can get into some trouble. So it has to be, diversified from the geographies across, within the country and outside the country. Then multi-sourcing strategy. Establish the relationship with the suppliers for the critical item. We buy, the supply chain department buys from pin to elephant. And for us, the egg in the kitchen and the stent in the cath lab is equally important. So that's the diversifying field that we operate in. Then nurturing strong relationship. During COVID, this has come as a very important factor that the partners who are, so it's not a typical vendor management, but it's a partners. So the partners who are having strong relationships actually supported the hospitals. So we have to nurture and build the open communication with such supplier, and it has to be collaborative. It is not that win-win situation, it has to be win-win situation and not only one-time transactional situation. Value-based procurement. This is also gaining a moment nowadays, that it has to be seen in terms of how you can partner only not from the supplies, but on the service support also. Long-term partnership, yes, again, it should not be a one-time transactional effort with the vendors, but it has to be seen how, they can be partnered for long time. Then building resilient inventory management, I think Dr. Sanjeev has covered this, but the replenishment of the inventory has to be so dynamic, and it has to be monitored in line with the consumption pattern. That will give us more predictability of how we can manage our inventories. Keeping up to date with the latest legislation. Imagine you order a stuff, and when it lands in India, you realize that item is under restriction. Just like a lot of PLI regulations are coming in, or there is a lot of CDSCO approval that is required nowadays. So the department has to be very clear about the latest legislation, and that investment has to go in terms of education and, even if required, taking some legal guidance from the market. Again, adopting a sustainable approach. So we should not be depending nowadays on the single sources. It has to be circular supply chain, and just like buying a reusable product or recyclable product, that also has to be incorporated into the, just like tissue paper, for example. Rather than buying the virgin material, you can go in for the recyclable material and ethical sourcing. So I would say that the presently world situations are combining to form what we call as the storm of disruption for supply chain, and the present situation will keep testing the agility and the flexibility of supply chain managers across the world. Thank you.
Thank you, Sachin. It was very well enlightened us with the risk factors and risk reduction, not just COVID, entire our day-to-day life. Also, he has told like geographical location-wise how we manage multi-strategies. And one of the very few we come across like imported medication, something we got from foreign countries. Then what is the legal requirement? How do we approach status quo and get those things? So now, since the Rio Summit in 1992, the paradigm of the corporate environmental responsibility has shifted. It has become very extended in terms of how we are taking this environmental regulation and taking up proactive measures to have a very world-class supply chain, not compromising the environmental impact. So going forward to the next session regarding how do we sustain this healthcare operations and making the greening of supply chain with minimal impact on the environment. So I would request Ms. Aditi Jairam, who is a project officer in Geneva Sustainability Center, to take forward the next session. Over to you.
Thank you so much. I wanted to say thank you so much, sir, for setting it up very appropriately for me to be able to talk about a sustainability approach. I also really appreciate this room. It's a lot easier to be able to see people, and standing behind a dais can be tricky for someone as short as me. So as I was saying, my name is Aditi, and I work for the International Hospital Federation. We are a membership-based organization that's based out of Geneva, and we essentially work with hospital leaders. We've actually been around since 1929, so we're older than the WHO itself. And within the IHF, I work with the GSC. So my job is to be able to help and support healthcare leaders become more sustainable within their communities and their journeys in terms of saying, okay, what is it that we can do to help support reducing carbon emissions within the healthcare sector? So here's my biggest takeaway for today, and I'm giving to you right up front, which is to say what we buy will give us ideally the greatest opportunity for savings and decarbonizing. And so what do I mean by this? So when you see this, it's a pretty busy slide, but I want you to focus on the little purple sections, right? So carbon emissions itself is broken down into 3 sections. It's called 3 scopes. So your first scope is what's being produced on site. So let's take the example of, say, an ambulance. Right now, if the hospital owns the ambulance, then the emissions that are directly related to the operating of the ambulance, the fuel used by it, falls under scope 1 emissions, so direct emissions. Now, scope 2 is anything that's indirect. So for example, the electricity that's used within the ambulance, that has been purchased elsewhere, and so that falls under scope 2 emissions itself. And so it's indirect. And scope 3, which is all these little purple sections, is everything else. So right from the fuel used to manufacture that ambulance, to any of the materials that goes into constructing it, and all the waste that comes from generating all the operations within the ambulance itself, all of that falls under scope 3. So it's really very extensive. And oftentimes within the healthcare sector, we like to say, okay, maybe that's something we don't really not need to touch. Let's just look at scope 1 and 2, and we don't really need to really address scope 3 because it's so vast and extensive, and in many ways overwhelming as well. So what we're here to hope, what we're trying to do is to say, okay, what does it mean to start moving towards a low carbon, equitable, and resilient healthcare system? And the idea really over here, what I might take away from this is that it has to be a collaborative engagement. Of course, all the other topics have been touched upon by the previous speakers, but the intention over here is to say we need to get started, and we really can't ignore supply chain and the emissions associated with it anymore. So at where I work, we've developed a tool called the Sustainability Accelerator tool. Now the tool itself is a dashboard where what you get to do is, as a healthcare organization, it is identify where exactly the gaps are in the way your carbon emissions are currently being produced. Now, we've rolled it out across a whole bunch of countries. There's a lot of work that's gone into identifying the kind of KPIs you need to be looking at. But my biggest takeaway is that, okay, we have 3 specific domains. We look at environmental impact, we have health equity and well-being, and of course you look at leadership. Now, let's look at procurement and some of the data that's come in from 33 different hospitals. If my slide will allow me to change it, there we go. From 33 different hospitals across 15 different countries. And as you can see, great work being done in leadership and governance. Also, fantastic work within the health equity sector. But environmental impact, as always, is taking a bit of a beating. And as you can see over here under the subdomain, the one I want to highlight is the one in the dark blue, which is once again procurement and supply chain is an area that does need to be in focus within the healthcare sector, and leadership really needs to start turning an eye towards what that looks like. So what is it that we're hoping to do over here? As the previous 2 speakers were talking about it, we said, okay, we need to start engaging our suppliers, but we also need to start talking to our clinicians, because oftentimes the demand comes from what a specific doctor wants, right? And how is it that we go about making that joint decision-making process? This really does require the input of everybody in the room to be able to make that right decision. And there's a fantastic amount of training and education that has to go into place. You also want to make sure that you are doing a fair bit of continuous monitoring and engagement to ensure that you're looking at what your carbon emissions look like. Now, actually, let's go ahead and put it to test. And there's a couple of examples over here that I want to be able to discuss. So the first one, which is one of my favorites, is this hospital in the UK. It's called the Great Ormond Street Hospital. And they have a special needs and childcare unit, the pediatric unit itself. They realized that they were buying over 200,000 pairs of gloves, non-sterile gloves, every week, right? And so when you realize that you really don't need that many gloves, they started to kind of reassess the work that they were doing. And they went through this very extensive process where they talked to their nurses, they talked to all the allied health professions and said, okay, what is it that we can do to start changing this up? And so they went through extensive training. They got a lot of feedback, and eventually, over a period of 9 months, they were able to reduce their glove consumption by 21 tons. Now, if you are a visual learner like I am, 21 tons is the equivalent of 3.5 Tyrannosaurus rexes. Okay, so it's a lot of gloves that they managed to save. The next one is about how there's clinician-led change, again within the NHS, in moving away from the use of desflurane. So now we know carbon dioxide is bad for the environment. Desflurane is 2,500 times worse than carbon dioxide, right? And so every time you use it under anesthetic practices, it does have a massive impact on the environment itself. And so they went ahead and said, okay, this is about 2% of our carbon emissions within the NHS. What is it that we can do to start addressing this? And so they went on to, again, this is clinician-led change. Let's not forget that. And so they went on to say, okay, you know what, we want to reduce it and only use it in an emergency purpose. And over a period of 1 year, they were able to reduce emissions to the extent of being able to power 11,000 homes. That's how much reductions they were able to see. So as you can see, the takeaway from this is that you can see change. So you can see behavior change, which is a positive impact. You can see change in the way your procurement purchases can have an impact. And the best part, there's a ton of savings to be seen, right? Again, over here, to kind of throw back to what my previous 2 speakers were saying, which is to say, let's have these conversations with our suppliers. We need to start engaging with them. We need to let them know why we're doing this, because there's no point in making demands without getting them to understand why is it that their input and their intake is also just as important. Their buy-in is so important, right? And it's about setting expectations. It's about letting them know that we're in this journey together, because honestly, climate change affects everybody, whether we're sitting over here in Delhi or from my hometown of Chennai, as he was very explicitly stating, it is tricky to get around, especially during heavy rains. What is it that we need to be doing in terms of engaging our suppliers and working through that? There we go. And so the way I would see it is, oftentimes we sit in a room like this, we're like, okay, all these decisions tend to take place at the at the leadership level. What is it that I can do? This has very little to do with me. How am I in this, in part, how is this my decision making over here that comes into play? And the way I like to see it is, I think every single person in this room is a healthcare leader, because you have the opportunity to be able to look at your workplace and say, okay, what is the one thing that I can make a change? What is it that I can talk to my supervisor about and implementing a change? Whether it's as simple as getting started with, like you were saying, using recycled paper. Maybe you're doing a better job of turning off some of those lights. So little quick wins. Maybe you set yourself up for a project and say, okay, over the next 9 months, I want to see how much reduction in paper usage we've seen, right? There's an excellent example on how you can transition to more organic, cleaner supplies for cleaning itself within hospitals from the University Hospitals of Geneva. Anyone who's interested, please reach out to me. So those are quick wins, as I'd like to see them. But then you can also start looking at short-term and longer-term goals towards transitioning towards a more decarbonized, more resilient supply chain as well. So my big take-home messages. We need to start thinking about things from a more cyclical process. It's about saying, I'm buying something today, but when I throw it away in the trash can, it goes somewhere else. Just because I don't see it doesn't mean that it stops existing. It goes and lands up in a landfill, which affects someone else's health, and then they end up at our hospital because of the way we are disposing things. And so it's about reassessing how it is that we're getting rid of things, because waste is not just waste because it's gone away. Waste lasts a lot longer, because just because we don't see it doesn't mean it stops existing. This is, again, as I was mentioning, a collaborative process. We do need buy-in from everybody. Everyone in the room has agency. Everyone in the room has the opportunity to make a difference. And there's always the need for continuous improvement, as is with any case. And education and collaboration really is going to help us get there. So thank you so much for your time and attention. This is a bit of a shameless plug on our end. We do have our World Hospital Congress that's happening later this year. And if you have any more questions, we'd love to continue this conversation over there. Thank you so much.
Thank you, Aditi. Thank you, Aditi, for detailing out on supply chain and how nicely is been told, like how to start, how to get it started in the organization. Even the simple thinking, which starts from the buying of the thing, and you start thinking of how do you discard the waste. So green is a process, not a status. And what is the use of a hospital if we don't have a planet to put in on it, decent planet to put in on it? So there's a very famous quote when it comes to environment: take care of earth and it will take care of you. So not stopping you between the very important part of the session, that is your question answer. When you have such a very debatable and talkable and discursive topic, one talks about the building of resilient, lean, agile supply chain. Another talks about the strategies, risk reductions, how do we handle this, and the not the last and the least, which is very important, how do we prevent the environmental impact when we handle the supply chain. So going on to the favorite session, we are in time. We have still 15 minutes for the question answers. So let us make it more interactive. Questions from the audiences. Yeah.
Hi, my name is Amit Arora, and thank you for this thought-provoking supply chain conversations which you all had. My question goes to Sir Dr. Sanjeev. Like you started with explaining the complexities, especially after during the COVID times, and then so my question is, like how we see right now the Instamart delivering the ingredients, the home-based materials in just 5 minutes. Today morning I had an experience of lovely having a breakfast, just 5 minutes delivery at my home step, and then I'm here. Then what step would you took? You spoke about the external lead time complexities with the vendors, but then when we talk about the internal lead time, what step you took so that the medicines which are there lying at your stores inventory levels and it has reached to the on the bedside of the patients in just few minutes. So any AI methodology or any new techniques or any new intervention which you did so that it reaches to your patient in just few minutes. Have you ever explored anything new? Or
Thank you.
very nice question. Basically, you want to make my pharmacy Blinkit right? That's what you are looking at. Luckily, if you see the hospital ecosystem, we have built in such a way, you have a crash card, so those medicine which you require in 5 minutes are there. In hospital, you have impress stock, so that even if I supply in half an hour your painkiller, nurse will pick up from that ward and give you painkiller so that your pain can be immediately. We have already built those resiliency into this, but at the same time, I don't want to run at such a speed that accident will happen. So my priority is not only speed in the supply chain, safety is also my priority. So how balancing that? I don't want to delay anybody's medicines. Somebody is having high fever, I don't want to delay his paracetamol, but I want to ensure that he get the same paracetamol of 500 or 650 what he deserve, right? So making that balance is very, very important. How it can be done? One is basically where you need to look into where the delays happen. So if you are using paper-based system, so it will take time for nurse to realize something has happened, and then she need to put in computer, goes to the pharmacy and your medicines. So start with CPOA. So the time doctor decide that this medicine is required, it hits to your pharmacy, and it becomes your blanket, and then you deliver in 10-15 minutes. You lot of devices are available for doing that. Pick up that, right? Now you have robots also doing your dispensing. You can look into that and sending this. There are technology available from your pharmacy to the patient room. You can send those medications, but look into your needs for putting so much money. Do you really need that? Is it your real problem in your hospital? Look into that, because they are with lesser money, environmental friendly things, right? You can achieve the same thing. Thank you.
Yeah, thank you. Next question. Yeah.
Actually, I want to ask ma'am.
Yeah.
Ma'am, I don't know whether you will go to the detail or not, because you have taken one example. That example of one hospital where they reduce usage of gloves up to 21 ton. That is a huge quantity which they reduce.
Yes.
So is there any strategy how we can reduce, like some consumables like gloves or any other consumable which we use frequently in hospitals?
Absolutely.
So is
Sorry, go
there
ahead.
any strategy behind that particular scenario?
Yes, I believe it's education, training, and more education. I think when we talk about decision making itself, my struggle often tends to be that you have this like lots of conversation happens at the upper echelons. You have your leadership doing a fair number of testing and things like that. But then to me, at the end of the day, if it doesn't trickle down when I'm seeing patients, if it doesn't trickle down to me, then it's really pointless, right? And I believe you cannot over communicate so much so that you talk to them again and again and again about what is it the pinch points are. So the way these guys did it was to say, okay, let's go through an entire day, let's identify where are the different ways in which you're using these gloves, and let's actually assess every single situation where you truly need it or not. And then you go through the process of saying, okay, as you get rid of the gloves, you have to go back, you have to wash your hands, all of these different elements. They tried to start looking at the different pinch points and said, let's start addressing that. And once that got taken care of, now it does take time, like behavior change doesn't happen every day, right? I'm sure if you've tried the habit of drinking more water, it takes a little bit more than you think. I tried going to the gym, it really doesn't stick as well as I wanted to. But the idea is to be able to say, what is it that we can do to help initiate that change and sustain it over a period of time to be able to make that true change. And so this did take them some time. It didn't happen overnight. And so the strategies itself were to be able to educate their employees, especially the nursing staff, in terms of saying, what is it that, do they truly need the gloves? And the two is give it a little bit of time, give your project a certain, X amount of time to be able to see it through. And then go back and reassess. So do a pre and a post to reassess, to identify how much change has truly taken place. And if not, maybe we go back and make certain tweaks. So
Yeah.
One One more thing, ma'am. The example which you have taken, how many bedded hospital it was, and the data was for 1 month or 1 year?
This data itself, in terms of
The example which you had taken.
so the data is from 33 different hospitals across the globe, right? So again, the number of beds will vary. And this is the initial data, which is to say it's a qualitative assessment. So the hospital itself sits down with the different leaders and says, how well are we doing in certain different areas across the 3 domains? So environmental, health equity, and leadership. How are we, so it's a self-assessment, right? You decide how well you're doing or not doing. And most people have come back and said, yes, we could be doing a lot more within the procurement and supply chain areas itself. So,
Thank you, ma'am.
I want to add one more thing regarding the point what you asked. Apart from education, which happens on the long-term basis, there are some fine strategies that we can do in the back end, like auto-filling of the toiletries in the room. This is one thing that we have implemented. By nature, if you keep a lot of stuff on the table, the chances of wastage are more. So we made it demand-based. One was that. Second was we reduced the size of the toiletries. So these are some. The third was the reducing the size of the sauce sachet. See, if you look at it, if you have a 20-gram sachet or a 10-gram sachet, we will not completely squeeze it. So rather than reduce the size of the sachet. So these are small strategies on ground that we implemented. So education will go in long-term basis, but these are the strategies that the supply chain managers do on the ground.
More than education, basically.
I have one question.
just to quickly to be able back, really it's a very interesting topic. But real quickly, it's also what he talked about is behavior change, right? And so oftentimes, so there's this one hospital that talks about this example where, you go to the cafeteria and you want to order something, and anything that is, I guess if you're looking at a burger, they make it a little bit more harder to access. Versus, say, you have fruits and vegetables and things that are truly actually good for you if you keep it in the front counter, a little bit more easily accessible. Sort of like that stick of gum that you buy just at checkout. They have those little mints and all that. So what if you switch that out? Instead of candy, you had something else, right? And so constantly giving people easier access to things also very subconsciously does change their behavior in the long term. So
Yeah.
I have one
Access for
question
good
as well.
things.
Hi, yeah. So my question is for Mr. Sachin, as I take care of dental operations, and the supply chain is a topic very close to my heart, because I'm struggling to achieve some sort of metric into it. So if I have to conclude, the unanimous statement that came across is we need to diversify our list of vendors. Whereas in my experience, I have seen the more vendors that I had, it led to the tat of maintenance, and a chaos and the real downtime of my. For example, let us take dental chairs. So we have like a ton of at least 8 to 10 of dental chair vendors, and we do not have a specified vendor which we suggest that for our partners or for our Apollo Dental franchisees, we are going to just let you have only them. So they have engineers not available at all locations, so on and so forth. Okay. I hope I was able to convey my message. And then I also came across a podcast I was hearing where Indigo Airlines, why it's the only one of the rare airlines that runs in profit. So they actually, what they did was, so they have only one vendor where they buy their aircrafts and all their maintenance equipments from, and they reduce for every flight 10 minutes. Okay, in the maintenance when they are on the runway, be it cleaning, flushing, so on and so forth. And that 10 minutes led to approximately, my numbers could little vary because I'm aging and my memory to remember that. So some 3 to 400, crores of business they could increase just by saving that 10 minutes on that runway. And that was done by, pit stopping on just one or max 2 vendors. So how do we justify this, this list of vendors? Yeah.
So I would suggest that we should not spread too much thin on this. That means, see, if I give you example of sutures, there are at least 10 to 12 sutures brand available in India. But then we go for those 5 good quality brands. those vendors who are having credibility in the market, and we do regular assessment of their performance. Regular means the yearly assessment. So like if you have 10 centers, you can take feedbacks from your individual centers in terms of which are the vendors performing good on these parameters, be it quality supply, be it time, be it the service support. So if you do the assessment, performance assessment every year, you will be able to know which are the vendors which are falling in there. And if you list the vendors, multiple vendors for multiple location, then this problem will never get over. So I think the good vendors and the performance, these two parameters need to be taken care of.
I just want to add over this. If you depend too much on one vendor, I gave example of N95 mask, which we used to depend on 3M. N95 mask mean 3M N95 mask. That was the one thing. And when COVID strike and all of us needed 3M, right? That and it's good if you want more profit on lean and depending upon one vendors. But think about your hospital will stop functioning if something happens to that vendor. So we need to balance that approach, have alternate. Your margin may be little bit vary, but you will have resilient supply chain, right? Your agility of supply chain will increase if you do that. Margin may be little bit, yes, maybe, but long term it will be much better. When shock comes, it will go down, and ultimately, depending upon one vendor, you may be in loss rather than in profit.
Right. Thank you so much.
Any more questions? We have another 2 minutes. Yeah, one last question we can take.
My question is to Dr. Sanjeev Sharma sir. Good afternoon, sir. I want to know what kind of metrics we can use for supply chain agility.
Thank you for a good question. As we were talking about, don't depend upon one source of supply chain. Very make it multi-source. You need to have here in pharmaceutical supply chain. Don't depend upon one manufacturers. At least two different alternate of that you have, so that there is a problem with, say, some drug recall happens in that, and you will end up in having not any drug in hospital. If you buy, you may be earning more from one vendor because you are given exclusive right. He might have given you more margins, but problem may come. Second is the vendor from where you are getting this particular drug, how far away he is. If on that particular road, what are the risk factors? I gave example of Chennai, where literally sometime 4 or 5 days of torrential rain impact your supply chain. So in your local area, like in Delhi, right? If you say we have that farmers issues and some roads were blocked, is your vendor in that particular area? So that kind of risk, what is that risk? You need to evaluate and have other alternate vendors. And very important is have your critical items list, increase their supplies of that, so that your operations are never hampered. These are some of them. And of course, using technology, having good relationship with vendors. As Sachin sir, he will be able to tell this raw material is in shortage, please increase your stocking if you have that good relationship. So probably that may help.
More questions?
Miss Aditi, I just wanted to know whether IHF has hosted any, any educational resources for, in the interest of audience, so that we could go up and look for it, for some informations like this GOSH case that you told,
Right.
or the clinician-led practices. So, is there any, repository that we could refer to on IHF?
Absolutely. We are
Great.
full of resources, and they're all freely available on our website at ihf.org. Don't go to ihf.com. That's about the International Handball Federation. We are ihf.org. And there's plenty of resources within the Geneva Sustainability Center itself. And there's a lot of tools that hospitals can use. So go ahead and give it a look, and feel free to reach out to us if you have any other questions. Thanks.
Thank you.
Yeah. So ends are always not the bad thing. It's just like it means something else is going to begin, something good is going to begin. Until the next time, let's carry the momentum. So with this all, I conclude today's session with such an insightful discussion on supply chain resilient, how to build resilient, agile, lean, and strategies, risk reduction and balancing, and the environmental impact, and making the greener supply chain. So let's end this today's session with a round of applause for the speakers. Thank you all of you.
Thank you, everyone. I request our session chair to please give the gifts to the audience who interacted. Yeah. Excuse me, ma'am, I don't know your name, so please. Poonam, hi. Yeah. And sir, please, yeah, onto the dais. Thank you, each one of you. I would like to thank our sponsors, Dozy, Fujifilm, and Pfizer. Request everyone to please take their seats. Sachin, sir, please take your seat. Not letting you go out. We are rolling into our next session. Please take your seats. We have everyone. we're starting our next session. Simplifying processes while amplifying the experience. While this is the topic of our next session, this topic plays a key role in achieving operational excellence in healthcare, reducing complexity, streamlining workflows. I'm particularly curious to hear the discussion about this topic. While this might, really sound, let us hear from our speakers whether they have a groundbreaking AI solutions or solutions as simple as, putting up some boards for better navigations. What sort of process change can amplify the experiences? I'm really looking forward to that. For the same, it's my honor to welcome our session chair, Dr. Kiran Shingote, Unit Head of Apollo Hospitals, Navi Mumbai, onto the dais. He has been pivotal in advancing healthcare services and patient care. Yeah, okay. Under his leadership, the hospital has earned accolades for clinical excellence and launched specialized facilities like the Advanced Liver ICU. Please join me in welcoming Dr. Kiran Chingote. Please have a seat, sir. It's my pleasure to welcome our first speaker, Mr. Jagdeep Singh, onto the stage. Mr. Singh is the director of SPS Hospitals and has been instrumental in making world-class healthcare accessible across North India. As managing director, he has led the hospital's growth, clinical advancements, and quality initiatives, securing 4 JCI accreditations. A warm welcome to you, sir. Please have a seat here. It's my honor to welcome our second speaker, Dr. Tausif Tangalwadi. Excuse me. Thank you. Vice President of Operations at Red Health. Onto the dais, Dr. Tausif, a seasoned emergency medicine specialist with over 18 years of experience, is currently the Vice President of Operations at Red Health, India's largest pre-hospital care provider. Have a seat, sir. A warm welcome, yeah. It's my pleasure to have our third speaker, Mr. Munish. He's not around? Oh, okay. It's my pleasure to welcome our fourth speaker, Mr. Karan Puri, Chief Executive Officer of Apollo Proton Cancer Center. With nearly 2 decades of experience in hospital operations, sales, and facility management, he has played a key role in driving organizations to market leadership and spearheading groundbreaking advancements in cancer care, including India's first total marrow and lymphoid irradiation program. His expertise in optimizing workflows and leveraging team strengths continues to set new benchmark in patient care. A warm welcome to you. Please have your seat. Thank you. Over to you, sir.
Thank you. Hello, can you hear? Yeah. First of all, let me tell that photograph is not mine. I would love to be that person. In terms of monetary gain, I'll be most happy because he earns highest as a surgeon. Is Dr. Rajesh Shinde. He's a colorectal surgeon in Apollo Hospital, Navi Mumbai. Setting context, let me tell you first, the speakers are varied. Mr. Karan represent maybe a first and the only center in India who gives a specialized care in proton. So you will have a views which is completely different than the routine hospital, routine multi-speciality hospital. We have Dr. Tausif who handles again a biggest private ambulatory care service which caters almost all state in India, right, Dr. Tausif? And he represents medical side, so we'll be again understanding from him exactly how process or simplifying process will help to enhance the experience. Again, Mr. Singh represent the multi-speciality hospital, biggest in Ludhiana, so he'll give us the broadest perspective of experience coming to the multifaceted, multi-speciality hospital. To set a context again, just imagine that everybody among us or somebody who is first time entering in hospital, just see what happens. What we see, I'll create a touch point. If you see somebody accessing hospital from outside, be it be call center, be it be our website, or be it be our app or something, or somebody entrance in the hospital through a security channel or all that thing. What we see is
is a touch point. What we see exactly that patient get hustled, they may not have access to hospital through a right channel. What we see, sometimes doctor struggles to get the report, they struggle to compare the report. What we see, a nursing staff struggle to go on floor, their core activities to go and give the care to the patient, but they struggle in paperwork, they struggle to match the report, they struggle to indent, they struggle to issue. Same for housekeeping, same for front office. So what our aim today, if you really consider a patient as a center and experience as the output, what I am expecting out of this session is all three of them guide us how we are going to simplify the process to amplify experience. Starting with, I'll request Mr. Singh to start his presentation first.
Introduction. Have the presentation, please. You know, before this comes on, the power, the moments is gone. So that's what happens. You know, all the right things happen when the wrong people come to speak. So I would say, what is power of moment? It is a particular incident, it is a particular interaction which leaves an indelible mark in your memory over a long period of time, and you can't shake it off. You live with it. You live with it till the time you're living. The year was 1998. I was traveling to the UK because my mother-in-law was very sick. And Delhi airport was not what it was now. It was a huge crowd. It looked like a Hapad bus adda. So it was very difficult. So we were under a lot of stress, me and my wife. So suddenly we saw somebody from the British Airways looked towards us and said, "Something is wrong somewhere." "What is wrong?" I said, "It's just that my wife told him we are under distress." So she took us aside, gave my wife a chair to sit, and she said, "Don't worry, let this rush clear off. I will personally guide you there and leave you and help you get to your seat." We have never met that person. We have never met that lady again, but I still remember her name, Swarna Tuli. In my lifetime, I'll never be able to shake off that name. So that is the power of moment. That is the power of touch. That is all for all hospitals need to get to this. This power of moments is something is wrong somewhere, or I don't know how to run it. Yeah. Yeah, yeah. There's a famous definition of what is customer experience, and it's given by Patricia Seybold, who's one of the biggest authorities on customer experience. And she says, good customer experience should just be the way to do business. After all, what are you? What are we? Nothing. If there are no patients, or they are dissatisfied patients, or they have other alternatives, and they choose them over us, we are nothing. So it is that experience, it is that one patient which brings that bread and butter on our table, bread and brings food on our table. So every experience has to be taken from us, that this is all more what we can give you, and for him, a memory, we give him a memory for a lifetime. The next one, sir. We go on to the previous one first. Yeah. The moments in patient care, interpersonal interactions between patients and medical staff that are meaningful and memorable. They're leaving a long-lasting impression in our minds, and this is all what is all experience about you. It could be your staff experience, it could be your people who are delivering care, and they're making it worthwhile for each one of us. Next, next one. The next. Yes. Now this is the quadrant. If you see, what are the essentials? There is relevance. Usually they say there's relevance, convenience, reliability, responsiveness. But I say most important is responsiveness, because that is an amalgam of all the other three. When you are saying responsive means you are sensitive. And experience, if you are not sensitive, it means nothing. So this responsiveness, how it reflects, your responsiveness reflects two things. It represents the agility of the organization to recognize that this is what is required. Responsiveness means a finer, sensibility which your people who are delivering that care, they have that sensibility that, we need to do this for the patient to make it a everlast for a better experience. Now, see, the challenge for the hospitals is relationships are becoming very, very transactional. Short stay, single day surgery, come, get treated and go. Where is the time? Of course, you have long stays, but your challenge is much more because you are dealing with people who are, sometimes hovering between this way or that way. So your challenge is much greater. But for people like us who are not handling that serious patients, short duration stays, when a person, like if you see a person going to a bank, he's just got to get a draft made. So it's a very short duration. His criteria of evaluation is going to be very, very high. I came at 12:30 and it is 12:45 and I'm still not. Those 15 minutes for him are everything. So for the organization, because it's a very transactional relationship, he's going to come, get the draft, probably not even come back because probably go to the other bank. So this is a very big challenge which the hospitals are facing. And then when the duration is short, the wow experience time you will not get. How do you do it? Like we were lucky that we were going, there was time for the flight and she was able to gauge and she created that impression for us. But normally when it's so transactional, you will not have that time. And what happens is experience, the hospital organizations risk the reputation. Their reputation is at stake. They'll say, most of the people in Punjab, they will say, oh my God, nobody's met me. Now what? Now nobody met me is a very generalized term. But they say, koi milan nahi aaya, koi dekha nahi aaya, it becomes very difficult. Dr. Saab will know it. So people it is nature that your expectations from the other person are always are much higher than what you can do for them. It's always high. You will be able to walk 10 steps, but they'll expect that, you need to walk 100 steps. They themselves can't walk 5 steps, but that's what it is. Now, there are moments. So the next one. There is a very famous book, The Power of Moments, written by Chip and Dan Heath. They are professors in Harvard Business School. They usually write on change and strategy, but they've written this book about customer experiences. They consult companies in America. They are one of the biggest people consulting firms. So they do for John Deere, big tractor companies, and they do small healthcare companies advisors. So in this book, they've given an example of a person of Star Healthcare, which manages hospitals across America. And one of their executives' father fractured his foot, and he went to that hospital. Very good experience, doctor, nurses, very good. They took very good care of the people. There was a connect with those people while he was there. But suddenly that connect was lost when he was shifted from that ICU or OT area to the ward. Now, first of all, he was there in that place after surgery. He was there for 2 days, so there was some connect. Then he was thrown into a ward, like I'm using a wrong word, thrown, but that's what they've said, that he was thrown into the other place. But those people were not known to him. The caregivers were not known to him. People were walking in, walking out. So all the experience which was gained there was nullified there. And then on top of that, he had a fall. And he was picked up very gruffly by those caregivers who were putting him back on 3 minutes. Bad. So I'm bad, but I've never gone beyond my time. I'll finish it in that. So, yeah. So I've done 7 sessions, but I've never gone beyond times. I'll finish it off. So what is very important is that those people who are giving care are very important. See, healthcare is very difficult. People treat you, they give their life, blood, sweat, tears, bringing you back to health. Yet, the moment the patient steps out of that place, people forget them. So, there is a company, sir, if you could just scroll through, go down, further down, further down, further down, further down. Yes. So, this is a company in America. I can give more examples, not being a doctor, so they're more from the consumer facing examples. This is a company named Next Foods. This is based in Arizona. So if you buy, they grow a lot of cherry tomatoes and grapes. If you buy a packet in America, these small grapes and cherry tomatoes are sold in small packs. So you flip open the cover and you will see a face of many of these people who are there. What are these people? I will not even know who's the maintenance guy, who's the packaging guy, but that is the company's way of recognizing that these people are giving there, and they say that they are the beating hearts of the company. So what I want to say is, you have how many discharge summaries? There is in a discharge summary, there is a doctor, there is a nurse, there is a dietitian, there's a physiotherapist. There are so many people, yet we do not see them. So what I would want to do it is that let organizations, at least in a discharge summary, they'll say there could be legal issues, they will, case ho jayega or ye ho jayega. But what I say is, somebody needs to recognize those people, at least have somebody see off a patient. Now, the finance people will say it is cost. It is not cost. It is a permanent experience. You are helping get more patients into the hospital, recognizing those people. What is this food company? Somebody will not even look at those, he will take out the grapes or cherry tomatoes and throw off those packs. But the company has recognized, for the company means they say these people are our beating hearts. So this is very important. So for key meaningful moments, there should be there should be personalization, timeliness. In Punjab, there is a big problem. They'll say, I'm not saying all problems. In Punjab, there are good things also happening. But people say, if the discharge is delayed, it is discharge is 11:30 and it is, say, 12 o'clock. They'll say, you're wanting to make money, that you don't want to discharge. But before I end, I want to give you one example. We had an NRI who was there, who came to our hospital for treatment, and they said, my taxi has come and we've gone. It was taking a little time for his reports to come in. That is why it is probably an inefficiency on our parts. But we told him, fine, while you are resting, we'll take your wife for a blood test and a checkup. And we found out that that lady was heavily diabetic. If she would have walked out of the hospital, she would have been in all kinds of trouble. So I said, I am writing off your this half a day's charges, what you were saying, but we are making sure that your wife gets treated for her diabetes. We took her to an endocrinologist, took her follow-up from, and every year on New Year's Day, I get a message from him from Canada. Thank you for helping my wife conquer her diabetes. So, thank you. I hope I have not gone. There is time still? No, there isn't. Thank you.
I actually wish to say thanks to Manish. He has allowed us to go 3 to 4 minutes extra, and I think you burned that as well.
Burn that.
Oh, okay. Thank you very much, Dr. Singh, and I think we will come back to you after. Mr. Singh, we will.
See, every time somebody calls me a doctor, it reminds me of my failure. I was not able to clear the PMT exam.
No, but thank you very much.
Exam.
Thank you very much for putting these thoughts. It's important. I think you touched very important aspect of process flows and where human angles comes into the picture and the power of movement which needs to be taken into account. Thank you very much. We'll move to Dr. Osip to go ahead and have his presentation.
Check. My presentation, please. Right. Yeah. Thank you. Okay, so moving from in the hospital, thank you, sir, for a fantastic talk. So many anecdotes, really, really close to the heart. And I'm a very strong believer in the moments. I love interacting with people, and more so in the emergency when they have a, yes, and that's when everybody's emotions are heightened, and that's where you need to be at your best in those moments. And I love that about it. Right. I worked for a long time inside the emergency department. For about 20, 22 years I was there. But over the last 2 years, I'm outside the emergency department. I work in pre-hospital care very much. I hope they have my presentation. But I work in pre-hospital care. Now, emergencies, as you all know, don't start in the hospital. They start somewhere else, anywhere. It could be home, workplace, the roadside, somewhere where you least expect it. And care has to start there. And that makes the most difference because we all now know about golden hours, platinum 10 minutes, and how when you give the great care, we can make a big, big, big difference. And there's a big problem statement here. How many of you are confident that we have great ambulance services in India?
No, and I don't think so. No.
That's unfortunate because India has had ambulance or pre-hospital care service since 1982. Delhi started it first. CATS started in Delhi in 1982. 108 came about only in 2005. Started off in Hyderabad, now across 19 states in India with 20,000 ambulances. Yet we are not confident. Okay? Why? And how can we change these emergency response workflows? And then the presentation is not coming still. Okay? Right. So let me quickly preempt the presentation and go on. Yes? Okay. So, are we good? The presentation? Are we finding it? You want to go? Okay. Yeah, sure. There. Okay. So, I know these slides. I've done it 100 times, so I can do it without the slides as well. Quick question. Do you think we have enough ambulances in this country? Yes, no. Show of hands. No? Okay. What if I told you we have twice the number of ambulances that WHO recommends? And that's the truth. India has 2 times the number of ambulances than what the WHO recommends for a sizable population. But we're still not confident of great, ambulance care. Now, what is a typical customer journey in India? And hopefully the slides come back. I will show you those in pictures as well. Somebody calls or somebody has chest pain. How many of us know which number to call? Right? The people in the healthcare fraternity, a good friend, Nitin's here. Obviously, I'm going to call Nitin if I'm in Bombay. Okay, he's going to help me. I know that for sure. But those of us who are in the healthcare fraternity are lucky. We may know a number that we can call. But if you're not there, we will not know which number to call. And even then, if you're not calling the emergency department or the EMS service, and you call the hospital's line, how long will it take for you to connect to the emergency service? We don't know, right? We don't know. And that could be those precious 10 minutes or of your golden hour or your platinum time, right? That could be a problem. That is one pain point. Let's say you get through, the ambulance gets dispatched, okay? And then the concern starts. Is it on its way? Kahan tak pahunche? Where did you reach? Are you coming? How long will you take? That starts and that becomes a pain point, okay? And then they're on their way. And when they reach you, how sure are you that that ambulance that's come to you has oxygen, has the right equipment to monitor what's happening to you, has the right staff whether they can give CPR or not. And all of this is happening in the emergency situation when you need an ambulance the most, right? And then you regret. You wish you had prepared better for this. And that's the major problem statement that we have in India, which a few countries have tried to solve. For instance, Singapore, one of the best by far pre-hospital care systems in the world, wherein the moment a patient is loaded onto the ambulance, everything is getting transmitted. Vitals are transmitted, audiovisual connections are happening, times are being tracked. They are carrying mechanical CPR devices with them when they're going to see the patients. Small country, I'm thinking it's easier to do. Large country, how do we get it done? But there are other systems. There's 911, 999 in the UK, 911 in the US. So a lot of systems that's working there. Our question today, what does it take to build a 911 in India? And that's what we wanted to showcase with RED and what RED is doing. Okay? So that once that comes up, we'll go through the cycle of what RED is trying to do. First and foremost, what is pre-hospital care? We just talked about it. It's emergency care that happens outside a hospital. Who are the essential pillars of pre-hospital care? An ambulance driver, of course the ambulance, but an ambulance driver, yes. A paramedic, yes. The third and the most important part in what Sir talked about, moments, is the dispatcher. There's a third person called the dispatcher who's the first person to receive the call that you're sending out, right? So you need to call somebody and that person has to be smart enough. Ta-da, all right, whoa, lifesaver, okay? Hey, that's our lifesaver. So that you need to be smart enough. Oh, I have the slide. Thank you so much, Dr. Kiran, for getting the slide out there, okay? And that's the dispatcher, and we'll come to that. So this is what I was talking about. India has twice the number of ambulances. Those are the real numbers. And this is evidence. It's not something that you're hearing Dr. Tausif say. I talked about this entire patient journey, chest pain and how there's tracking, are you coming or not coming? And then the whole ambulance and the CPR and the equipment that's there with it. And then the golden hour. We know if you don't treat a patient during trauma, 30% will die in the first 1 hour. And that's 45,000 deaths that you can save, or preventable deaths in this country. 1.5 lakh people in India die every year from trauma. Heart attack, within the first 1 hour, if you treat them, 90% lives can be saved. The lives that are lost, preventable deaths, 90%. We know about brain and sepsis. Brain, more time, more brain gets damaged. Sepsis, every hour delayed, 8% more lives lost. 1 of 4 people with sepsis die. 25% mortality rate. Big difference you can make in the emergency, right? So how do we increase the efficiency of our emergency response? So what does it take to build 911 in India is what I was talking about. We started out by building the infrastructure. And that was very, very important. Like the 20,000 ambulances that the government system has, we are trying to build infrastructure across 25 cities in India. We have 500 of our own ambulances. We have what you call an Uber Ola-like platform where ambulances can partner with us, and that extends it from 500 to 5,000 ambulances. We have reach across 88 cities, physical presence in 25 cities, but we can do about 88 to 100 cities is what we currently do in India. And we are trying to keep our estimated time of arrival under 20 minutes. We've reached about 18 minutes on average. Our next goal is to reach 8 minutes. We're trying to do a flash model at 8 minutes is where we're trying to do. Oh, there it is. And then we built a fleet. We made sure we remove all the omnis out. We build in hygienic fleet. We work on the fabrication innovation. Red has brought out the first multi-purpose ambulance where you can use an ALS and then put a neonatal equipment into it, ECMO, IABP. We are making sure one ambulance can become multi-purpose, and a hospital does not have to spend for multiple different ambulances for a cardiac or a neonatal case. So one ambulance, change the equipment, and you can move on. And we build this complete system. So there's a triaging that happens. So the dispatcher is important because they do the triage. They tell if it's an emergency case or non-emergency case, an ALS should go, an advanced life support ambulance or a basic life support ambulance, and they do it. And then they triage and transport the patient. So this is very, very important, and we're working on all of this to make sure the response times are very, very quick. And then we got accreditation. Because what's to differentiate you from the next ambulance provider? How do you know? So what happened in India and why it became so unorganized and people were not able to get good care? The ambulance driver earned enough money, bought an ambulance. Where's the quality? Where's the training? And that got kind of lost along the way, okay? So we got accreditations done to show that ambulance care or pre-hospital care is not beyond accreditation. If hospitals can get accreditation, so they can. So can the pre-hospital care service. And this is what we want you to look at. Whichever ambulance provider you're using, are they accrediting themselves? Because that will tell if the equipment is calibrated or not. So we are Asia's first JCI, private medical transport organization with JCI. We have ISO for data security. We are HIPAA compliant. And more certifications coming along the way that we have. And then we move on to innovation. So that was basics. That's essentials. That's hygiene. How do you become better? How do you better the workflow? That is important. Calling times. So we have faster response times. Even today, if I get you to call, I'm assuming the call, our number is 911-4911911. If you call, and when we have time, I'll ask you to do that. I'm assuming they'll answer under 2 seconds, at the max 15 seconds, which is the best in the world. That's our call response time, because we have made it very streamlined, and we help hospitals also with this. We give them an emergency number for that. We've changed the paradigm. Instead of a linear flow, we do a parallel working. We ask, assign, and dispatch at the same time. So the ambulance is sent while more questions are being asked. We're not waiting to get all the data and then send an ambulance. So the dispatch happens very quickly. We are also tech-enabled. All of this happens on a platform. Hospitals have this problem. People have this problem. The ambulance driver sitting there says, "ये hospital मत जाओ. यहाँ बहुत पैसे लेते हैं. ये hospital last time लेके गया था. You know, something happened." There's nothing of that sort anymore. The pickup drop location is fixed, and that's where it is. The ambulance driver or the paramedic is not allowed to deviate. The patient has a choice as to where they want to go at the start of the trip. No confusion on the way, right? So that doesn't happen anymore. And we can make this completely, automated. This is the world's first auto dispatch system where the machine can assign the right ambulance once you triage it appropriately. Right. And then a lot of questions we answered. The devil is in the details, like Sir rightly mentioned. The common questions, kitne sawal puch rahe ho? Ambulance to bhejo. So we will send the ambulance, okay? And then, kahan hai? Pahuncha ki nahi pahuncha? Acha, kahan aana hai? No direction checking, right? So we know exactly location tech we use. We share on WhatsApp. There's a one-stop check link that you can do an SMS and then get the landmark. And then money, cost-conscious society. So in an emergency, how can we ask for money? So we're building solutions. A lot of hospitals are very kind enough to say, don't charge the patient, we will take care of it, don't worry. And we're very happy, right? And then there are insurance providers we're trying to work with. Corporate companies want to protect their employees. So we're working with solving all these questions. This is an entire ecosystem we have today. This is not futuristic, this is today. We have a customer-facing app, which allows them to get protected. We have a Red OS platform where all the cases we do, which is about 12 to 15,000 transfers a month, is documented. We can pull out any case to do an RCA on it. We have a driver app, a paramedic app, where they get it and they enter the data, they accept on it, so our turnaround times as well as data tracking is there. We have live vitals transmission called SyncX. We have Salus EMS where the ER doctor can check and have their 5G connected ambulances. They know how many are going out, how many are coming in, what's the case. They can find out from that. And once we reach the hospital, we can get all of this into a PDF and add it to the EMR. This is currently existing in our system. We've built all of this. An entire ecosystem, which is tech-enabled, is what we have done. And then we have Salus EMS, like I said, a management software that, fleet management software that ER doctors can use. It's completely built in so that your team, your code blues, your code stroke, code trauma can be announced 15 minutes prior. The team's ready, patient comes in, your door to needle time, door to scanning time, everything is reduced, right? So that's what we're doing with the 5G. Safety, we use a lot of AI. So when the driver's driving, are they driving rash? Are they fatigued? Seat belt? Are they wearing seat belt? Are they eating something, drinking something? All of this is AI enabled. And the moment any alert happens, there's an ambulance operations manager. We have a clinical operations manager who's sitting here. Shiju's right here. So they get an alert and they call up and ask what's happening, right? So we're very high on safety as well. And then distance is no longer an issue. We can transfer anywhere from anywhere in India or abroad because we have air ambulance as well. So it's become a one-stop shop. So it's air, train, road. We're doing a lot of foundational work to ensure the right systems are built in because that's the core business that we do, okay? And we also do teaching and training, because emergency response workflows, you can have enough money, you can spend on tech, you can spend on ambulances and equipment, but if you don't have trained manpower, what are you going to do? So we also have an academy that we are now actively promoting. We have started in association with IHMR, that's Indian Institute of Healthcare Management Research, India's first management course in pre-hospital care. So it's not just about BSc and diploma and life support courses. We're also getting them into management streams so that there are fantastic administrators who can come in and run this very, very professionally. And that's what Red Health is trying to do. Well, that was really, really quick, but why I wanted to show you this is you save more lives. So when I showed you 30% of people can be saved in transit, when you do all of these, we save 20% of that 30%, meaning we save 2/3 more lives. And that is why this all becomes important, because as fantastic as we may be as doctors and nurses and all healthcare providers, they don't reach your hospital alive. How are you going to save them and get them better? And this is where these innovations come in. And these are some of the hospitals that trust us, some of the big names in the country. We have Apollo here, who's a very, very strong supporter. Nitin's a super strong supporter. Dr. Kiran is. We are there with them. Of course, we have other hospital chains also. There's CARE, there's NH, there's Fortis. Medanta now has joined us, Paras. A lot of them are now trusting Red to come in, partake. And it's a growth. I'm not saying we have got it right perfectly, but we are definitely keen on making it the best, if not comparable with the rest of the world. That's what we're definitely trying to do. And we can't do it with hospital support, because let's face it, even today, you're calling hospitals, not the ambulance service. But there's no confusion. We know where we are going. That's what we want to do. So thank you so much for the time. And let's make our roads in sky safe. Thank you.
Thank you, Dr. Sip. Thank you very much. I think it's very, very insightful. You have given us complete glimpse of what happens when you run the largest private ambulance services with the complexities. When we say when you are on road, you don't know what is going to happen. Only thing which is helping you to be as robust as possible is how we have simplified the process, how we have put the AI in that. What we heard from sir is about movement and the human touch. Now you're driving the processes through the technology, through AIs and all that stuff. I think definitely it is going to take a lot of innovation going forward. Coming back to a core point now, we have heard ambulatory services, we have heard about movements, power up movements and everything. What we are now going to see, just imagine what it requires to have a simplified process for a doctor, for a nurse, for housekeeping, or for a technologist. What they require for doctor, what they require the right time for. They want a patient coming on the floor on right time. They want their juniors to prepare the patient coming on spot on so that there is no error. For what nurses required is support. They require indent on time. They require housekeeping preparing the patient on time. What they required is a system that does not require to enter a lot of data. So what Mr. Karan is going to help us to get through the streamlined workflows to improve the patient experience today through Proton's experience. Thank you.
Thanks, Dr. Kiran.
Stage is yours.
We'll go to the presentation, I think, 45, 50 seconds later. I just want you to visualize something in front of your eyes. I know most of you have been here from yesterday. Hands up. Me also. Now imagine you came to this venue, there were no signboards, there was nothing in this venue, and you were just told go to hall number 15. No bus, nothing to take you from location A to location B, and they just say go to room number 15. And then you land up at room number 15, and someone tells you, Hope session is in room number 13 on the 3rd floor. What will you do? Or what will I do? I'll say, okay, no problem, where's the escalator? I'll go to room number 13, 1st floor, 3rd floor, and I end up in that session and enjoy my session, which most of us are doing. Now I'll ask another question to all of you. Right now, health-wise, how are you all feeling? Anybody having body ache, temperature, headache? No? We are in the red of our health, pink of our health, right? Now visualize something else. You have a member of your family who has accompanied, or you've accompanied them to a hospital. They are not feeling good. Minor headache, stomach ache, fever, body ache, anything. You are an attendant who is working, Someone is a housewife, you have kids at home. You are working, you have to go to work. Someone is a sportsman, they have a net session in the evening. And then you are made to run from counter A, pillar B, counter B. How will you feel? I won't feel good as an attendant, as a patient, and I'm sure none of you will, right? Now this brings us to what I am here to present. And again, there's no presentation, though I have tried to capture it in 4 or 5 slides, but I think I've set it right, wherein just think from the perspective of an attendant, a family member who's in the hospital, right? All of us, the community at large is well read right now. They know what's happening. Everyone has a smartphone. They know how to go on Google, artificial intelligence, many tools at hand. Now the question comes what sir was telling, or what he was talking about, that touch, that simplicity, how you would have that transparency with your patients. That brings us to this topic, which I would just like to highlight, how we bring in efficiencies into the system so that we make it an auto mode system for our patients where they need not have a hassled experience at the hospital, right? Patient experience, a very common used word. We all know. What's experience? What's experience? What you've went through. Anybody else? It's a feeling, right? And all of us can have different experiences. In the same room right now, different experiences, 30 of us, 25 of us, maybe 5 have the same experience, some have a different, and that's very personal. You cannot tell me how my experience was. If your experience was good, doesn't mean that my experience will be good, vice versa, right? Now, this is a slide which just tells about, when I talk about a complex world healthcare, this is what a patient goes through. They don't know what's happening. And these are your workflows. We as medical professionals, as doctors, administrators, we know what jargons are all about, right? But a layman, a patient won't understand. You talk, doctors will talk to their technicians, to their nurses, do this, do that. What was mentioned in the PPT 5 minutes back, people don't know which number to call when you have to call an ambulance also. The same happens with them when a doctor would use terms like BiPAP. A layman won't understand what a BiPAP is all about. You will tell that, okay, we are expecting the discharge to happen, someone will come in, they'll write on the discharge summaries, they'll prescribe medications. Patient is not interested in all of this. They have come to the hospital, they want to get cured, go back. If they have insurance, they expect full insurance to be covered. They are not concerned about 3 lakh cover, 5 lakh covers. And what sir was mentioning, I think not only in Punjab, everywhere if a patient stays more than 12, they think we are trying to make money. And that's a normal way it is. All of us feel the same. So these workflows are very confusing for a patient. And they don't want to understand, neither will they understand in future also. And that's a challenge we all have. I've just taken 2-3 initiatives which we've done at Apollo as an organization. We know digitalization is something which is happening all across industries, and that's what we've done in Apollo, where we don't want our patients to go through a tough journey. We don't want patients to come with a paper in hand. We don't want patients to come with a file in hand. Everything which a patient undergoes, their entire history is in the system. Which means if you are a patient coming in for the first time, we would capture everything. We'll make sure that's there, whatever the doctor is saying, and everyone in the Apollo ecosystem will have an access. When I say everyone, every hospital. Something is happening in Bangalore, an Apollo hospital from Delhi can pluck out what the patient's condition was, what are the comorbid conditions. That's something which we've done, which is convenient for our patients. Next time you go into a hospital at Apollo, you need not worry what's happening. You just give your UHID, every data is there. And the doctors at the other place can help you. So this is one bit. I'll come to the streamlining of the process, how we do it, but I've just taken there. We were talking about discharge. I know it's a pain point at all hospitals, and all hospitals are trying to improve their discharge process. We are also doing, we've done it. At few places, we've got some improvements. At few places, there's a lot of work to be done. But again, this is something which it boils down. Everything is in the system. You talk about transparency and proper communication, which happens with a patient, where you've got to tell them and you've got to articulate how insurance will be taken care of, how discharge summaries will be taken care of. And this should happen at least a day or two before the patient is there in your hospital, not at the 11th hour. Discharge is at 11 o'clock, and then you tell at 10:30, sir, I will process for the insurance company. I'm not sure whether the approval comes or not. I'm sure patient will give you a bad feedback. That's the way it is. So this is one part to it, where we talk about enough processes which we are doing. We are talking about streamlining. We are talking about automation, where everything is in the system. So that's one side of the story, right? Now the question comes, if you're doing something like this, how would you measure it? We are saying we are the best. Everyone says that. Now the question is, to our patients, to the community at large, how would you rate Apollo? How would you rate this hospital? Are they doing good work? Are they living up to your expectations? Then we come to the second phase. The second phase is how you would assess, how would you look at the feedback of a patient, what the patient has given it to you. Everybody collects feedback. Every industry does that. We also do that. We used to do it. Earlier it was the paper mode where everyone used to look at, right? And when we were talking about digitalization before that, we'll walk up to a patient, we'll say, here is a paper. Please rate us on these 6 questions. What do you think on a scale of 1 to 10? But with a hand on our hearts, how many of you think it's a genuine feedback? If I go with a paper in front of my patient and tell him or her, please rate me, sir. Some will say it's good, patients are rating you, it's fair. Some will say, I don't agree. Maybe I am having the power to influence the patient when he or she is in my premise. Sir, please give me 9. No, please. I was very nice to you. I wished you every morning. Please give me 9. The food came on time. Please give me 10 on 10. Some patients might, some might not. But again, that was not foolproof. What we did, I'm sure a few other organizations are also doing, we started evaluating every feedback through NPS. We all know what NPS is, Net Promoter Score. What differently we are doing is, we are making sure that when we talk about streamlining of our processes, we have made a point where every patient who's registered with us, with the registered number, at every touch point when they experience something in the hospital, they get a push SMS on their handset. A link wherein you as a patient, you as an attendant, when you are at leisure at home after 4 hours, you can probably rate how the services were. I am not influencing you. You have every right when you're sitting at your home after 4 or 5 hours, you just think, was the service good? This was good, this was bad. That brings us to the point where we talk about how we are capturing the feedback of patient, which means we are working on every step. First, I'll make sure I streamline my process where I bring in efficiencies into the system. Then I look at, I give the patient the right to choose how they want to rate me. I am not influencing you. You decide what you have to, what your journey has been, and you rate me on that. But here's a catch. This is not that easy. The trends and the data shows people who get the information through a link, or it is very difficult to get 100% feedback from patients who get the link. In FMCG industries, in banking, in other industries, it's only 5 to 6%. If I trigger an SMS to 100 people, only 5 would respond. But still, at least some place, somewhere we've made a beginning where at least I'm getting 5% of the patients who are rating me. I'm sure when more industries would do it, people would want to rate you. I think in another 5-10 years, it will reach a point where people would be doing it at 80%, 90%. And that's something which will help us improve more at every industry. Like I said, patients, like sir was mentioning, because of our patients, we all are here, right? And it's their voice, their feedback which matters. Because if they are coming and taking medical help from us, it's important what we do. And somewhere I also read that that's the simplest form of marketing. You need not invest. Whatever your patients have experienced by word of mouth, they'll go and tell it to many more people, and that's how the goodwill tends to get created and more people would come into your hospital. So that's what we are looking at. And these are a few things which we are doing. Again, the success over here is how simplify we can do for our patients when you talk about the processes. Nobody wants to go from pillar A to counter B to counter C to counter D. No. Everybody wants that one shop stop. If I've come to the hospital, I am least interested in whether housekeeping would do it, or a duty doctor would do it, or a surgeon would do it. I want everything by my bedside because I am paying you for those services. And that's what every patient demands. And I am not exaggerating, this is the reality. I am sure with ambulance also, they are giving you the money. That's what they feel. If I am buying or utilizing your services, I need everything. From A to Z is what the patient wants. And this has changed. In the last 10, 15 years, patients are not compromising on even one thing which they don't want. Everything they would need from you because they feel they've come, they've paid, and we have to live up to their expectations because it's a complex, dynamic world. Healthcare is very complex. There are many centers which are coming up. People would choose them. And at one side we say, we take pride in saying we have the best clinical talent, we have the best processes, SOPs. A lot of us might ignore this and might not give that much of impetus on this, but this plays a vital role. It plays a very important role in deciding where you would want to take your patients. And let me be blunt, most of the organizations have decent clinical talent, except for few specialities where you need someone who's there at the top, people might choose. But in big cities, in tier 1 cities, most of the healthcare providers have decent clinical staff, decent clinical talent, where decisions like these or factors like these, they influence the decision of a patient. Again, these are a few things. I know we all are in the tech world where you would want to see the Google reviews. All of us like to see as to how our patients. So again, these are few yardsticks on which we measure. And when we measure, we look at how the trends have been, whether we are seeing an improving trend, whether we are seeing a decreasing trend. And that helps us probably go to the whiteboard, again, talk to various stakeholders, try and understand what can be done better. And we look at everything minutely. If there are 10 patients, out of which 6 patients have given a feedback of 3 for something, we try to make sure what we do so that the 3 becomes an 8 or a 9, and then we evaluate that parameter going forward. So that's the groundwork, minute work which we do to make sure things are set in order. Again, this is generic. Most of us who are as healthcare administrators, professional, would want to do things, but it all boils down, like I said, for us to understand, just think of yesterday morning, 8 o'clock, if you've arrived in this place, what your experience was, and now just club it up with a family member who is a patient and you go to the hospital. How will you feel? So that's something which I just want to have a thought in all of your minds, that we need to make sure that we bridge the gap when we have patients and attendants in our hospital, so that that touch from our side can make a genuine difference to that patient.
Thank you. Thank you, Karan. Thank you. I think you rightly summarized it. A center of healthcare or maybe hospital, what we promise is restore, what we promise is comfort, what we promise is heal. And I think for that, workflows or experience or putting processes in a place is most important. Any question from Cloud? Any questions so that we can conclude the session?
How the dispatch can happen without even understanding whole address and their what sort of problem. They should send the normal ambulance or the cardiac ambulance. So before even understanding everything, how the dispatch can happen.
Fantastic question. So how that basically happens for you, for us, is first and foremost, when the patient calls, the location is automatically captured. So the whole idea of where's the location, that's sorted, right? Because on the platform, wherever the phone number is coming in, we can track it. So that's easy. The second part is, do we send a basic life support or an advanced life support? That's the only two differentiation. We're not thinking it's cardiac or non-cardiac, we're just thinking basic or life, advanced. So we have a 60-second questioning. So we know certain set of questions that we have given to them, and then we say, based on this, you classify emergency, non-emergency. If he says emergency, the ALS already starts. If he says non-emergency, then we have time. We schedule, we discuss, and then the rest happens. And it also depends if the ambulance is someone going out from the hospital or coming to the hospital. So if it's an emergency and it's coming to the hospital, then the urgency heightens. If it's going out from a hospital, then we are much more relaxed. We have so much more time to discuss. Just to answer your question.
Yeah. One more question from my side. I think we are discussing about process and amplifying experience. Most of the AI tools and everything we have heard, you will have maximum what you say staffing which is more unorganized, coming from a different strata, educational status is slightly different. How you ensure that their mental status, their coordination remains at top, so that when they interact with the patient, they give a ample or good experience to the patient?
Right. So first is the entry point for all of this stuff into the system. We try to make it as tight as possible. So there is first a questionnaire-based survey of the paramedic's qualification and knowledge. There's a senior paramedic-led interview, and there's a clinical doctor-led interview. If we are tying up with the hospital, then it's the hospital doctor who interviews. Otherwise, I am there, and there's a team that works with me that interviews. So that's the entry point criteria. But we don't rest there. We then do training. All paramedics, twice a week, they have a training session. That happens. Sincerely, it's run by doctors, and they lead it. And we have an infection control officer who's a nurse, so she's the coordinator for these trainings. We continuously train them on clinical practice guidelines, as well as JCI-related protocols that they're supposed to do. And soft skill training is part of their induction, and there's a refresher that happens every 3 to 6 months, which is led from the HR team and the customer experience team. So we put all of this as a package, and there's a tracking. And because, obviously, it's JCI, we have to show this to them. And it's not just for the paramedics, for the pilots as well, and to a lesser extent to the clinical operations managers, the ambulance operations managers, the people, the relationship managers of the hospital. So multiple levels of training. Is that what we try to do? Yeah.
Any other question?
What if we are calling on somebody else's behalf? You said, the moment you get a call and you immediately send the ambulance, but maybe the person is somewhere else and we're just calling upon their behalf.
And then that's where the delay happens, unfortunately, yes? So if you're calling on somebody else's behalf, we're still going to pick up your location, and you have to clearly tell us, no, that's not the location, I will give you their location. And that's one reason for delay. The second reason for delay is they're in a narrow, crowded area, and you need more than one person to go. So we have to find another helper or a paramedic to go along. Sometimes they need special tools like a wheelchair or something. So all our ambulances have wheelchairs if they're ALS. But supposing they need something which is not available, then we have to arrange that and go. So these are some of the pain points that we have and the delays that happen because of that, unfortunately.
That could be one of the top questions that, okay, is this for you or for somebody else? So that would help.
100%. We try to do, so we are trying to solve it. We have subscription-based services where family members can enroll their family members. Like, let's say we have a lot of older population living in India now, their children living abroad or in other cities. So we ask them to subscribe. So we have in our database their parents' location already. So it shortens the time, and it's easy for them, and it's comforting for the children to know that, okay, I know I can call them and they will always be there. So we have subscription services that are there. We also have an app-based service. So they can download the app onto there, and then there's an emergency SOS button. Just click that from wherever. They don't need to give us details, and the ambulance will get dispatched. So we're trying to come up with these kind of solutions, and they have to catch on. That's
Very
the idea.
nice, very nice.
Thank you.
See, you are doing such a fantastic job. But the thing is this, you have your back against the wall because you are fighting the unorganized sector. If you go through AIMS or Safdarjung, the number of ambulances which are there. So I think the biggest challenge for you is to educate the people how how you are different from the others. Like JCI, for us people here, everybody will know JCI, but the guy there in Safdarjung will not know. I think a public awareness has to be. See, outside our hospital, there are, our hospital has 5 ambulances, all fully equipped, trained, everything. Outside the hospital, there are 16. They say, we've got to go to Phagwada. That guy will do it in 1500 bucks. So I think the biggest challenge for you is to educate. A public awareness thing has to come where you differentiating. This is how you're different. JCI will not get registered with the people. They will not know. This is, I think, this is one effort you will have to make on this.
Yeah, so I think we have overshoot time. Thank you very much. When my emergency head is here, just to answer some, I'm just not able to, in Navi Mumbai, we have around 12 lakhs population, 13 lakh population. For last 7 years, we are running campaign which is dedicated to societies, to corporates, to even government. We run some of training program from government, but still size of our hospital, which has 500 bedded with almost 1500 emergency footfall, we get around 70 calls, 60 to 70 calls, and we have an emergency footfall of 1500, 1600. So I think it's a larger efforts. One, definitely you said awareness, but secondly, government. I think most important aspect, and we do discuss this with the local authorities and state authorities, that there needs to be a larger engagement from population. The scoop and run is the factor. Even a doctor's family believes that they can take their own vehicle and go to the hospital, and they don't see a safety of transport, they don't see a nature of injuries, whether it can be done properly or not. So this is a problem. I think it requires a larger forum to solve. Thank you very much. I think we have overshoot our time. Thank you very much for my all panelists. Thank you for, very much for organizer to organize this event very well. Thank you. Thank you.
Thank you, everyone. Thank you, our session chair. Thank you, all the speakers. Yeah, as we end this session, I would like to quickly make an announcement, to the audience. Please don't forget to reach the plenary hall for BK Shivani's session at 4:30, and then Dr. Jayashankar's at 5, our External Affairs Minister. So we'll see you there. So whoever interacted among the audience, we'd request our session chair to please give them these gifts here. If you could please stand up. The gentleman in the cream off-white shirt, and then ma'am, you there in the sari. Yeah, thank you. Sorry, don't know your names. Now we are shifting gears to an exciting lightning session. Please take your seats, sir. Yeah. A fast-paced, knowledge-packed discussion on a topic that's shaping the future of healthcare. Request everyone to please be seated. Our first topic is digital transformation in healthcare engineering, embracing smart technologies. Please join me in welcoming Colonel Jasmeet Singh on the dais, please. As Director of Projects and Engineering at PD Hinduja Hospital, Colonel Singh has been instrumental in advancing hospital infrastructure, integrating cutting-edge technologies like the Da Vinci surgical robot and intraoperative MRI. His leadership ensures operational excellence, patient safety, and sustainability in healthcare. Please join me in welcoming our second speaker, Mr. Vyom Kumar Gupta, Chief Engineer at Indraprasth Hospital, onto the dais. He oversees the hospital infrastructure, maintenance, and engineering operations. With extensive expertise in healthcare facility management, he ensures seamless functioning of critical systems, safety compliance, and energy efficiency, contributing to the hospital operation excellence. A warm welcome to both of you, sir. Please have your seat. Request we have a seat, audience, please. Over to you, sir.
See, we all have heard about digitization happening in the healthcare segment. When we talk about the patient who wants to come to a hospital, either he will go to a website or he will go an app to book an appointment for the doctor. When he goes into the hospital for a health check, there a lot of digitization is already there in the system. For a billing, these automated billing systems are happening these days. Now, when we talk about digitization in the back end, when we are saying engineering or maintenance, I mean, these engineering and maintenance functions are also the backbone of the hospital operations. So, what can we do in this digitization in this sector? So, we talked about, we discussed this thing, and we also have an experience from previous 10 years. Like, I was not a healthcare professional when I joined the healthcare organization. And Colonel Jasmeet was also not from the healthcare, he's from the army. So both of us were not from the healthcare organization, and we don't have any experience in the healthcare. Now what we have done or what we plan to do, we just wanted to showcase here. So while I was in this previous session, I was just thinking, how do I start my presentation or discussion? So this discussion, I happened to meet a gentleman yesterday in my office. He comes to my office and he says, my father was a patient in this hospital. He was admitted on 15th November 2023. So in the 15th November 2020, he was admitted, and I wanted to make sure, I raised a complaint at that point of a time, and I want to know what is the status of this complaint. That's a true story. It has just happened yesterday. So, I mean, what should be my answer? Sir, your patient was admitted a year back, maybe more, 1.5 years back. And the problem which we raised, we already sorted out the problem out, and everything is done. He said, no, I want an evidentiary proof of this. So then I just immediately just called our colleagues. I said, this is a problem which has happened on this date, and I need to know all the complaints and what was the resolution happened at that point of a time. So how we could do this? Because we have got a complaint management system which is happening in the hospital. So anyone from his room or from the call center can raise a complaint to our control room, and it gets registered. Now once the complaint gets registered, there's a possibility it gets solved within few hours, few minutes, or it might take some time. When I say time, it might take a week or might take 15 days also. It depends on what is required there in that point of time. So when we checked up our systems, we called our team was there, and they said, sir, this problem has happened. We know about this problem, and this is recorded in our system. And I said, what happened after that? What was the resolution? So they were all looking left and right, resolution. So then they say, then I talked about it. We have got a system where if a complaint is not closed within an hour, we should make a work order system. We should make a breakdown work order, and this breakdown work order remains in the system until the complaint gets resolved. So then we checked up the breakdown work order system, then it was written there, yes, this problem was there. So we have replaced these 3 sections of the pipelines which were rusted at that point of a time. And once though that problem was resolved, once it was changed, the problem is resolved. And since last 1 year, we do not have such complaint. So this is a one form of automation I talked about it. Now, we are talking about for what we can do this more. So we have got a major system. Like when we talk about engineering, we are talking about health HVAC, which is primarily air conditioning system. We are talking about electrical systems, where the electricity is provided to the hospital. We are talking about the backup systems, which are there in the hospital. And we are talking about plumbing systems, which are there. Now, what we can do in this whole process? So when we say HVAC system is a complex system which starts from chiller, which actually cools the water. And this cooled water goes to the rooms. It could go to operating theater rooms, it could go to ICU rooms, or it could go to patient rooms, or a administrative room also. So that is the function of chiller system. When the water is cooled in the chiller, we have got a cooling tower system, which is either on the terrace of the hospital or at the ground floor of the hospital. Now, previously, these were all connected through a pipeline system. Now, the guy who is operating that, he doesn't know what is the temperature going on in the chiller. If he has to know, he will go to the chiller and he will find out what was the set point. It was 7 degrees centigrade or 8 degrees centigrade. Now, today, systems are available where we get all the data. Like a cooling tower which is running at the terrace of the hospital, we can find out what temperature it is running, what is the cooling tower basin temperature, what is the temperature of water which is going to the chiller, what is the temperature of water which is coming from the chiller, and what frequency it is running, and what speed it is running. So everything is available on a desktop, which has been, equipments have been integrated. So you get all the information regarding the equipments on the desktop. Or if a patient is there, like if a patient is in operating theater, earlier the operating theaters were running in, no one would know what is the temperature in operating theater. It is there. I'm talking about 10 years back. What is the requirement? If operating theater has to be maintained at 20 degree plus minus 2 degrees centigrade, plus minus 1 degree centigrade. So it is there. Now our help desk system is there. If temperature is high, he will get a call from the OT section. Then the person will go from desk. A complaint will be assigned to a technician. He will go to a operating theater and he will see what is the problem over there. Then he will provide a resolution. Now, the situations have changed, times have changed. Currently, each operating theater data is being presented on a desktop today on the control room. So what is the temperature in the operating theater? Which is very important considering the infection control requirements. We are talking about what is the differential pressure of the operating theater vis-a-vis outside environment. So those things are today available on the desktop. In case something happens, like differential pressure goes up or down, somebody keeps the door open. So immediately an alarm is generated, and the alarm is generated in the control room. So people get to know, okay, this is a problem has happened in this OT. So instead of somebody calling from the OT, the person already knows. He goes there, and the problem is getting sorted out. So these kind of a thing has happened in the automation in the healthcare sector. Because we're talking about operating theater. Same goes with our ICUs. And now what we are trying to reach is that we reach to the level, even the patient rooms. Even the patient rooms, you should be getting all the informations in the systems. We are talking about generating stations, powers. Power goes off, power comes back. This is very common. Everywhere it happens. Now today, the requirement is that we have to reduce the manpower also. So if I've got 5 DG sets, I need a person to go there when the DG sets are operating. A person goes on every DG set, he makes a logbook, he takes a logbook, he writes down the data into that, voltage, ampere, current, running hours. So those things were happening. Now the technology is available today where we can integrate our DG sets. So instead of person going there on the DG set and writing all those information, automatically information comes from the DG sets to our electrical control systems on a desktop, where all the data is available. So this is also possibility which we have in foreseen and we have implemented into system. Now person don't need to, the people are making logbooks, manual logbooks. Now since today the data is available, it is being dumped from the engine itself, so we are making automatic logbooks. The data automatically gets populated, we get a data in terms of fashion, the fashion which we want. So these things are available as of today, which has been done. Now, since I talked about it, and just go back to presentation. So, yeah, on this slide. See, when we're talking about digitization, when we're talking about digitization, so the first and foremost thing is in the old hospital. Generally, we have got old hospitals. Since we have got an old hospital, and when we say digitization, how do we implement digitization? So this becomes a challenge. I mean, this could be a mindset challenge, sometimes attitude challenge. So I asked Colonel Singh to just tell me about how do we overcome these challenges.
Thank you, Vyom. It was a good introduction that you gave, that what all is available in the hospital industry today. The same thing what you mentioned here, really most of the hospitals have it. With the technology changing, all these new things are coming in. But like you rightly said, the hospitals are old. You can't change all these systems in one go. There are old systems which are adaptable, which have been used by the people. They're more comfortable with it. The moment you get a new system in place, the change management happens. And people are not very comfortable with it. We've got 3 chillers. One of them is very old. So the life of the chiller is 20 years old. 2 chillers are there on the BMS. They are working fine. They're giving us the data. But the 3rd chiller being the old one, data is not available. So by the time, it will take some time to replace the 3rd one. These are the changes where you have the integration of the old system with the new system is very important. So, like you said about the OT, yes, there are 2 OTs where you've done that changes, but there are another 2 OTs which are old, which are being used for casualty management and all that. But those OTs, the things are not available. So it will take some time, train the people, tell them what is to be done, and get the things in place. Because the issue is that the finances also got, the budgets are tight. The moment you go to finance, the first question is how are you going to repay back? So with the constrained budgets, we need to change slowly. Next is that the change management, the organization should also have that kind of a culture to understand and accept these changes. The top management should support you in these changes, then only these things can happen. I understand that sustainability also we're going to talk about. Sustainability is another thing with the new thing coming up. We have to ensure that the sustainability angle is also covered. Now I want to understand from you, Vyom, how do you feel that what all else that we can do, or what are the other smart technology that we can adopt in the near future in our hospitals, where the things can become more streamlined and the things are more visible and the things can be controlled better.
See, when we talk about smart technology which could be implemented into the system, I mean, it's just a thing which we need to just look after, start thinking about it. When we're talking about, I started with the HVAC systems. So HVAC system has got a multiple components. We've got a cooling towers, we've got a chillers, we've got a pumping systems, we've got a water is the most important. Let's say water which is used for the cooling systems. Chiller is still it's better placed. But when we're talking about cooling towers, we are not getting a good quality of water. So we have got a scope here that we can automate whole this process. That where there is a system, independent system is there, who's monitoring the quality of the water. And if the quality of water goes bad, it takes automatic action on its own by pumping the chemicals, water treatment chemicals into the system. So we have done that process, like there's a NALCO based system, you might have heard.
Yeah.
So this is a digitization which we can put in forward.
And I also understand that with the new sustainability issues coming up, where the recycling of water is also important. So the cooling tower water will have to be recycled, maybe not immediately, but yes, another year or 2 years down the line, we will be questioned that how much water are we consuming and how much water are we recycling. So that recycling is another thing which I feel that could be important in the entire process.
Yeah, I mean, this is going to be very challenging in the coming days. We are talking about hospital built on a zero liquid discharge.
Yes.
So you cannot discharge any liquid from the hospital, which is going to be very challenging. I mean, I still don't know how we're going to reach there, but a step has to be taken. And the step is like, sometimes it is a compliance oriented, the statutory bodies makes us do that. Sometimes it's our own interest that we start doing it. So when we talk about, I'm just taking example of our own hospital, which is Indraprastha Apollo Hospital. So we were actually using around 700 kiloliters of water, I'm talking about annualized basis, per day. Some of this water is coming from the bore wells. Some of this water is coming from the municipal water supplies. Now, if we were operating the 700 KLD like we were operating 10 years back, even today, we were having shortage of water. Definitely our bore wells would have dried up. So we started a process of recycling. As you are saying, whatever the water is being consumed, we started recycling that water. We put up a sewage treatment plant. Over sewage treatment plant, we put up a ultrafiltration plant. Then we started sending this water to our WC for flushing purpose, horticulture purposes, which is implemented in the system. So we started consuming about 170 to 200 KLD of water from this system. Now, as you said, next stage is that you do a tertiary filtration and put up another RO plant and utilize this system, this water for the cooling tower applications. So yeah, we have to reach to that stage. And I think this is possible, but zero liquid discharge is still a challenge. I just wanted to ask you, Colonel Singh, what would be the impact of climate change and sustainability, and how we can integrate this with the digital transformation?
Today, with the sustainability score coming up in a very big way in the industry, we are being questioned about what is the ESG score. As of now, the healthcare industry, just because the patient comfort, patient care is of the prime importance, it has not come up in a very big way. But then it has already started, and the rules and the things are being made. And as you are aware, the hospital is a major energy guzzler as far as the 24-hour HVAC consumption, electricity consumption. So the energy requirement is very, very, very high. So we have to look at the various means and techniques where we can reduce our energy consumption, get the renewable energy resources, where we can reduce some amount of consumption has to be done by looking at the renewable resources and other options. Next is with the high uses of HVAC, the greenhouse gases emissions goes very high. So we have to look at various techniques. We're already looking at it. But how can we, optimize the functioning of the chillers, optimize the functioning of the HVAC system, where we can reduce the emissions. Maybe we do not run them at peak at all times. We run them at the dependence on the requirement. We have the technology in place where maybe at night when the temperature is little lower, we reduce the use of the chillers, and maybe in the daytime it increases. So we have to look at the controlling our emissions also. And yes, like we discussed about the waste management and the water recycling, because hospitals also have the waste management issues. The biomedical waste is being generated, which there are issues from the infection control point of view also. So we'll have to create a balance between the patient care, patient health, and looking at the climate change and the sustainability also.
Yeah, interestingly, you brought out a point of waste management. I don't know how it goes in other state, but Delhi state is pretty tough on digitization of this waste also. Whatever the waste is being generated in the hospitals, it has to be properly accounted for, and every waste which is generated has to be displayed on the website of our own hospital website. So if you are discharging a water, it has to be monitored on a real-time basis, and the data must go to the control board, pollution control board. And same goes with the biomedical waste. So everything. So this is also digitization.
Yeah, this is also digitization.
This.
See, you can only control it if it is visible. If the data is seen, that is the time when you can look at how to reduce it. So the data analytics is very important. Getting all those data at one place on the website. So when it becomes visible, then only you can look at how to reduce the consumption. How can you reduce the management of it?
So digitization is getting into the backbone of the system. I mean, when we're talking about daily operations, where it is unthinkable. I mean, I tell you, I just visited an hospital a few years back, Grand Hyatt in Mumbai. I was working with the elevator industry at that point of a time. And since it was elevator industry, so I had to interact with the technical people. So we went from the back side. There's a front side and the back side. When I say front side, it is where the guest comes.
Yeah, and the rear side is the service.
Rear side is service.
Side.
And I was amazed to see a number of people. The shift was ending. I was amazed to see like thousands of people are coming out. When I say thousands of people are coming out, and when you say the front side of the hospital, it's all empty.
That is where the action is.
So there is the action is.
I think we are running out of the time. We'll have to conclude and
yeah.
Close. So as you rightly started and we discussed that digitization is a very important thing as far as the data management is and the hospital working is concerned. It has got a lot of benefits. It gives us where we are and where we need to reach, and at the same time create a balance between the patient's health, patient care, and the energy and the all the resources that we are using. So looking at that, we as the engineers have to be very careful and see how we can reduce and maintain the sustainability of the system also in place.
Yeah, I mean, I echo the same points, whatever you said, sir. If there is any question from the audience on this.
So how to calculate is a challenge. But I think if we'll look at this sub-unit system and sharing the data with the people who are actually using it, that might also help in some way sensitizing people. So is that a possibility?
It is already happening. Water, not possible, because we don't have the kind of water consumption. But yes, as far as the electricity consumption is concerned, there's some concept called smart meters. So we have those smart meters being installed at, say, this is the hall. We have it one outside. Yes, and the smart data is connected to your BMS, and it is generating the output every day. So it's triggering every evening that this is the consumption of this room. So it will tell you yesterday the consumption was say 500 units. Today the consumption is 700 units. So you know that this hall has consumed 200 additional units, and you have a reason behind it. Maybe it was used more, or is it that somebody left the lights on? So if you are in charge of say MRI, MRI, I tell you today you used say 1000 units, tomorrow you use 1200 units. So you know, yes, yesterday my patient count was 10, today my patient count is 12, so yes, it is justifiable. Or is it that the patient count is same but the consumption is still higher? Then we look at the reason that why has that consumption gone high. It is there and it is part of the BMS.
What you said it's exactly here. When you see the dashboard, energy management dashboard, micro units also. This is the MV panel. When you say MV panel, is a broad-based head.
As of now, it is there, but see, nobody asked for it because it's you know why. So it will, if you want, it can be shared. We can do it.
Currently, it is being used for our own optimization systems. So we are checking every year what was the consumption, or every last week what was the consumption. It is used
Finance
for
people will not leave you otherwise.
Uh, I think what you're saying is absolutely correct. We have also done our own calculations. If my best quality of water which I'm sourcing is suppose 70 rupees per kiloliter, but when I treat it through RO plant, it becomes 100 rupees or maybe 110 rupees. The only thing is that we have to take a call here that we want to go for sustainability or we don't want to go for sustainability. If you're looking for sustainability, at the end of the day, we have to take those calls. So it's a tricky matter. And there also, when we talk about sustainability, since the electricity consumption is also going high, which means we are generating more carbon. So there also we have to think about it. So yeah, it's difficult, but the calls have to be taken.
It is said that sustainability comes with the cost. Yeah. So if you're going to use single-use polythene, you anyway are going to throw it. So again, you're producing more. So you'll have to create a balance somewhere to decide that what is to be done. But sustainability comes with the cost.
Yeah, but the sustainability and compliance, because when they're going to be rigid, then we have to do it. We will not have any options.
Yeah. No, they're very strict.
Yeah.
They're very strict. Yes.
And yeah.
Especially in the metro city, they're very strict. They're very particular about it.
Okay, you got a surplus water. Oh, excess water, STP water. Yeah. See, that's the first use. Go use it for the horticulture. Yeah. Yeah. That is also a better way of doing it. Yeah. That's a challenge. Correct, correct.
Thank you. Thank you.
Thank you, Colonel Jasmeet sir. Thank you, Mr. Vyom sir. We really appreciate and for your valuable insights. Yeah. As we disperse for lunch, we reconvene at 2:30 in the same hall for our further sessions. Thanks to both of you once again. Yeah. So we'd like to hand you over the speaker kits. Hi, good afternoon, everyone. Well, as they say, not all heroes wear capes. Some wear scrubs, gloves, and exhaustion. Healthcare workforce forms the background of our entire medical system. And today we shine on some light on these heroes who protect us. We'll see how we can protect their interest, create a safe, secure, and a resilient environment for them. To share their valuable perspective on this topic, I would like to invite our session chair, Mr. Harkaran Singh, an experienced healthcare leader with a master's in hospital administration and an executive master's from Indian School of Business, currently the chief operating officer at Apollo Hospital, Jubilee Hills. He has over 2 decades of experience in healthcare and telecom. Mr. Harkaran has contributed to renowned brands like Medanta, Fortis, Vodafone, and Airtel, specializing in customer service, patient experience, operations, P&L, digitization, and process optimization. Please take the dais. A warm welcome to you. Please join me in welcoming our first speaker, Dr. Anuradha Pichumani, Executive Director, Sri Ranga Hospital. She is a leader in patient safety and healthcare quality, a NABH Principal Assessor, and CAHO Quality Wing Chair. She contributes to global healthcare standards. An award-winning expert, she has published extensively on quality improvement and patient-centered care. A warm welcome to you, ma'am. Onto the dais here, thank you. Please join me in welcoming our second speaker, Mr. Kiran SV, Chief Executive Officer, Apollo Health and Resource. His experience spans from being Senior VP to CHRO and now a CEO of the AHLL Group. Apollo Health and Resource Group. Currently, he heads the global workforce development and addresses the global shortage of healthcare skills and talent. A very warm welcome to you, sir. Please join me in welcoming our third speaker, Mr. Iga Vesviswara Reddy, and gain insights from his perspective on strategies to create a safer environment, ensuring protection and respect for those who protect us. A warm welcome to you. Please have your seat. Thank you. Please join me in welcoming our fourth speaker, Ms. Bobby Ramesh, Group Director, Nursing Excellence, Sarvodaya Healthcare, a seasoned nursing leader with 29 plus years of experience in clinical teaching and administrative role. She currently serves as Group Director, Nursing Excellence at Sarvodaya Healthcare, NABH Assessor and award-winning nursing professional. A very warm welcome to you. Over to you.
Hi, good afternoon, everyone. Namaste. See, this conference is by the name of International Patient Safety Conference. We talk about patient safety. We talk about how we can reduce or remove completely harms across the hospitals, across our facilities. But nobody talks about employee safety. If you look at most of the incidents which are happening, of course, they are reported for patients. But if you look at equal number of incidents which are getting reported are actually related to our staff as well. How can we create such an environment in this era, and especially when we are growing and expanding exponentially with the help of AI and ML learning and all? We are moving into patient safety, we are moving into patient experience, we are elevating our processes, but nobody talks about the basic responsibility of a healthcare provider, which is taking care of their members. Now that's an important topic, and it's like the need of the hour. We have seen so many incidents. We have seen what happened recently in Kolkata. It was a disaster, not for the healthcare workers, but for the humanity, I would say. So it clearly focuses the need, and it pushes the administrators who are running the hospitals, who are running these facilities, and the teams across. How can we create such an environment where people should feel confident, feel empowered, feel trained, and feel owned. I would say they need to own the system so that they can go and serve patients and reduce those harms. Of course, I'm trying to be on your side now to understand from our esteemed speakers what they have in it for us and what is the need right now for all of us to do and how we can take this forward to the next level. It's not only about the safety of patients, it's the safety of the workforce which is there. It's about the safety of our attendants, or I would say the caregivers which are there across. So we really have to take care of them. Create a safe environment, not only for the patient, but for everyone stepping into that facility. So what all can we do? Let's hear from our speakers. So I would request Dr. Anuradha to start this and tell us what we are missing and how we can take this forward.
So good afternoon to all of you. At the outset, I would like to thank the whole team management of Apollo for having this passionate commitment to run this conference year on year. It's highly commendable because this is a very important one on patient safety. And I'm very happy to be here talking on sustainability of behavioral change. I think I'll see the screen. Okay. So sustainability of behavioral change, it's among the healthcare workers, which is very important for patient safety. So we need to understand why this matters. So this matters because you are talking about patient and worker safety. Again, you are talking about sustaining positive behavioral change against all barriers. So what we shall do in another 5 or 10 minutes is we'll try to discuss about the experiences, our own experiences, what we have done in our projects, and also some real world experiences which has happened recently, and how this experience has been changed. So how we are going to sustain a behavior where you are going to save lives. So I think most of you will remember this. This happened just last month. So on January 29, 2025, you had a mid-air collision in US where a passenger flight hit a helicopter and more than 65 people were dead. So the preliminary investigation shows there are various contributory factors in this: failure in communication, lapses in situational awareness, non-adherence to standard protocols. But all this tells us that this was a preventable error. That is what has been coming on now. And I think some of you might remember this way back in 2009. This was another emergency landing which happened on the Hudson River. This photo came out on all papers where the whole flight was, the flight was hit by a flock of geese as soon as he took off. And he had to make an emergency landing and he couldn't land on the runway, and so he had to put it down in the Hudson River. So since it was a perfect landing on the water, everyone was saved. So the captain was asked about this incident. So he told, this is what he has told, that because of his repeated experience, 42 years of experience, training, this is what has brought out this change. And so he was able to make this perfect landing. So it happens only once in your lifetime, or it doesn't even happen also. But you need to be prepared. For this, sustained behavior is very important. So safety is not a one-time intervention. You need to have sustained change, so that that's to prevent any disaster. So moving on, you have all these challenges in sustaining behavioral change. I think most of you know about it, and I'm not going to dwell on this. You have, because of cognitive overload or fatigue, low human resource in the department, lack of motivation. You have some barriers in the organization. You have limited frontline engagement. All these are barriers to sustain any behavior. So we'll now see how we are going to move on. So where this was working previously, showing carrots and sticks. So you need to now to think beyond carrots and sticks, because this behavior doesn't work. You need to build on motivation among your team to improve on the behavior, because we are talking about complex creative work. Healthcare environment is always complex and it's highly risky. So you need to build on the motivation, and you have to support every individual as well as the team to change the behavior. So you have what is called the self-determination theory. where you talk about autonomy. Autonomy is the employees feel that they have a control on what they are doing. Second thing is competence. Competence is your skill training. So they have the confidence of doing something. Third is relatedness, which is a sense of belonging. They belong to that organization. So these three things help you to motivate your employees. So this is called the self-determination theory. And we did a project with Ariadne Labs, which is in Harvard. So this is on WHO Safe Childbirth Checklist. We implemented this checklist in 9 hospitals in Chennai. And we were able to see the changes as we moved through the PDSA cycle. So we moved through 2 PDSA cycles, and even after we finished the project, as we finished it, it was at 97 to 100%. But even after we finished, after 6 months, when we got back, when we analyzed again, the behavioral change was very good, and they were able to maintain it at 100%. So I'll be able to tell you what are the lessons we learned from this. So whenever we do any implementation, you need someone called the champion. So this is an implementation pathway with a champion. You need to understand who is a champion. The champion is a person who will be able to motivate the team. He should be an internal person. And you need 2 types of champion. One will be the project champion for that specific project. The second will be the organizational change champion. This person has to support that project champion to get the resources and other requirements. And you need to identify and empower the champion. Empowerment of the champion is very important because they are the persons who have an interest and they have a commitment towards the organization. They work relentlessly and they are enthusiastic, they are dynamic, and they have a strength of conviction of that specific issue. So the roles of the champions will be on advocacy, on education, monitoring, and problem solving, whatever arises during that specific project. And for this, you have what is called the nudge theory. Has anyone heard about this nudge theory? No? So maybe you can take this up and use it in your own organizations. So all these are behavioral patterns. So this nudge theory helps you to change behaviors. So you have what is called the system 1 thinking and system 2 thinking. System 1 thinking is automatic. It acts as a reflex. Whereas system 2 is slow. System 1 is like brushing your teeth. Do you think before brushing? How you're going to put your brush, how you're going to put the toothpaste on the brush? You don't even think. You just act. So that is called system 1 thinking. Whereas system 2 is slow and you think before you act, like filling an application form. So most of the things, whatever we are going to do in our organization, if you can nudge them to do it as a system 1 thinking, so they will be able to move it further. So you don't force a behavior, you present it as a choice. For that, you need to simplify the process, whatever is happening in the department. You need to give them some timely reminders, give some default options, give some incentives so that the behavioral change happens. Again, you have what is called the COMB. C is for capability. Capability is again giving them knowledge and skills. O is for opportunity. You're going to environmentally restructure the area. You're going to do the time management so that they are able to do something. And again, you need to give them some motivation, recognition, and the communication has to be there. So with capability, motivation, and opportunity, the behavior starts changing. So this is called the COMB model. You identify behaviors and barriers to implement a change. Then you have the other implementation pathway with the collaborative. So collaboratives are a group of people with like-mindedness working together. So in collaborative, it moves faster. The change happens rapidly. So it happens in implementation cycles. So the groups help to drive and sustain the change. You have the planning phase, engagement phase, implementation, and then it moves on to the sustainability change. And you have 2 theories on this behavior with a collaborative. One is the theory of planned behavior, and second is the HAPA model, the second one. You can use this theory of planned behavior when you want to do some change, like asking a person to do the hand washing before they start a procedure. So this is best suited where attitudinal change is crucial. So you're going to make the change. So in a theory of planned behavior, you have the attitude. It can be a positive attitude or a negative attitude. So positive attitude, you have to tell them what will be the change because of this. Whereas sometimes you have negative attitude because they think that it is unnecessary documentation. You have some more paperwork, some more work to do. So you have to change the attitude. Then you have the norms. Norms are what you do, what you perceive. So you have some peer influences, which some regulatory norms which make you do it. Again, you need to have the control. This is a perceived behavioral control. where you simplify the process, teach them how to do it, give them some competency and skill assessment. And based on this, the intention to change starts, and then the behavior changes. So this is called the theory of planned behavior. Then you have the other model, which is the health action process, the HAPA model. So this model suits better whenever you are going to change the behavior and you want to sustain it. So most of the quality improvement projects fall flat as soon as you go on to the next project. So always you need to sustain a project. To have the sustainability, it has to be done with the motivational phase and then the volitional phase. In the motivational phase, you need to make them understand what are the risks if they don't do it. And then you need to tell them about the outcome expectancies. What are the things which are going to happen as soon as they do the project. And then it goes on to the self-efficacy, give them some self-confidence, motivate them. And then it slowly, the intention to change starts. And then it goes on to the planning. Planning is very important in this because you need to give them some checklists, some timelines, schedule, and the roles and responsibilities have to be defined so that they need to understand who has to do what. So this planning becomes important and then the action starts. So you have a motivational phase and a volitional phase, and this is how it sustains the behavior. So QI collaborators, which needs a structured approach from action to maintenance, can take up this model. So these are the various lessons which we learn when so you are going to sustain a behavior, which is very critical. You need some leadership commitment. You need to utilize technology. You need a continuous training, motivation of your employees repeatedly, give them recognition. Give them a supportive infrastructure. Only you give them that support, they'll be able to take the change. And then the change has to be embedded in the organizational culture. Culture of the organization is very important and it depends on the leader to change it. So I leave you with this message. Sustained behavior change, it's not only about compliance, it's about a commitment to culture of safety. Thank you.
Thank you so much, ma'am. It is very explanatory here that how we can create a behavior change amongst the healthcare workers using these models. It will be very helpful for all of us if we can go back and implement these. However, we want to understand in terms of what is the need right now, how we can create, we can do the right kind of training, right kind of hiring, and right kind of environment, how can we create across the healthcare system to make sure that safety is not only for one person or one set of group of people, it is for everyone. So on this note, I would really would like to call Mr. Kiran SV to take us through his insights and how we can take this forward and learn from his guidance and whatever he's going to show us. It's definitely is going to be very helpful because he has led the human resource department and he's created a very strong workforce across Apollo hospitals. And it is not only helping us to create a strong, safe environment, but it is going to help us in creating mechanisms through which across the healthcare people can learn and be benefited out of it. So over to Mr. Kiran SV.
Thank you, Harkaran. Namaste. Please bear with me. I have a little sore throat, so my voice is not that clear. So the next 10 minutes, right, I'm just going to take you through the mental health matters, right, supporting workforce well-being. When I was requested to talk on this topic, while we do this regularly, when we deal with every member of the Apollo family who works with us, we don't realize the impact that it has and what is it that we're trying to prevent. So I actually tried to pick up as many statistics as we can and then see how we can make a difference to every healthcare professional working in any of the healthcare setups. So, I'm going to take you through the 4 different things. The mental health crisis. I mean, we don't realize it, but it is huge and it is increasing. And therefore, where are we today in terms of the mental health crisis in healthcare? What do the numbers say? What are the factors that are actually contributing to this mental health issues among the medical workforce? How do we, as an organization, each one of us can help solve this problem completely and not just treat it? And what are the 4-5 things that an organization should look at? Here are some mind-boggling numbers that I came across when I was working on this. If I see it globally, what you see is that the latest report, a report which is about 10 months old, released by the WHO, says that 1/3 of our healthcare workforce is impacted by mental health distress, which is affecting the efficiency and the quality of patient care. 1/3, 33% is a huge number, right? Suppose if we have 1,000 people working in our hospital, we have 333 people who are not yet there. I mean, they need some support in terms of their mental well-being while they are at work. If I have to look at the India-specific data, is it any better? There's a study revealed by AIMS in 2023, which says that 62% of the Indian healthcare workers experience high stress and anxiety while at work. And these are very, very authentic reports, as you see. 62%, almost double of what's happening in the rest of the world, right? And I'll tell you why that happens also. So what's the impact of this on the patient care? There's a report released by Lancet in 2021, which basically shows that the medical errors due to the stress-related fatigue account for almost 23% of adverse patient events. And I'm talking of not medication errors, not this thing, I'm talking of 23% of the adverse events happening just because of stress, which are all avoidable if we were to take care of our people. And what has also been realized, there is an IMA survey of 2023, which is again about less than 2 years old, who says that 78% of the healthcare professionals have reported an increase in the workload and emotional exhaust post-COVID-19 pandemic. So what this basically tells us is, we all go to office, we interact with our colleagues, right? We meet each other, or we just keep throwing the ball from one score to the other, right? Saying that that person has done it, that's why this error has happened. Nobody told me that this patient is having this, and so on and so forth. We hear all that, right? And there are so many protocols that each one of our healthcare institutions have come out with to say, see the patient band, identify the patient, talk to the patient, and so on and so forth. But having said that, right, we never see why our people are doing all this, right? And when we look into this, then we say there is an urgent need, first for us in India and across the globe, to actually address this. So what do we do, right? So let's understand what really causes the stress, why these statistics are such mind-boggling. So there are 4 primary factors that we have identified, or the reports have identified, which actually create, stress for the healthcare workforce. First is the long working hours, right? This is very, very evident in most of our healthcare systems, right? I'll take a simple example of a nurse, right? How many of our hospitals really have a workforce planning system? And I do not mean any software. I'm talking of even if we are doing it on the paper, how many of us really have a scheduling methodology wherein we see who has worked for how many hours, who is having a proper balance or not balance, and schedule accordingly. We start with the first shift. We say that for the second shift, say 10% of the nurses have not turned up. So you request some 50 nurses, 30 nurses, whoever that you require, to continue for the second shift. At the end of the second shift, you see that, no, I still don't have 20 nurses. They say continue at the night shift, right? Very rarely you continue after the night shift, but there are several instances that I know. After night shift, can you do the first shift and go, right? The secondly, if you are not able to substitute, then you increase the nurse-patient ratio. So you ask one nurse to take care of more patients, right? Because not always you will get a substitute, right? Or they are not in a reachable format, etc. So if I have to just take this happens with our doctors. I have seen most of our junior doctors work, 12 hours, 14 hours, 24 hours, even 36 hours. In most of our hospitals, I've seen them. They come, they are there for 36 hours and go. What this actually leads to is a huge stress factor because of this, leading to actually a chronic fatigue, right? And this fatigue, one doesn't realize, but this fatigue has an impact on their health, on their mental well-being, and therefore the way they interpret the patient communication, the investigations, and therefore what they suggest. All are impacted, and very late that they realize that this is happening with them. The individual himself or herself do not realize that this is happening with them, right? So therefore, it's very important, and I've seen some of the Western countries, particularly US, etc., where the scheduling, the workforce scheduling to ensure that the tiredness because of the long hours is taken care of. They have the required softwares or the processes and systems in place to address this. The second thing is the workplace violence and abuse, the behaviors. I mean, to put it in a simple way, I mean, in the first thing you can see, the instance is as high as 45%, but you see this, the workplace abuse or the behavioral issues, as reported by FICCI Healthcare Report in 2024, says that 72% of nurses experience workforce violence, leading to an increased turnover rate, right? Now, violence does not mean physically hitting. What it means is how, right, the co-workers, the doctors, right, the administrators, the patients, right, everybody behaves with them. And this is a problem that many of us know. How many of us at our own hospitals and at our own institutions take out time to actually define the methods of communication, train our people on methods of communication, respect, dignity, and so on and so forth, so that workplace becomes a happy place where most of our people would get up out of their bed and say, hey, it's fun to go to work today, right? And this could be like, we can do multiple interventions, like have a friend at work, have your own HR teams, have your own managers, interact with them, spend time with them, give them the time and freedom to actually open up and share their problems with the managers, with the HR, and then these people taking the initiatives to solve the problems. If they just hear and keep quiet, people will stop sharing. Instead, if they do interventions and they start solving, that's when you will see that. And 72% is not a small number. The third factor that creates stress is the emotional burden and compassion fatigue, right? And this happens because most of them, right, are dealing with life and death all the time, right? Our people working in OTs, emergency, ICU, right, oncology centers, and so on and so forth. These are very, very prime areas where even in all our hospitals we see that these people complain of fatigue. And if you actually go back to the attrition data and see which departments have higher attrition, you'll see that oncology has a very high attrition because they see death very closely most of the time, right? Emergencies has, ICUs have, right? That's what we have seen. So therefore, what do we do as an organization to take care of people working in these departments and give them the comfort, right? And of course, the last one is the lack of mental health resources in our own setups where this support can be provided. And only 35% of the hospitals provide a mental health support, either in terms of colleagues or in terms of psychologists or for that matter anything else. And therefore, right, they don't have help. They can't go and discuss this at home. Most of them don't. They either discuss with friends or they're just internalizing it, adding that to their stress more and more till they actually one day actually come on burst out, right? So if this is what is happening, right, it's extremely important for us to now solve this problem, right? So there are multiple ways in which we can solve these problems. I've highlighted it under 4 sections, but I'll also tell you in each one of these sections what can we do to make this better. But this is not prescriptive. This is just to initiate a thought or idea in your mind. Each one of you can pick it up and figure out what is it that you'd want to do, which is relevant in your organization, in your setup, to make this happen, right? First is the workplace mental health programs. When I say programs, right, usually we think that we have to take it from somewhere and do this. But basically, this is very, very specific to your organization. A Harvard study found that the mental health programs reduce stress by about 45%. So if you have any initiatives in your organization, they really help. So I just told you about a friend at work. I told you about managers and HR. But just look at your systems and processes which cause these. Many a times what we find in our hospitals is that systems and processes are created to solve a particular problem that has happened at that point of time. Nobody has seen these systems end to end to see how do we cut down the unnecessary steps and make it straightforward and simple. Second thing is empowerment. How many of us really empower our our healthcare talent to take decisions which are appropriate for the patient, for their work, etc. For everything, if people have to refer back, if people have to check, if people have to really find out, can I do this or not do this, is an issue, right? It can be starting right from, medication, infection, how are you dealing with those things? What happens if there is an error? Or how do you ensure that that doesn't repeat? Today, many of us say, hey, there is an error, you have done it. So we start thinking of a punishment towards it. Right? However, if we were to just look at what has led to this error, it's not that somebody has intentionally done it. How do we improve our systems and processes to prevent this error and therefore facilitate our people to do better? If this approach comes in, it makes a huge difference. So it has a lot to do with the organizational culture, the workforce culture, interpersonal interactions, and how, we make our place a better place to work. The second thing is in terms of flexible scheduling, rest breaks, etc. We see that we all think several times before we give a leave to our people, right? As it is, our nursing teams, our junior doctors, etc., they don't take many leaves. But when they ask also, oh my God, my occupancy is very high, I can't give you leave right now. Why don't you go later? Right? Or some specific festivals when they want to go, we say no. But what we don't realize is they are humans. They also require those, periodic breaks to rejuvenate, refresh, and come back. Right? Leave is just one example. The frequency of shifts, how frequently you change the shifts. Right? The more frequently you are changing, the more frequently you are changing their cycles, their sleep cycles, their work cycles, etc., etc. Right? So, right from leaves to the breaks at office. How many of us have a break room in office? Right? How many of us have employee engagement initiatives going on very regularly? Right? Some fun at work, some picnics. In many years ago, I remember most of the corporates used to have that policy. At Apollo, at least in some of our locations, we have this policy on the picnic, and we give a picnic allowance. Company pays for it, so you take your picnic allowance, go out as a team. It not only breaks the stress, but also builds the teams, etc., etc. Right? So just a few such examples of, how can you make your work hours flexible? How can you ensure that they get periodic rest? And they can come out of what is piling up in them. And what they have seen is a flexible policy. This is an NHS study done in 2023. Says that if you give a flexi working, it reduces the burnout by 30%. And flexi working is also a concept of break shift. This is very commonly used in Western world. We don't use a break shift as a concept. As hospitals, depending upon which location and what specialties we run, there are always peak loads and low loads during a day. If we were to track it and think of, say, your front office people coming for a 4-hour shift in the morning, afternoons are easy, so therefore you give some of them a break in the afternoon, and then they can come back in the evening, say by 4 o'clock, and they work with you till 8 o'clock. What happens because of this is, not only you are giving them break from work, but you are also facilitating them to go home, take care of their family needs, and then come back. What we have seen is it not only helps you in stress, but also it helps in terms of reducing the attrition, bringing in more bond, etc. Right? So some of these things in terms of the shifts. The leadership policy and interventions. The leadership connect. Many of them do not even know what's happening in their organization. Right? What's changing? They keep hearing a lot of information from sources which are unreliable. And when they hear things which are not pleasant, when they hear things which actually, makes them think whether they are safe and secure on their roles, their jobs, etc. If they hear about something which is not really positive for their organization, it starts causing stress unknowingly, and that starts building up. Oh, am I safe? Should I look for a job? Oh, is my company not doing well? Will I get my salary at the end of the month? And so on and so forth. And most often than not, what you see is that this is all incorrect information. Somebody has started some rumor there and all, and therefore it spreads, and then it causes stress in the organization, and therefore to its people. So therefore, clearly communicating the leadership, policies, strategies, keeping every member informed about how we are doing, what we are doing, and what's in it for them is going to make a long way in terms of reducing the stress. And then, of course, the assistance from technology and AI solutions. All of us know that a lot of our healthcare workers, a lot of our healthcare professionals do non-value adding work, right? In case of our nursing, we always hear about a lot of notes that they write, indents that they do, and so on and so forth. But if you take any role and if you actually track what do they do for 8 hours, what is their core job, how much of the time out of those 8 hours are they doing their core job, and how much of the time they are doing what could be avoided by them. And if all that can be automated, right, by bringing in the appropriate technology, that significantly reduces the stress. Because worldwide studies say that almost 40% of the time, our healthcare workforce does things which they can avoid and need not be done, right? So these are the four key areas that I saw. And as I said again, there's a report from Deloitte which says so. But having said that, you can customize and make this much more. So what next, right? So for every organization, I'd like to suggest 4 things that will help you to create a action plan to address mental health needs of your employees in your respective hospitals. One is strengthen your organizational commitment towards mental health issues. As an organization, decide and make policy to say we will address the mental health requirements of every employee working in our hospital. Second, create a safe and supportive work environment, right? But very often we make it as a part of the culture, or we call as a culture. Safe and supportive. Safe is given. That's something that is non-compromisable. Supportive environment where everybody works as a team member, where everybody supports for the common cause. I know all organizations have politics, but how do you minimize it so that everybody feels felt, everybody feels welcomed, everybody feels that yes, this is my place that we should go. At Apollo, we call it as an Apollo family, right? Where do we do that? We spend 8 hours, which is 1/3 of our everyday's life at work. If we don't feel welcomed, if we don't feel safe, and if we don't feel happy there, then obviously it leads to stress apart from the productivity issues, etc., etc. Invest in mental health trainings and resources. I think we should come out of this era where this is seen as something which is stigma. I mean, people who are of different kinds, people are all of different emotional requirements, and they can handle stress in a different way. Not everybody can handle it in a way that some of us can really do. So if we are able to help and support them by training them and giving them the required handholding and guidance, you'll really see that it significantly improves the mental health of an organization. And lastly, the regular assessment and improvement programs, so that this doesn't happen. And assessment does not mean a mental health assessment of every employee. It means assessing your organization preparedness in your organization, how it is contributing to less stress and less mental health issues will make it. So it's an assessment of the organization and the culture rather than anything else. So at the end of it, a well-supported healthcare team will keep your work environment safe. Thank you.
Thank you, Kiran sir. Amazingly, very well showcased across. And I feel that this is what we have seen at Apollo. All these were implemented, and we have. That's the reason why Apollo has the lowest attrition rate. And we are we are proud to say that yes, we are creating this kind of environment where we take care of our teams, take care of their mental well-being. And I, as an administrator, have learned a lot of things from this last 10 minutes. And I'm definitely going back and implementing across. While we talk about behavior, we talked about mental health, but still we see a lot of physical violence happening across healthcare, especially in hospitals, when there is especially with the frontliners, whether it is nursing, front office staff, managers on duty, when they handle tough situation, unpleasant scenarios, which leads to these kind of conflicts. How can we minimize it? How can we make sure that it is not there? We all know that humans, of course, especially in India, we all are high on EQs. So emotional outbursts are very common, whether it is with patients or the families, and of course, at the staff level as well. So we will have Mr. Vishweshwara, who's going to take us through what are the best practices they follow, what they do, and how we can prevent these unpleasant scenarios at our workplace. Vishweshwara.
Thank you, Harikaran. And I would like to thank Kiranji also. Most of my content, my statistics already, sir has briefed in detail. So I don't take much time. So I have first thing I would like to thank for giving me this opportunity to talk about a very critical topic, which is very important, like to prevent the workplace violence in our healthcare industry. Yeah. So today I'll be discussing about the workplace violence, and I will be introducing you to the what are the types of workplace violence and what will be the objectives, how to overcome that, what are the things which we are following in Apollo hospitals across our group, and how to overcome that, and what are the stats says about the workplace and how is it impacting about on the patient care. So the objectives of today's topic will be, I'll be creating an awareness on about the issue, present key data and the real life examples, and outline comprehensive prevention and response strategies. As the definition says that any act, threat of physical harassment, intimidation or disruptive behavior occurring in the workplace. And there are different types of workplace violence. It is physical, verbal, psychological, or sexual, or invisibility. Like I will take it further. Before going into the types of workplace violence, already our Kiranji has mentioned that 38% or 8 to 38% of the healthcare workers face physical violence during their work. And the national statistics is recently one of the study which is conducted, it is 70% of the doctors in India have experienced some form of abuse. It is 1 in 3 women and 1 in 5. It is very serious thing which we have to work upon. And the examples, a nurse being physically assaulted by the patient's relative. Nurse spends half of his life in day-to-day activity of treating the patients. But end of the day, if there is something delayed, like the way the patient attendee or the patient relative reacts, that is in terms of a physical abuse or a verbal abuse, or as a verbal abuse, the emergency department staff facing outbursts from the attenders, or psychologically violence like harassment and bullying that create a hostile work environment, and sexual harassment, few of them are unwanted advances and inappropriate remarks, and workplace incivility is disrespectful behavior and dismissive communication. What you would do if a patient relative becomes really aggressive as a healthcare worker? We as a nurse or a doctor or administrator, what do we do? Be calm and quiet. Interesting, okay. What else we do? Seek for help. Exactly, all of you are right. Let us see what we will do. See, before going into the today's core topic, few of the case studies. Every day in our day-to-day situations, we will be facing, we will be hearing it, or we will have overcome this, or we have seen in our day-to-day activity. One of the few case studies, like a nurse in Delhi, you all might have heard, assaulted when treatment delayed caused frustration among the patient family. And another case study says, an emergency department doctor faced repeated verbal abuse from a distressed relative affecting overall team morale. And some of the situations, like, once the treatment is going on, they doesn't speak anything. Once we will give the bill, then we'll get to know that what kind of things we all will be listening as an administrator or from the front office team or a billing team. What are the causes and the risk factors of workplace violence? It's a high stress work environment. Like whatever the work we do, these kind of workplace violence will result for a high stress. And some of the times, the staff shortages, as already Kiranji has said, and I will be listening few things from Bobby Ramesh ma'am also, like staff shortages also sometimes leads to this workplace violence. Once they are being burdened on their day-to-day activity, once they couldn't able to communicate appropriate communication, so that time also this will lead to the workplace violence. And overcrowding and long waiting times. For few of the scenarios, like in few of the situations, especially in the OPD waiting time, for one of the well-known consultant who has the patient has come at morning 9 o'clock and the appointment has not got, and we made them to wait till 2 hours or 3 hours without giving a proper communication to them has results sometimes to the physical abuse or the verbal abuses. Sometimes the other factors are patient mental health issues and the substance abuse are few of the factors. As I mentioned, communication gaps, like ineffective communication between healthcare workers, patients and the family members can escalate tensions, which results to this workplace violence. Whenever a patient is sick, intermittent counselings and daily updates about the condition of the patient, or whenever there is a change in the condition of the patient, if you are not able to communicate to them in an appropriate way to the right team or right patient attendees, this will leads to this workplace abuse. And inadequate training. Some of the times the attendees or patients will be aggressive, but if we are not able to tackle them in a right way, definitely it will lead to in one of the form of an abuse. And not only the communication and the training, the environmental factors also will lead to this workplace violence. You may ask how it is possible. Like you don't have a counseling area for appropriate counselings and kind of audio video counseling rooms in ICUs, or you don't have adequate seating facility, or you have a seating facility but the amenities are not available. This also will result for the workplace violence. And the impact of the healthcare workers on the physical and psychological condition, already Kiranji has explained in detail about it. Some of the examples which I would like to say that it is not only about the patient, not about the workers, but also on the patient care also it will be affected. Once we are not fit to work and once we are not happy at the workplace, it definitely results in the care which we render to the patients. And these are the preventive strategies to overcome this workplace violence. First is the legal regulations, which is very, very important, and it should be its mandate. And some of the, the training and the policies also plays a major role. And the environmental and technological enhancements will reduce these workplace violences. I'll go in detail about this. The policies and the policies and the frameworks. See, most of our hospitals, not only the Apollo and the other hospitals wherever we go for conduct some random audits, we see that there are fantastic policies which are not even turned once or twice, which will be limited only to the quality team or to the key members of the hospital, not to the ground level. So these policies and the policies and the SOPs needs to be designed, and it should be adopted in all the levels, starts from the top management. So then only this will help us to reduce the workplace violences, and it should be a zero tolerance policy. No means no, irrespective of whatever situation it is, whether it is a VVIP or VIP, or whether it is irrespective of area which they are from, it has to be a zero tolerance policy. And next is the training. First thing is, we all know that we all have a fantastic policies. The training needs to be, first we have to prepare the policy, and then we have to train them, and then on how to go further, we have to inculcate the culture in the hospital. So then we have to make sure that whatever has been implemented, it has to be adopted. And enhancing the security measures. The physical security measures like installation of the security cameras across the areas, especially the high-risk areas, the panic buttons, or the controlled access points at the all critical care areas will reduce it. And some of the technical solutions like real-time monitoring of our patient condition and updates to the key workers, whether it can be a doctor. There are so many ECCs are there now, like DOSI or Life Science and all, so that gives you the real-time update to the consultant as well as the healthcare workers. And the screening procedures during the and the policies like visitors policy, and whenever you are allowing any of those people into the system, like the screening is very, very important, and what they are carrying, especially into the ICU areas or ICU zones. Before we allow them into the areas, we have to be monitored strictly. And the crisis management components, like whenever whenever there is an emergency response plan, we have to call for help. Like in most of the hospitals, there are different color codes or emergency responses like code gray or code purple. So, and then we have to support them whenever safeguard our team members, and we have to report the incident properly, and we have to do the analysis, and then we have to give the emotional supports as well. Creating a culture of safety is very important. It's from the leadership role point of view, or from in terms of peer support, or with the communication. And what is an action plan? We have to define a short-term and long-term goals for of safety initiatives, develop a training schedule, and we have to keep some matrix of whatever the trainings which have been required for the which are conducted, and then we can how to monitor them will reduce this. And this is the to conclude it, zero tolerance policies needs to be made available. This will reduce 35% of the unacceptable behavior. And regular de-escalation trainings boost staff confidence and helping reduce conflicts around 25%. Anonymous reporting system improves incident documentation by 50%. Enhanced security measures will reduce 40% of the workplace violences. And these are some of the examples from success institutions like Johns Hopkins and VA hospitals. So that's about it. Thank you.
Thank you, Vishweshwara. Very nicely put across. Yes, it is important to take care of our staff. And end of the day, what he mentioned in these slides is basically the communication. All these situations are preventable if we communicate properly. If we empower our staff, we train them. Now, to understand how we can empower our staff, how can we train them better, we have Ms. Bobby Ramesh to take this stage forward and then help us, guide us in terms of what are the measures that we are going to implement to make sure that it is going to reap good results for us. Ma'am, over to you.
Respected Chairperson, Mr. Harkaran, distinguished co-panelists, Mr. Kiran, Mr. Vishweshwar, and Dr. Anuradha Pichumani, dear delegates and my dear friends. I'm here to discuss on the importance of empowering healthcare teams for exceptional patient service. Mr. Kiran, who was the previous speaker, has made my life easier by touching upon few of the points. As healthcare providers, we are committed to providing the best possible care to the patients. Am I right? Yes. However, exceptional care would be possible only with teamwork, collaboration, innovation, and above all, empowerment, which is a very, very important factor. Empowered healthcare teams are the backbone of high-quality patient services. In today's world, where there's so much of competition between hospitals, if you have to stand out in the competition, you have to provide exceptional high-quality patient services, for which empowerment is very, very important. Empowerment means giving your team the autonomy, the resources required, and the support they need to make decisions, take ownership. It is not only allowing them to do it freely, but also making them accountable, making them take the ownership, and helping the team provide exceptional care. Fostering collaboration by means of various huddles, leveraging technology, and promoting continuous learning. We can enhance patient outcomes, improve operational efficiencies, and create a compassionate environment for our patients. Did you all know that studies have proved medical errors can be reduced by 30% if your teams are empowered? If your teams are empowered, they can collaborate effectively, they can communicate effectively, and reduce the number of errors. By reducing number of errors, the patient satisfaction can be improved by 25%. Why it matters, as I had already mentioned, it improves patient satisfaction, it improves team coordination, and team can have better communication. Empowered teams communicate better, and because of which there is greater efficiency in the service delivery, which gives an improved job satisfaction for the healthcare team members. Today, the healthcare providers are faced with various challenges related to staff shortages, which Mr. Kiran had already mentioned, and burnout because of the staff shortage, which affects the quality of care, navigating regulatory and complaints requirements, increasing patient demands and expectation. Gone are the days when patients were coming to the hospitals only for treatment purpose. Now patients want quality care, personalized care. Their cultural preferences need to be addressed too. So these all are the challenges faced by the healthcare providers today. And also giving quality care which is affordable, which doesn't cost much, and adapting to new technologies and digital transformation in your hospital would be also challenging. How to empower healthcare teams in today's scenario for exceptional patient services? With all these challenges, we need to overcome these challenges. As I'd already mentioned, first of all, we need to provide adequate resources. You need to have adequate staff in your hospital. Let us talk about the acronym EMPOWER to enhance healthcare teams for exceptional patient care. Educate your team. If team have to feel empowered, they need to update themselves. They need to undergo various trainings and ongoing trainings. You need to engage your team members in various committees, in various meetings, in various activities. The teams have to be involved. Team cannot be there only for the work what the leaders or the HODs tell them to do. Team also need to participate in various committees. Many of the hospitals, it is only the HOD who attend various committee meetings. In the hospitals, wherever I have worked, I groom my team members, and each team member in the admin team attend various committee meetings. And many of them are successful nurse leaders today because they knew how the committee functions, how they can contribute in the decision making, in telling their opinions. Motivate and mobilize your team for enhancing knowledge and skills, cross-training, cross-deployment, so that everybody's skills can be utilized. Provide them autonomy and ownership for open communication. Hear them out. Let them talk to you without any fear. Let them come out with their points and ideas. Offer them adequate support. When they come out with their points, gone are the days when seniors only can, tell or teach. Even youngsters can be mentors. Reverse mentorship also is a thing which is catching up in this world where the technologies are rapidly moving ahead. The younger generation are more tech savvy. They can be mentors and preceptors for the senior team members. So welcome their feedback, learning from them, and inclusivity. Be more inclusive of your team members. Encourage collaboration between various departmental team members. Teamwork. Teamwork is very essential. In previous speakers have spoken about even the huddle meetings with multidisciplinary team members. If you have huddle meetings, you can discuss on various concerns, various points related to patient safety and patient satisfaction, and you can promptly address the patient's problem, and the patient-centered care can be better. Respect, above all, respect your team members. Recognize them for their achievements. Don't be so punitive. But when they do a good thing, be it a junior staff or a senior one, everyone likes to be appreciated and recognized. So have forums where you can recognize them and reward them for their achievements. As I already mentioned, for building a patient-centered care, you need to have good teamwork and empowered team so that the communication and the empathy quotients will enhance patient trust, patient satisfaction, and the outcomes can be improved upon. And this culture requires leadership commitment, staff engagement as well. And various technological advancements also leads to better improvement. I said as the resources we need to provide, all these telemedicine, remote monitoring system, various automated system to reduce administrative burdens, these all will, and AI and machine learning, EMRs, wearable health tech for real-time patient tracking. These all will definitely empower our healthcare team members to take care of our patients more confidently and more effectively. How to sustain? For sustaining the empowerment, we need to invest in staff development and engagement. We need to invest in continuous training, because continuous training will make them more confident. More confident team are better empowered team. Leadership support. I remember an incident which I'd like to share with you. This was an incident in Apollo itself when I was a director nursing. I told my infection control nurse, you are empowered to stop anyone who's not washing their hand when you are on rounds, whether it is a nurse or a doctor or anybody, for doing any procedure. If you see them or touching the patient, you are empowered to stop them. So my ICN went and stopped. A doctor was not wearing a gloves. He was trying to open a dressing, and then this ICN said, sir, you are not authorized, or sir, you cannot touch the patient without without doing your hand hygiene. So the doctor said, you cannot check me like that. And then the ICN went and reported this matter to the medical director. The medical director supported the ICN and called the doctor, summoned him to his office and made him say sorry to the ICN. And then the ICN felt more empowered and more, happy and satisfied to carry out his daily. That is how the leaders had supported. One more example I'd like to say. I'd been to the hospital for a health check. And I was not working in Apollo at that time. This is about Apollo again. I do not know whether I can quote it, but then I'd like to quote this. So I went for a health check some time back, and then the OPD nurse said, ma'am, you are our ex-director nursing, so I'll get you some rebate, so please come and talk to our operations manager. So I went to the operations manager after my blood test, and then immediately the operation manager said, ma'am, what discount? You are our ex-director nursing and I'm waiving off your charges. I felt so happy. I thought next time I'd definitely like to come to Apollo only for a health check, or even if I get an opportunity to work again in Apollo, it would be great, because that operation manager was empowered. She didn't have to ask permission from her. It may not be only for me. I'm telling, I had gone there as a patient. It may be for others as well. So be it a nurse or an operations executive or a dietitian or a chef, they should be empowered to take their decisions, to give that extra satisfaction to the patient, so that they look forward to come to the hospital again. If every time they have to take permission from their HOD. One more example I'd like to quote here. In Chennai, I had to stay in a leading hotel for more than a month because of crisis in one of my hospital. At that time, one day I didn't have my dinner. So the chef noted that, and he said, ma'am, why are you not having the dinner? I said, I'm staying here for more than a month and I've finished with all the menu. So I'd not like to have the same food again. So I'm going back to my room. No, ma'am. What you want, you tell us. Even if it is not there in the menu, we would like to offer it to you. Same thing in the hospital also. If a patient says, this food I don't need, I didn't like this food, preferring his choices, whatever is within the limits of the treatment, the chef or the dietitian should be able to provide an alternative without having to take permission from the higher authorities. That definitely gives the edge over other hospitals, and the patient will definitely like your services better. So various strategies, you need to have ongoing trainings for staff development. You need to have good mentorship for empowering your team. Wellness and mental health support, Mr. Kiran was mentioning, that is the most important to avoid burnout of the patients. I presently work in Sarvodaya Healthcare, and I always say that there is no burnout. If anybody says, I say, there's no point of burnout there, because the HR team, every month there are activities for the staff, every month there are activities, every half yearly there are picnics and outings. And next week too, all the nurses are going to be taken for picnic, the doctors with families, that everybody have these sort of activities happening in the hospital. So burnout is taken care of. So many hospitals, many reputed hospitals have such things in place so that the wellness aspect is taken care of. They feel better empowered, they can deliver better services. And you need to encourage a culture of feedback from your team members. So in conclusion, I'd like to conclude by saying that empowering healthcare team is very crucial and it is a cornerstone of delivering exceptional patient services. So for excellence in patient care, as I'd already mentioned, commitment, innovation, teamwork, and above all, empowerment is very much required. By investing in your staff development, leveraging technology, fostering collaboration, and prioritizing patient-centered care, we can achieve sustainable excellence through empowerment. So let us all come together as healthcare leaders, empower our team better, and strive for excellence in healthcare services. Empowerment is not about giving all the answers, it's about giving them tools to find their own way to success. Thank you so much.
Thank you so much, ma'am. Of course, this is right. Yes, the more empowerment, the more people you empower on ground, you will definitely produce good leaders. You'll produce brand ambassadors, and end of the day, the people who are serving on ground, those are your brand ambassadors, and not the ones whom you hire for your marketing campaigns. So great thought from the nursing director from Sarvodaya. Great, and would like to take this forward now. I empower all of you right now to please ask questions from our learned, esteemed speakers here, and the forum is open for all of you, but with the shortage of time, we'll keep it one question per speaker. So over to you. I empower all of you. Go ahead. Any questions from anyone?
Kiran sir, I have seen one of your slides, it mentioned 63%.
Correct.
So it's all over India or it's only for the AIMS group?
It's all over India.
Okay.
The study done by AIMS for the Indian healthcare.
And how they collected data, sir?
How they collected data? Oh, they got in touch with the respective hospitals. They asked who are the participating hospitals. Some have participated, some have not. Most of the government hospitals did participate, and some of the national institutions participated.
No private hospitals?
There are a few private hospitals who participated. So it's a quite well done study.
In the north region or in the south region?
Both, all, east, west, all the four.
Thanks.
Okay. Any more questions? See, this is the opportunity for you to learn, to ask questions, to clear your doubts. Yes, ma'am.
So it's to you, sir. Actually, you just talked about the workplace violence. So just would like, as a healthcare worker, suppose if we are in emergency only, the scenario is like the patient is becoming little aggressive, very aggressive, because maybe of some might be maybe the patient is sick and there is some he's finding out there is some long way communication, something is happening. In that case, as a healthcare worker from the reputed organization, I am being taught that I need to be calm and we need to calm down the patient also. But in that case also, like if they become physically aggressive or something, we all have this code violate, we announce, everything is there. But that mental hurt which the person feels, what can be done for that in prior hand? Because the done thing, the action is being taken after that. Prior hand, what the things can be done? Means, is there some policy should be recreated or something should be there for that beforehand?
If you see for us in Apollo, what we do is each and every code gray alert has been raised as an incident. And if those incidents are analyzed in all the ways, and whoever has been affected, whether it is a physical or a psychological or verbal, these people will be put forward for the psychological counselors. They will be emotionally and psychologically will be monitored for next 3 months of time. So it has been monitored very closely. And just one example I want to quote it. One of the patient attendee who has come to our OT, operation theater, and he has literally he has come into the OT and asking for one of the doctors want to interact with the doctor, and he said that I am the husband to the doctor. And then the security also has taken the details and he has allowed to walk into the OT. There, the receptionist who was sitting there, he said that there is nobody as such, because when she has asked for few more doubts. Then she has found out he is not a right person, and then he has called immediately the security. Then he started, beating her, manhandled her there, then and there, when she said that no, he was so aggressive. She has literally has been, has faced that psychological impact for 6 months. There are almost 5 to 6 sessions has been taken up by the counselor to that staff, monitored, and not only that, and we have empowered our security to take any of these things needs to be routed to the security office only for people if they want to meet through during the working hours. So these counselings help them psychologically, not only during that particular point of time, and it will motivate other employees also, like to whenever they face such situations, to overcome that. And furthermore, and this especially these particular incidents, we go to a next extent saying that we will literally lodge a complaint against that person. So from the management point of view, so these are the things which we follow at Apollo Hospitals, Mysore.
I just want to add something to what Mr. Vishweshwaran has said. The JCI mandates something called a standard called the second victim policy. So the first victim over here is the patient. The second victim is the person who has gone through that particular issue. Now let me say you said a doctor or somebody in question who has, like, maybe done the right things, but she was slapped, or whatever, it was a panic situation and she's still going through that. All of them are not emotionally and psychologically built to handle certain pressures. So if she's going through that, she's not sleeping, panic attacks, and that is recognized by her HOD or a colleague at work, or even if she feels that I'm not okay, I need help, she needs to understand that the hospital where she is working has something called a second victim policy, and everybody is empowered to approach the HOD, and the HOD will also definitely know. As per the policy, within the first 24 hours of identification of this particular issue, she needs to meet a psychologist, not a psychiatrist. A psychologist who will assess her, find out what the issue is, and then, she may require, as he has rightly said, some counseling. But some of them will not be okay with counseling. So they may need to be referred to a psychiatrist. So in that case, they may give some anti-anxiety measures and all. In all of this, we are doing very good work. We are, doing whatever is as per protocol. But do not forget the family. The family has to be kept in touch, because we may not know that what that particular person who's going through this, what is the action that she's going to take when she goes home? What is she going to do? Cut herself, jump somewhere, commit suicide? What her level of panic at that point of time, although she goes through sessions, will not be known. So she needs to be told, the family needs to be aware. Plus, the management needs to give the reassurance that what can be done. Some resolve has to be there. Like you said, we will lodge a police complaint. If there is vandalism, they've broken everything and all, definitely a police complaint. So that is reassurance that you are in a safe environment. We talk about safety culture. So it starts at that ground level, that you're very safe in our organization. We will take care of you. You need to, whatever we need to build around that particular person, a hedge around that person, will go a great way in showing and role modeling what the organization stands for. I hope I've answered your question. Anything more? No, I think that's...
For example, we are having code blues. So before that, we are implementing Muse, so that the person should have the step-up transfer to before the announcement of any code blue or cardiac arrest. I'm asking, is there any strategy or rule out of any plan to handle, to just assess whether there is going to be some aggressive action from the patient side, to assess that prior, not after the action, before the incident, regarding any identification, can there be any strategy for that? That was my question, actually.
I think I will leave it to him to answer. I think there are definitely strategies.
We have unacceptable behavior, Okay, and we have like enhanced communication. There are separate policies and protocols. This will help us to reduce these things. At the first instant itself, if the patient is raising his voice, there itself we raise the alert. Not to the extent where he comes and aggressively, he gets into the, disaster situation. So this has prevents and it reduces these code gray alerts.
Great.
No, this is called, de-escalation techniques which we train our team members.
Okay, great. Thank you so much, everyone. Of course, this was one of the. I would say I've learned a lot in this session, and of course, the best way to end this session is on this topic of violence and how to handle this violence and how to have a preventive measure to handle this violence. Thank you, ma'am, for this question. So, would like to end this session, and I really want to thank the entire panelists, all the speakers here, for coming up across and especially taking out time for this very, I would say, very touching topic, which is healthcare workforce safety. I think this is a never-ending debate and never-ending topic. We need to, it's like practicing day in, day out. So we all have to work towards it. And I really want to thank all of you for your insights. And definitely we are going to go back and implement. More than that, I really want to thank the entire audience for this post-lunch session. And thank you for, I'm sure these presentations worked as caffeine for you. All of you were awake, and thank you so much for being very participative. And I really want to thank the organizers for helping us in putting up this show across. Thank you, everyone.
Thank you, Session Chair. Thank you, all the speakers, and thanks to all the audience. We request each one of you to please move towards the plenary hall. We have another lineup of sessions there. Thank you so much, sir. Yeah. So all the prizes, everything will be given at the plenary hall itself. So please move on to there. Thank you.